Quality of care. Appendix PP, Regulation Section 483.25, tags F684 through F700. Begin reading. Tag F684. Section 483.25, Quality of care, is a fundamental principle that applies to all treatment and care provided to facility residents. Based on the comprehensive assessment of a resident, the facility must ensure that residents receive treatment and care in accordance with professional standards of practice, the comprehensive person-centered care plan, and the resident's choices, including but not limited to the following. Intent: to ensure facilities identify and provide needed care and services that are resident-centered, in accordance with the resident's preferences, goals for care and professional standards of practice that will meet each resident's physical, mental, and psychosocial needs. Definitions: highest practicable physical, mental, and psychosocial well-being is defined as the highest possible level of functioning and well-being, limited by the individual's recognized pathology and normal aging process. Highest practicable is determined through the comprehensive resident assessment and by recognizing and competently and thoroughly addressing the physical, mental, or psychosocial needs of the individual. Hospice care means a comprehensive set of services described in Section 1861 DDL of the Act, identified and coordinated by an interdisciplinary group IGE, to provide for the physical, psychosocial, spiritual, and emotional needs of a terminally ill patient and or family members, as delineated in a specific patient plan of care. 42 CFR Section 418.3. Palliative care means patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care throughout the continuum of illness involves addressing physical, intellectual, emotional, social, and spiritual needs, and to facilitate patient autonomy, access to information, and choice. Section 418.3. Terminally ill means that the individual has a medical prognosis that his or her life expectancy is 6 months or less if the illness runs its normal course. Section 418.3. Guidance. Note: although federal requirements dictate the completion of RAI assessments according to certain time frames, standards of good clinical practice dictate that the clinical assessment process is more fluid and should be ongoing. The lack of ongoing clinical assessment and identification of changes in condition to meet the resident's needs between required RAI assessments should be addressed at Section 483.35 Nursing Services, F726 Competency and Skills to identify and address a change in condition, and the relevant outcome tag, such as Section 483.12 Abuse. Section 483.24 Quality of Life, Section 483.25 Quality of Care, and or Section 483.40 Behavioral Health. Use guidance at F684 for review of concerns which have caused or have a potential to cause a negative outcome to a resident's physical, mental, or psychosocial health or well-being that is not specifically addressed by any other tag at Section 483.25. Additionally, F684 contains guidance for end-of-life and hospice care. Nursing homes must place priority on identifying what each resident's highest practicable well-being is in each of the areas of physical, mental, and psychosocial health. Each resident's care plan must reflect person-centered care and include resident choices, preferences, goals, concerns/needs, and describe the services and care that is to be furnished to attain or maintain or improve the resident's highest practicable physical, mental, and psychosocial well-being. For concerns related to the resident's comprehensive care plan, see F656, Section 483.2 1B Comprehensive Care Plans. The following sections describe some, but not all of the care needs that are not otherwise covered in the remaining tags of Section 483.25, Quality of Care. I. Review of a resident with non-pressure-related skin ulcer/wound. Residents may develop various types of skin ulceration. At the time of the assessment and diagnosis of a skin ulcer/wound, the clinician is expected to document the clinical basis, e.g., underlying condition contributing to the ulceration, ulcer edges and wound bed, location, shape, condition of surrounding tissues which permit differentiating the ulcer type. Especially if the ulcer has characteristics consistent with a pressure ulcer, but is determined not to be one. This section differentiates some of the different types of skin ulcers/wounds that are not considered to be pressure ulcers. Note: guidance regarding pressure ulcers is found at 42 CFR 483.25, B1F, 686 Skin Integrity, Pressure Ulcers. Use this tag F684 for issues regarding non-pressure-related skin ulcers/wounds. Kennedy terminal ulcers are considered to be pressure ulcers that generally occur at the end of life. For concerns related to Kennedy terminal ulcers, refer to F686, Section 483.2, 5B Pressure Ulcers. Arterial ulcer. An arterial ulcer is ulceration that occurs as the result of arterial occlusive disease when non-pressure-related disruption or blockage of the arterial blood flow to an area causes tissue necrosis. Inadequate blood supply to the extremity may initially present as intermittent claudication. Arterial/ischemic ulcers may be present in individuals with moderate to severe peripheral vascular disease, generalized arteriosclerosis, inflammatory or autoimmune disorders such as arteritis, or significant vascular disease elsewhere, e.g., stroke or heart attack. The arterial ulcer is characteristically painful, usually occurs in the distal portion of the lower extremity, and may be over the ankle or bony areas of the foot, e.g., top of the foot or toe, outside edge of the foot. The wound bed is frequently dry and pale with minimal or no exudate. The affected foot may exhibit diminished or absent pedal pulse, coolness to touch, decreased pain when hanging down dependent or increased pain when elevated, blanching upon elevation, delayed capillary fill time, hair loss on top of the foot and toes, toenail thickening. Diabetic neuropathic ulcer. A diabetic neuropathic ulcer requires that the resident be diagnosed with diabetes mellitus and have peripheral neuropathy. The diabetic ulcer characteristically occurs on the foot, e.g., at midfoot, at the ball of the foot over the metatarsal heads, or on the top of toes with Charcot deformity, and venous or stasis ulcer. A venous ulcer, previously known as a stasis ulcer, is an open lesion of the skin and subcutaneous tissue of the lower leg, often occurring in the lower leg around the medial ankle. Venous ulcers are reported to be the most common vascular ulceration and may be difficult to heal, may occur off and on for several years, and may occur after relatively minor trauma. The ulcer may have a moist, granulating wound bed, may be superficial, and may have minimal to copious serous drainage unless the wound is infected. The resident may experience pain that may increase when the foot is in a dependent position, such as when a resident is seated with her or his feet on the floor. Recent literature implicates venous hypertension as a causative factor. Venous hypertension may be caused by one or a combination of factors including loss of or compromised valve function in the vein, partial or complete obstruction of the vein, e.g., deep vein thrombosis, obesity, malignancy, and slash or failure of the calf muscle to pump the blood, e.g., paralysis, decreased activity. Venous insufficiency may result in edema and induration, dilated superficial veins, dry scaly crusts, dark pigmented skin in the lower third of the leg, or dermatitis. The pigmentation may appear as darkening skin, tan or purple areas in light-skinned residents, and dark purple, black or dark brown in dark-skinned residents. Cellulitis may be present if the tissue is infected, Roman 2. Review of a resident at or approaching end of life and / or receiving hospice care and services. Assessment. The resident must receive a comprehensive assessment to provide direction for the development of the resident's care plan to address the choices and preferences of the resident who is nearing the end of life. In addition, in order to promote the physical, mental, and psychosocial well-being of a resident who is approaching the end of life, the facility and the resident's attending physician/practitioner should, to the extent possible, identify the resident's prognosis and the basis for that prognosis, and initiate discussions/considerations regarding advance care planning and resident choices to clarify goals and preferences regarding treatment, including pain management and symptom control, treatment of acute illness, and choices regarding hospitalization. Care plan. The care plan must be based upon the resident assessment, choices, and advance directives, if any. As the resident's status changes, the facility, attending practitioner, and the resident representative, to the extent possible, must review and / or revise care plan goals and treatment choices. Based upon the resident's assessment, the care plan may include, but is not limited to, addressing oral care. The care plan should include the provision of ongoing, consistent oral care, including interventions, as necessary to provide comfort and prevent complications associated with dry mucous membranes and compromised dentition. For concerns related to the provision of oral hygiene, refer to F676 or F677 activities of daily living. And for concerns related to dental care, refer to F790 and F791 dental services. Skin integrity. The care plan should include, for a resident who has skin integrity issues or a pressure injury or is at risk of developing a pressure injury, approaches in accordance with the resident's choices, including, to the extent possible, attempting to improve or stabilize the skin integrity / tissue breakdown, and to provide treatments if a pressure injury is present. For concerns related to pressure injuries, refer to F686. Medical treatment / diagnostic testing. The resident and his or her representative and the attending practitioner may, based on resident choices / directives, make decisions on whether to continue medications, treatments, and / or diagnostic tests. This must be included in the resident's record. For concerns related to choice, care planning decisions, and right to discontinue treatments, refer to F552 and F553. Symptom management. Symptom management may include controlling nausea, vomiting, uncomfortable breathing, agitation, and pain. Symptom management may include both pharmacological and non-pharmacological interventions consistent with the resident's choices and goals for comfort, dignity, and desired level of alertness. For concerns related to medications, refer to F758 psychotropic medications and F757 unnecessary medications. Nutrition and hydration. The resident may experience a decline in appetite or have difficulty eating or swallowing. Care plan interventions regarding nutrition / hydration must be based upon the resident's assessment, disease processes, and resident choices / directives, and include amount, type, texture, and frequency for food and fluids. Dietary restrictions and / or weight measurements may be revised / discontinued based upon resident / representative and attending practitioner decisions, and must be included in the medical record. If the resident's condition has declined to the point where he / she may no longer swallow food or fluids, the determination of whether to use artificial nutrition / hydration, based upon resident choices / directives, is made by the resident / representative and the attending practitioner, and consistent with applicable state law and regulation. For concerns related to nutrition, refer to F692, for concerns related to nutrition / hydration, and for concerns related to feeding tubes, refer to F693. And / or Activities/psychosocial needs. Care plan interventions for activities must be based on the resident's assessment and include the resident's choices, personal beliefs, interests, ethnic/cultural practices, and spiritual values, as appropriate. In addition, the resident's assessment may identify psychosocial needs, such as fear, loneliness, anxiety, or depression. Interventions to address the needs must be included in the plan of care. For concerns related to the provision of activities, refer to F679. For concerns regarding medically related social services, refer to F745. For concerns related to developing and implementing the care plan, refer to F656, Comprehensive Care Plans. And for revision of care plans, refer to F657, Comprehensive Care Plan Revision. Resident care policies. The facility, in collaboration with the medical director, must develop and implement resident care policies that are consistent with current professional standards of practice for not only pain management and symptom control, but for assessing residents' physical, intellectual, emotional, social, and spiritual needs as appropriate. In addition, if the facility has a written agreement with a Medicare-certified hospice, the policies must identify the ongoing collaboration and communication processes established by the nursing home and the hospice. Refer to F841 Section 483.7, 0G Medical Director, or for the written agreement, to F849, Section 483.7, 0N Hospice Services. Note, if the resident has elected or is revoking the Medicare hospice benefit, a significant change in status assessment, SCSA, must be conducted as noted in the Long-Term Care Facility Resident Assessment Instrument, User's Manual version 3.0 Chapter 2. If a resident was admitted on the hospice benefit, i.e. the resident is coming into the facility having already elected the hospice benefit, the facility completes the required MDS admission assessment. If a terminally ill resident elects the hospice benefit after admission, a SCSA must be performed regardless of whether an MDS assessment was recently conducted on the resident. This is to ensure a coordinated care plan between the hospice and nursing home is in place, and a SCSA is required to be performed when a resident is receiving hospice services and decides to discontinue those services' revocation of the hospice benefit. Refer to F637, Significant Change in Status Assessment. Hospice care and services provided by a Medicare-certified hospice. Hospice care and services are based upon a written agreement between the nursing home and the Medicare-certified hospice, hereafter referred to as hospice or hospice services. CF 849 Hospice Services. This section discusses the collaborative services provided by the nursing home and the hospice for a resident who is receiving hospice care and services. A nursing home resident at the end of life may choose to elect the Medicare hospice benefit, or may choose to continue to receive the care and services provided by the nursing home. The resident considering election of the hospice benefit must meet the hospice eligibility requirements. According to 42 CFR Section 418.20, in order to be eligible to elect hospice care under Medicare, an individual must be A. entitled to part of Medicare, and be certified as being terminally ill in accordance with Section 418.22. Note, hospice is also an optional state plan benefit in the Medicaid program. If a resident who receives Medicaid chooses to elect the hospice benefit, the physician must provide written certification that the individual is terminally ill. Refer to SSA Sec. 190501A, 42 U.S.C. 1396 D01A if the resident is eligible for both Medicare and Medicaid. He/she must elect the hospice benefit simultaneously under both programs. And if the resident chooses to revoke the hospice benefit, he/she must revoke the benefit simultaneously under both of the programs. There is no requirement that a nursing home offer hospice services. Although a resident may meet the eligibility requirements and may choose to elect the hospice benefit, The nursing home may or may not have an arrangement with a hospice to provide hospice care and services. If the nursing home has an agreement with a hospice, it must, consistent with F552, inform each resident before or at the time of admission, and periodically during the resident's stay, of hospice services available in the nursing home. If a nursing home allows one or more hospice providers to provide services, there must be a written agreement between each hospice and the nursing home that describes their responsibilities prior to the hospice initiating care for the resident. For the written agreement, refer to F849 hospice services. If the resident chooses to elect the hospice benefit, but has not chosen a hospice provider, and the nursing home does not have an agreement with a hospice provider. If the resident wishes, the nursing home must assist the resident with a transfer to another facility or appropriate setting where hospice services are provided. Or, the nursing home may choose to establish a written agreement with a hospice. Coordinated care plan. The nursing home retains primary responsibility for implementing those aspects of care that are not related to the duties of the hospice. It is the nursing home's responsibility to continue to furnish 24-hour room and board care, meeting the resident's personal care and nursing needs. The facility's services must be consistent with the care plan developed in coordination with the hospice, and the facility must offer the same services to its residents who have elected the hospice benefit as it furnishes to its residents who have not elected the hospice benefit. Therefore, the nursing home resident should not experience any lack of services or personal care because of his or her status as a hospice patient. This includes what would normally be provided to a resident in the nursing home, including but not limited to the following: conducting the comprehensive assessments, which includes the Resident Assessment Instrument (RI), providing personal care, activities, medication administration, required physician visits, monthly medication regimen review. Support for activities of daily living, social services as appropriate, nutritional support and services, and monitoring the condition of the resident. The facility is required to develop and update the care plan in accordance with federal, state, or local laws governing the facility. The hospice retains primary responsibility for the provision of hospice care and services based upon the resident's assessments, including but not limited to the following: providing medical direction and management of the resident, nursing, including assigning a hospice aide as needed to support the resident's ongoing care, counseling including spiritual, dietary, and bereavement, social work, providing medical supplies, durable medical equipment, and drugs necessary for the palliation of pain and symptoms associated with the terminal illness and related conditions, and all other hospice services that are necessary for the care of the resident's terminal illness and related conditions. See 42 CFR, Section 418.112C6. Note, if there is an issue related to the provision of care by the hospice, the survey team may request the written agreement and review to see the steps the nursing home has taken to resolve the resident care issues. The written agreement should include how differences are resolved between the nursing home and the hospice, and the nursing home and hospice liaisons may need to be interviewed regarding the identified concerns. If there are concerns related to the provision of care based upon the failure of the implementation of the written agreement or the lack of a written agreement, refer to F849. The resident/representative must be included in the development of the care plan, which must reflect the resident's choices to the extent possible. In order to address communication regarding the resident's care between the nursing home and the hospice, the nursing home must designate a staff person to participate in the ongoing communication and include the resident representative in decision-making. The nursing home should provide the name of the designated staff member or designee to the resident/representative for ongoing communication regarding care or concerns. Refer to F849, designated member of interdisciplinary group IGE. In order to provide continuity of care, the hospice, nursing home, and resident/representative must collaborate in the development of a coordinated care plan which includes, but is not limited to, the following. Resident/representative choices regarding care, the hospice philosophy of care, and all services necessary for the palliation and management of the terminal illness and related conditions, measurable goals and interventions based on comprehensive and ongoing assessments, interventions that address, as appropriate, the identification of timely, pertinent, non-pharmacologic and pharmacological interventions to manage pain and other symptoms of discomfort. The hospice portion that governs the actions of the hospice and describes the services that are needed to care for the resident. Identification of the services the nursing home will continue to provide. And the identification of the provider responsible for performing specific services/functions that have been agreed upon. The structure of the care plan is established by the nursing home and the hospice. The care plan may be divided into two portions, one maintained by the nursing home and the other maintained by the hospice. The nursing home and the hospice must be aware of the location and content of the coordinated care plan, which includes the nursing home portion and the hospice portion, and the plan must be current and internally consistent in order to assure that the needs of the resident for both hospice care and nursing home care are met at all times. Any changes to the Plan S must be discussed and approved by the nursing home, hospice staff, and, to the extent possible, the resident and/or representative. As the condition of the resident declines, the hospice and nursing home must continue a joint collaborative effort, which includes ongoing communication with and input from the resident/representative, to assure that the care provided addresses concerns as identified in the ongoing assessments. Physician services. When a hospice patient is a resident of a nursing home, that resident's hospice care plan must be established and maintained in consultation with the resident's attending physician/practitioner, representatives of the nursing home, and the resident/representative, to the extent possible. See F710, Physician Supervision of Care in a Nursing Home. A physician's assistant may not act as the hospice attending physician. However, the resident's attending physician at the nursing home may delegate tasks to a physician's assistant. See F714, Physician Delegation of Tasks. Note, for informational purposes, the definition of an attending physician as identified in the hospice federal regulations is provided below. This clarifies that a doctor of medicine, osteopathy, or nurse practitioner, if meeting the listed requirements, may function as the attending physician in a hospice. The hospice regulations do not provide for a physician assistant to function in this category. Section 418.3 Definitions. For the purposes of this part, attending physician means a one-eye doctor of medicine or osteopathy legally authorized to practice medicine and surgery by the state in which he or she performs that function or action. Or Roman II nurse practitioner who meets the training, education, and experience requirements as described in Section 410.75b of this chapter. 2 is identified by the individual, at the time he or she elects to receive hospice care, as having the most significant role in the determination and delivery of the individual's medical care. Communication. Nursing home staff must immediately contact and communicate with the hospice staff regarding any significant changes in the resident's status, clinical complications, or emergent situations. These situations may include, but are not limited to, changes in cognition or sudden unexpected decline in condition, a fall with a suspected fracture or adverse consequences to a medication or therapy, or other situations requiring a review or revision to the care plan. The immediate notification to hospice does not change the requirement that a nursing home also immediately notify the resident's attending physician/practitioner and the family resident representative of significant changes in condition or a need to change the care plan. Refer to F580 notification of changes prior to care plan or order changes. The hospice and the resident's attending physician/practitioner may need to collaborate to address this change and to assure the resident's immediate needs and treatment decisions are met, including situations which could require a potential transfer to an acute care setting. This decision-making must be consistent with the resident's wishes. Refer to F849 hospice services. Additionally, the communication of necessary information to the receiving provider must include those items required at Section 483.1 5C2 Roman 3, F622. If there is a conflict between the hospice and the resident's attending physician/practitioner regarding the care plan, there must be communication between the hospice and the nursing home regarding the issue. This communication should be timely and include the hospice medical director and the nursing home medical director as well as other pertinent hospice and facility staff, as needed. The care of the resident receiving hospice services must reflect ongoing communication and collaboration between the nursing home and the hospice staff. It is essential that a communication process be established between the nursing home and the hospice to be used 24 hours a day, and that it include how the communication will be documented to reflect concerns and responses. Refer to F849, which requires that the written agreement specify the process for hospice and nursing home communication of necessary information regarding the resident's care. Review of facility practices/written agreement for hospice services, any concerns identified by the survey team related to end of life and/or care provided by a hospice should trigger a review of the facility's policies and procedures on end of life and hospice care and/or related policies, e.g., advance directives. In addition, the survey team should request a copy of the written agreement between the nursing home and the hospice. If there is a failure to develop and/or implement portions of the written agreement with a hospice, refer to F849 hospice services. Note, surveyors should refer the following concerns as a complaint to the state agency responsible for oversight of hospice for residents receiving Medicare-certified hospice services. Hospice failure to address and resolve concerns made known to them by the nursing facility, which are related to coordination of care or implementation of appropriate services, and/or hospice failure to provide services in accordance with the coordinated plan of care, regardless of notice from the facility. In addition, if the hospice was advised of the concerns and failed to resolve issues related to the management of a resident's care, coordination of care, or implementation of appropriate services. Review the nursing home/hospice written agreement to determine whether there is a failure by the nursing home related to the implementation of the agreement at F849. The survey team must refer the complaint to the state agency responsible for oversight of hospice, identifying the specific residentess involved and the concerns identified. If the hospice was advised of the concerns and failed to resolve issues related to the management of a resident's care, coordination of care, or implementation of appropriate services. Review the appropriate portions of F849 regarding the written agreement and determine whether there is a failure by the nursing home related to the implementation of the agreement. Investigative protocol for F684, quality of care use. Use the general critical element C pathway, or if applicable, the hospice and end-of-life care and services CE pathway, along with the above interpretive guidelines, or applicable professional standards of practice for investigating concerns related to the facility's requirement to provide treatment and care in accordance with professional standards of practice, the comprehensive person-centered care plan, and the resident's choices, for which there is no other quality of care tag that would address the issue. Summary of investigative procedure. Briefly review the most recent comprehensive assessments, comprehensive care plan, and orders to identify whether the facility has recognized and assessed concerns or resident care needs under investigation. If the resident has been in the facility for less than 14 days before completion of all the Resident Assessment Instrument RI is required, review the baseline care plan, which must be completed within 48 hours to determine if the facility is providing appropriate care and services based on information available at the time of admission. This information will guide observations and interviews to be made in order to corroborate concerns identified. Make note of whether the comprehensive care plan is evaluated and revised based on the resident's response to interventions. Always observe for visual cues of psychosocial distress and harm. See Appendix P, Guidance on Severity and Scope Levels, and Psychosocial Outcome Severity Guide. During the investigation, identify the extent to which the facility has developed and implemented interventions in accordance with the resident's needs, goals for care, and professional standards of practice for the specific condition or concern being investigated. In any instance in which the surveyor has identified a lack of improvement or a decline, it must be determined whether this was unavoidable or avoidable. In order to make a determination of unavoidable decline or failure to reach highest practicable well-being, the facility must have conducted an accurate and comprehensive assessment. See Section 483.20 Resident Assessment, including evaluating the resident's clinical condition and risk factors for the concern being investigated. Based on information gathered through resident assessments, with resident/representative input, developed a person-centered care plan, defined and implemented interventions that are consistent with resident needs, goals, and recognized standards of practice. Implemented the care plan and monitored resident responses to the interventions, and provided ongoing review and revision of the care plan and interventions as necessary. If the facility has not done one or more of the above bulleted items, and a decline or failure to reach his or her highest practicable well-being occurred, this would be considered an avoidable decline. Note, during the investigation of services provided to a resident from a Medicare-certified hospice, determine whether the hospice was advised of concerns by the nursing home and failed to address and resolve issues related to coordination of care or implementation of appropriate services, or the hospice failed to provide services in accordance with the coordinated care plan, regardless of notice from the facility. The survey team must refer the above concerns as complaints to the state agency responsible for oversight of hospice, identifying the specific residentess involved and the concerns identified. If the hospice was advised of the concerns and failed to resolve issues related to the management of a resident's care, coordination of care, or implementation of appropriate services, review the appropriate portions of F849 regarding the written agreement and determine whether there is a failure by the nursing home related to the implementation of the agreement. Key elements of noncompliance. To cite deficient practice at F684, the surveyor's investigation will generally show that the facility failed to do any one of the following: provide needed care or services resulting in an actual or potential decline in one or more residents' physical, mental, and or psychosocial well-being. Provide needed care or services, i.e., manage symptoms resulting in one or more residents' failure to improve and or attain their highest practicable physical, mental, and or psychosocial well-being. Recognize and or assess risk factors, placing the resident at risk for specific conditions and or problems. Implement resident-directed care and treatment consistent with the resident's comprehensive assessment and care plan, preferences, choices, rights, advance directives, if any, and if applicable, according to state law, goals, physician orders, and professional standards of practice, causing a negative outcome, or placing the resident at risk for specific conditions and or problems. Monitor, evaluate the resident's response to interventions and or revise the interventions as appropriate, causing a negative outcome or placing the resident at risk for specific conditions and or problems. And inform and educate the resident who decides to decline care about risks benefits of such declination, and offer alternative care options and take steps to minimize further decline, causing a negative outcome, or placing the resident at risk for specific conditions and or problems. Note, most noncompliance related to the failure to provide care and services needed for residents to attain or maintain the highest practicable physical, mental, and psychosocial well-being can also be cited at other regulations, e.g. assessment, care planning, accommodation of needs, and physician supervision. Surveyors should evaluate compliance with these regulations and cite deficiencies at F684 only when other regulations do not address the deficient practice. Refer to F697 for pain management, and if there is a failure to develop and/or implement portions of the written agreement with a hospice, refer to F849 hospice services. Deficiency categorization. In addition to actual or potential physical harm, always consider whether psychosocial harm has occurred when determining severity level. See Appendix P, Section Roman 4, E, Psychosocial Outcome Severity Guide. Examples of severity level 4 noncompliance immediate jeopardy to resident health or safety include, but are not limited to: the facility failed to promptly identify and intervene for an acute change in a resident's condition related to congestive heart failure (CHF), resulting in the family calling 911 to transport the resident to the hospital. The resident was admitted to the hospital with respiratory distress, pulmonary edema, and complications of CHF, also cross-referenced and cited at F580, Notification of Changes. As a result of the facility's continuous or repeated failure to implement comfort measures in accordance with the care plan, the resident experienced serious harm related to uncontrolled vomiting and nausea. Examples of severity level 3 noncompliance actual harm that is not immediate jeopardy include, but are not limited to: the facility failed to provide care for a resident with a stasis ulcer as identified on the resident's care plan and physician's orders, resulting in worsening of the stasis ulcer, as evidenced by a large area of the skin surrounding the ulcer being reddened, swollen, and, according to the nurse, warm to touch. There was exudate and slough on the wound bed, and according to measurements, the wound had increased in size. The facility failed to implement a resident's hospice/nursing home coordinated care plan that specified the resident not being transferred to the hospital for treatment. The facility transferred the resident to the hospital for treatment related to a urinary tract infection, even though the resident and the coordinated care plan indicated the resident did not wish to be hospitalized and preferred treatment at the facility. The facility did not contact the hospice prior to initiating the transfer to the hospital. The resident experienced increased pain during the transfer to the hospital and continued to express emotional distress, tearful/crying over the transfer. The resident had requested, and the care plan included a symptom management plan with the use of medication to reduce the resident's symptoms, but not to the point that the resident was symptom-free, so that the resident could be alert and able to participate in visits with family/friends. However, the facility failed to administer the medications as indicated in the plan of care. The resident experienced lethargy and somnolence and was unable to converse/relate to family/friends during visits. Examples of severity level 2 noncompliance: no actual harm with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to: failure to follow physician orders to obtain daily weights for a resident with a diagnosis of congestive heart failure, as evidenced by no documented daily weights on 3 consecutive weekends. Although this noncompliance resulted in no actual harm to the resident, it has a potential for more than minimal harm if the practice is not corrected. The resident receiving the hospice benefit was on a pain management program utilizing opioids. The resident was experiencing episodic minimal discomfort related to the facility's failure to consistently implement the bowel management plan as identified in the Coordinated Care Plan. Severity Level 1 noncompliance. No actual harm, with potential for minimal harm. Failure to provide appropriate care and services to meet the resident's physical, mental, and/or psychosocial needs places the resident at risk for more than minimal harm. Therefore, Severity Level 1 does not apply for this regulatory requirement. Tag F685. Section 483.2. 5A Vision and Hearing to ensure that residents receive proper treatment and assistive devices to maintain vision and hearing abilities. The facility must, if necessary, assist the resident. Section 483.2. 5A1 in making appointments, and Section 483.2. 5A2 by arranging for transportation to and from the office of a practitioner specializing in the treatment of vision or hearing impairment, or the office of a professional specializing in the provision of vision or hearing assistive devices. The intent of this regulation is to ensure the facility assists the resident in gaining access to vision and hearing services by making appointments and by arranging for transportation. Definitions: assistive devices to maintain vision include, but are not limited to, glasses, contact lenses, magnifying lens, or other devices that are used by the resident. Assistive devices to maintain hearing include, but are not limited to, hearing aids and amplifiers. Interpretive guidance: this requirement does not mean that the facility must provide refraction, glasses, contact lenses, or other assistive devices. Conduct comprehensive audiological evaluations other than the screening that is a part of the required assessment in Section 483.20b, or provide hearing aids or other devices. The facility's responsibility is to assist residents and their representatives in locating and utilizing any available resources, e.g., Medicare or Medicaid program payment, local health organizations offering items and services which are available free to the community for the provision of the services the resident needs. This includes making appointments and arranging transportation to obtain needed services. In situations where the resident has lost their device, facilities must assist residents and their representative in locating resources, as well as in making appointments and arranging for transportation to replace the lost devices. Investigative summary. Use the activities of daily living and communication sensory critical element, C pathways, along with the above interpretive guidelines, when determining if the facility meets requirements to ensure that residents receive proper treatment and assistive devices to maintain vision and hearing abilities. Summary of vision and hearing investigative procedure. Briefly review the most recent comprehensive assessments, comprehensive care plan, and physician orders to determine if the facility assists residents in gaining access to vision and hearing services by making appointments and arranging for transportation. Observations, interviews, and record reviews should be utilized to corroborate concerns identified. If the resident has been in the facility for less than 14 days before completion of all the Resident Assessment Instrument (RAI) is required, review the baseline care plan, which must be completed within 48 hours to determine if the facility is providing appropriate care and services based on information available at the time of admission. Tag F686. Section 483.2, 5B Skin Integrity Section 483.2, 5B1 Pressure Ulcers. Based on the comprehensive assessment of a resident, the facility must ensure that a resident receives care, consistent with professional standards of practice, to prevent pressure ulcers and does not develop pressure ulcers unless the individual's clinical condition demonstrates that they were unavoidable. And Roman II, a resident with pressure ulcers receives necessary treatment and services, consistent with professional standards of practice, to promote healing, prevent infection, and prevent new ulcers from developing. Intent. The intent of this requirement is that the resident does not develop pressure ulcers/injuries, PU/PI, unless clinically unavoidable, and that the facility provides care and services consistent with professional standards of practice to promote the prevention of pressure ulcer/injury development, plus promote the healing of existing pressure ulcers/injuries, including prevention of infection to the extent possible, and prevent development of additional pressure ulcer/injury. Note, CMS is aware of the array of terms used to describe alterations in skin integrity due to pressure. Some of these terms include pressure ulcer, pressure injury, pressure sore, decubitus ulcer, and bed sore. Clinicians may use, and the medical record may reflect any of these terms, as long as the primary cause of the skin alteration is related to pressure. For example, the medical record could reflect the presence of a stage 2 pressure injury, while the same area would be coded as a stage 2 pressure ulcer on the MDS. CMS often refers to the National Pressure Ulcer Advisory Panel's NPUAP terms and definitions, which it has adapted, within its patient and resident assessment instruments and corresponding assessment manuals, which includes the minimum data set MDS. We intend to continue our adaptation of NPUAP terminology for coding the resident assessment instrument while retaining current holistic assessment instructions, definitions, and terminology. The adapted terminology was used in the development of this guidance. Additional information can be found on the NPUAP website at https://www.npuap.org/resources/educational and clinical resources. Note, references to non-CMS/HHS sources or sites on the Internet included above or later in this document are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services. CMS is not responsible for the content of pages found at these sites. URL addresses were current at the date of this publication. Definitions. Definitions are provided to clarify clinical terms related to pressure injuries and their evaluation and treatment. Pressure ulcer/injury PU/PI refers to localized damage to the skin and slash or underlying soft tissue, usually over a bony prominence or related to a medical or other device. A pressure injury will present as intact skin and may be painful. A pressure ulcer will present as an open ulcer, the appearance of which will vary depending on the stage and may be painful. The injury occurs as a result of intense and slash or prolonged pressure or pressure in combination with shear. Soft tissue damage related to pressure and shear may also be affected by skin temperature and moisture, nutrition, perfusion, comorbidities, and condition of the soft tissue. Avoidable/unavoidable. Avoidable means that the resident developed a pressure ulcer/injury and that the facility did not do one or more of the following: evaluate the resident's clinical condition and risk factors, define and implement interventions that are consistent with resident needs, resident goals, and professional standards of practice. Monitor and evaluate the impact of the interventions, or revise the interventions as appropriate. Unavoidable means that the resident developed a pressure ulcer/injury even though the facility had evaluated the resident's clinical condition and risk factors, defined and implemented interventions that are consistent with resident needs, goals, and professional standards of practice, monitored and evaluated the impact of the interventions, and revised the approaches as appropriate. Colonized/infected. Colonized refers to the presence of microorganisms on the surface or in the tissue of a wound without the signs and symptoms of an infection. Infected refers to the presence of microorganisms in sufficient quantity to overwhelm the defenses of viable tissues and produce the signs and symptoms of infection. Debridement is the removal of devitalized/necrotic tissue and foreign matter from a wound to improve or facilitate the healing process. Debridement methods may include a range of treatments, such as the use of enzymatic dressings to surgical debridement, in order to remove tissue or matter from a wound to promote healing. Eschar/slough. Eschar is dead or devitalized tissue that is hard or soft in texture, usually black, brown, or tan in color, and may appear scab-like. Necrotic tissue and eschar are usually firmly adherent to the base of the wound and often the sides/edges of the wound. Slough is non-viable yellow, tan, gray, green, or brown tissue, usually moist, can be soft, stringy, and mucinous in texture. Slough may be adherent to the base of the wound or present in clumps throughout the wound bed. Exudate. Exudate is any fluid that has been forced out of the tissues or its capillaries because of inflammation or injury. It may contain serum, cellular debris, bacteria, and leukocytes. Purulent exudate/drainage/discharge is any product of inflammation that contains pus, e.g., leukocytes, bacteria, and liquefied necrotic debris. Serous drainage or exudate is watery, clear, or slightly yellow/tan/pink fluid that has separated from the blood and presents as drainage. Friction/shearing. Friction is the mechanical force exerted on skin that is dragged across any surface. Shearing occurs when layers of skin rub against each other or when the skin remains stationary, and the underlying tissue moves and stretches and angulates or tears the underlying capillaries and blood vessels, causing tissue damage. Granulation tissue. Granulation tissue is the pink red moist tissue that fills an open wound when it starts to heal. It contains new blood vessels, collagen, fibroblasts, and inflammatory cells. Tunnel/sinus tract / undermining the terms tunnel and sinus tract are often used interchangeably. A tunnel is a passageway of tissue destruction under the skin surface that has an opening at the skin level from the edge of the wound. A sinus tract is a cavity or channel underlying a wound that involves an area larger than the visible surface of the wound. Undermining is the destruction of tissue or ulceration extending under the skin edge's margins so that the pressure ulcer is larger at its base than at the skin surface. Undermining often develops from shearing forces and is differentiated from tunneling by the larger extent of the wound edge involved and the absence of a channel or tract extending from the pressure ulcer under the adjacent intact skin. Guidance staging. Staging of a PU/PI is performed to indicate the characteristics and extent of tissue injury and should be conducted according to professional standards of practice. Determining whether damage to the skin and underlying tissue is a PI or PU depends on the staging of the damaged tissue. See stages below. Note, regardless of the staging system or wound definitions used by the facility is responsible for completing the MDS utilizing the staging guidelines found in the RAI manual. Stage 1 pressure injury. Non-blanchable erythema of intact skin. Intact skin with a localized area of non-blanchable erythema redness. In darker skin tones, the PI may appear with persistent red, blue, or purple hues. The presence of blanchable erythema or changes in sensation, temperature, or firmness may precede visual changes. Color changes of intact skin may also indicate a deep tissue PIC below. Stage 2, pressure ulcer. Partial thickness skin loss with exposed dermis. Partial thickness loss of skin with exposed dermis, presenting as a shallow open ulcer. The wound bed is viable, pink or red, moist, and may also present as an intact or open/ruptured blister. Adipose fat is not visible and deeper tissues are not visible. Granulation tissue, slough, and eschar are not present. This stage should not be used to describe moisture-associated skin damage, including incontinence-associated dermatitis, intertriginous dermatitis inflammation of skin folds, medical adhesive-related skin injury, or traumatic wounds, skin tears, burns, abrasions. Stage 3 pressure ulcer, full-thickness skin loss. Full-thickness loss of skin, in which subcutaneous fat may be visible in the ulcer and granulation tissue and epibole rolled wound edges are often present. Slough and slash or eschar may be visible, but does not obscure the depth of tissue loss. The depth of tissue damage varies by anatomical location. Areas of significant adiposity can develop deep wounds. Undermining and tunneling may occur. Fascia, muscle, tendon, ligament, cartilage, and slash or bone are not exposed. If slough or eschar obscures the wound bed, it is an unstageable PU/PI. Stage 4 pressure ulcer, full-thickness skin and tissue loss. Full-thickness skin and tissue loss with exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, or bone in the ulcer. Slough and slash or eschar may be visible on some parts of the wound bed. Epibole rolled edges, undermining and slash or tunneling often occur. Depth varies by anatomical location. If slough or eschar obscures the wound bed, it is an unstageable PU/PI. Unstageable pressure ulcer, obscured full-thickness skin and tissue loss. Full-thickness skin and tissue loss in which the extent of tissue damage within the ulcer cannot be confirmed because the wound bed is obscured by slough or eschar. Stable eschar, i.e. dry, adherent, intact without erythema or fluctuance, should only be removed after careful clinical consideration and consultation with the resident's physician or nurse practitioner, physician assistant, or clinical nurse specialist, if allowable under state licensure laws. If the slough or eschar is removed, a stage 3 or stage 4 pressure ulcer will be revealed. If the anatomical depth of the tissue damage involved can be determined, then the reclassified stage should be assigned. The pressure ulcer does not have to be completely debrided or free of all slough or eschar for reclassification of stage to occur. Other staging considerations include deep tissue pressure injury, DTPI, persistent non-blanchable deep red, maroon, or purple discoloration. Intact skin with localized area of persistent non-blanchable deep red, maroon, purple discoloration due to damage of underlying soft tissue. This area may be preceded by tissue that is painful, firm, mushy, boggy, warmer, or cooler as compared to adjacent tissue. These changes often precede skin color changes, and discoloration may appear differently in darkly pigmented skin. This injury results from intense and slash or prolonged pressure and shear forces at the bone-muscle interface. The wound may evolve rapidly to reveal the actual extent of tissue injury, or may resolve without tissue loss. If necrotic tissue, subcutaneous tissue, granulation tissue, fascia, muscle, or other underlying structures are visible, this indicates a full-thickness pressure ulcer. Once a deep tissue injury opens to an ulcer, reclassify the ulcer into the appropriate stage. Do not use DTPI to describe vascular, traumatic, neuropathic, or dermatologic conditions. Medical device-related pressure ulcer/injury. Medical device-related PU/PIs result from the use of devices designed and applied for diagnostic or therapeutic purposes. The resultant pressure injury generally conforms to the pattern or shape of the device. The injury should be staged using the staging system. Mucosal membrane pressure ulcer/injury. Mucosal membrane PU/PIs are found on mucous membranes with a history of a medical device in use at the location of the injury. Due to the anatomy of the tissue, these ulcers cannot be staged. Prevention of pressure ulcers/injuries. A pressure ulcer/injury PU/PI can occur wherever pressure has impaired circulation to the tissue. A facility must identify whether the resident is at risk for developing or has a PU/PI upon admission and thereafter. Evaluate resident-specific risk factors and changes in the resident's condition, that may impact the development and or healing of a PU/PI. Implement, monitor, and modify interventions to attempt to stabilize, reduce, or remove underlying risk factors. And, if a PU/PI is present, provide treatment and services to heal it and to prevent infection and the development of additional PU/PIs. The first step in the prevention of PU/PIs is the identification of the resident at risk of developing PU/PIs. This is followed by implementation of appropriate individualized interventions and monitoring for the effectiveness of the interventions. Assessment. An admission evaluation helps identify residents at risk of developing a PU/PI and residents with existing PU/PIs. Because a resident at risk can develop a PU/PI within hours of the onset of pressure, the at-risk resident needs to be identified and have interventions implemented promptly to attempt to prevent PU/PI. The admission evaluation helps define those initial care approaches. In addition, the admission evaluation may identify pre-existing signs suggesting that tissue damage has already occurred and additional tissue loss may occur. For example, a deep tissue pressure injury identified on admission could lead to the appearance of an unavoidable stage 3 or 4 pressure ulcer. A stage 1 PI can progress to an ulcer with eschar or exudate within days after admission. Some situations, which may have contributed to this tissue damage prior to admission, include pressure resulting from immobility during hospitalization or surgical procedures, during prolonged ambulance transport, or while waiting to be assisted after a debilitating event, such as a fall or a cerebral vascular accident. It may be harder to identify erythema in a resident with darkly pigmented skin, putting those residents more at risk for developing PU/PIs. It may be necessary, in darker-skinned residents, to focus more on other evidence of PU/PI development, such as changes in sensation, skin temperature, or firmness. Multiple factors, including pressure intensity, pressure duration, and tissue tolerance, significantly affect the potential for the development and healing of PUS/PIs. The comprehensive assessment, which includes the RAI, evaluates the resident's intrinsic risks, the resident's skin condition, and other factors including causal factors which place the resident at risk for the development of or hinder the healing of PU/PIs. An individual may also have various intrinsic risks due to aging, such as decreased subcutaneous tissue and lean muscle mass, decreased skin elasticity, and impaired circulation or sensation. The comprehensive assessment should address those factors that have been identified as having an impact on the development, treatment, and or healing of PU/PIs, including, at a minimum, risk factors, pressure points, undernutrition and hydration deficits, and moisture and the impact of moisture on skin. The assessment also helps identify the resident who has multi-system organ failure or an end-of-life condition, or who is refusing care and treatment. If the resident is refusing care, an evaluation of the basis for the refusal and the identification and evaluation of potential alternatives is indicated. Risk factors. Not all risk factors are fully modifiable or can be completely addressed. Some risk factors, such as a permanent lack of sensation to an area, may not be modifiable. Some potentially modifiable risk factors, such as malnutrition or uncontrolled blood sugars, may take time to correct, despite prompt intervention. Other risk factors, such as pressure, can be modified promptly. Many studies and professional literature identify risk factors that increase a resident's susceptibility to develop or to not heal pressure PU/PIs. Examples of these risk factors include, but are not limited to, impaired/decreased mobility and decreased functional ability, comorbid conditions such as end-stage renal disease, thyroid disease, or diabetes, mellitus, drugs such as steroids that may affect healing, impaired diffuse or localized blood flow, for example, generalized atherosclerosis, or lower extremity arterial insufficiency, resident refusal of some aspects of care and treatment, cognitive impairment, exposure of skin to urinary and fecal incontinence, undernutrition, malnutrition, and hydration deficits, and the presence of a previously healed PU/PI. The history of any healed PU/PI, its origin, treatment, its stages if known is important assessment information, since areas of healed stage 3 or 4 PU/PIs are more likely to have recurrent breakdown. Although the requirements do not mandate the use of any specific assessment tool other than the RAI, many validated instruments are available to aid in assessing the risk for developing PU/PIs. It is important to keep in mind that research has shown that in a skilled nursing facility, 80% of PU/PIs develop within 2 weeks of admission and 96% develop within 3 weeks of admission. Reference: Litter CHILOEA, Pressure Ulcers, a Patient Safety Issue. In Hughes R.G. Editor. Patient Safety and Quality, an Evidence-Based Handbook for Nurses. Rockville, M.D., Agency for Healthcare Research and Quality U.S., 2008 APRA. Chapter 12. Available from http://www.ncbinlmnigov/books/NBK 2650/. Many clinicians utilize a standardized pressure ulcer/injury risk assessment tool to assess a resident's PU/PI risks upon admission, weekly for the first 4 weeks after admission, then quarterly or whenever there is a change in the resident's condition. A resident's risk may increase due to an acute illness or condition change, e.g., upper respiratory infection, pneumonia, or exacerbation of underlying congestive heart failure, and may require additional evaluation. The frequency of assessment should be based upon each resident's specific needs. Regardless of any resident's total risk score on an assessment tool, clinicians are responsible for evaluating each existing and potential risk factor for developing a pressure injury and determining the resident's overall risk. It is acceptable if the clinician's assessment places the resident at a higher risk level than the overall score of the assessment tool based on assessment factors that are not captured by the tool. Documentation of the clinician's decision should be placed in the medical record. Pressure points and tissue tolerance. Assessment of a resident's skin condition helps define prevention strategies. The skin assessment should include an evaluation of the skin integrity. Tissue closest to the bone may be the first tissue to undergo changes related to pressure. PU/PIs are usually located over a bony prominence, such as the sacrum, heel, the greater trochanter, ischial tuberosity, fibular head, scapula, and ankle malleolus. An at-risk resident who sits too long in one position may be more prone to developing an ulcer/injury over the ischial tuberosity. Slouching in a chair may predispose an at-risk resident to pressure ulcers/injuries of the spine, scapula, or elbow. Elbow pressure injury is often related to arm rests or lap boards. Friction and shearing are also important factors in tissue ischemia, necrosis, and PU/PI formation. PU/PIs may develop at other sites where pressure has impaired the circulation to the tissue, such as pressure from positioning or use of medical devices applied for diagnostic or therapeutic purposes. The resultant PU/PI generally conforms to the pattern or shape of the device. Mucosal membrane PU/PIs are found on mucous membranes with a history of a medical device in use at the location of the injury. Due to the anatomy of mucous membranes, these ulcers cannot be staged. PU/PIs on the sacrum and heels are most common. PU/PIs may also develop from pressure on an earlobe related to positioning of the head. On areas, for example, nares, urinary meatus, extremities caused by tubes, casts, orthotics, braces, cervical collars, or other medical devices. Pressure on the labia or scrotum related to positioning, for example, against a pommel-type cushion. The foot related to ill-fitting shoes causing blistering, or on legs, arms and fingers due to contractures or deformity. Nutrition and hydration. Adequate nutrition and hydration are essential for overall functioning. Nutrition provides vital energy and building blocks for all of the body's structures and processes. Any organ or body system may require additional energy or structural materials for repair or function. The skin is the body's largest organ system. It may affect and be affected by other body processes and organs. Skin condition reflects overall body function, therefore, the presence of skin breakdown may be the most visible evidence of a health issue. Weight reflects a balance between intake and utilization of energy. Significant unintended weight loss may indicate undernutrition or worsening health status. Weight stability in the absence of fluid excess or loss is a useful indicator of overall caloric balance. Severely impaired organs, heart, lungs, kidneys, liver, etc., may be unable to use nutrients effectively. A resident with a PU/PI who continues to lose weight either needs additional caloric intake or correction where possible of conditions that are creating a hypermetabolic state. Continuing weight loss and failure of a PU/PI to heal despite reasonable efforts to improve caloric and nutrient intake may indicate the resident is in multisystem failure or an end-stage or end-of-life condition, warranting an additional assessment of the resident's overall condition. Before instituting a nutritional care plan, it helps to summarize resident-specific evidence, including severity of nutritional compromise, rate of weight loss or appetite decline, probable causes, the individual's prognosis and projected clinical course, and the resident's wishes and goals. Because there are no wound-specific nutritional measures, the interdisciplinary team should develop nutritional goals for the whole person and address nutritional status and needs in the care plan as appropriate. Note: although some laboratory tests may help clinicians evaluate nutritional issues in a resident with PU/PIs, no laboratory test is specific or sensitive enough to warrant serial/repeated testing. A practitioner may order tests that provide useful additional information or help with management of treatable conditions at their discretion. Water is essential to maintain adequate body functions. As a major component of blood, water dissolves vitamins, minerals, glucose, amino acids, etc., transports nutrients into cells, removes waste from the cells, and helps maintain circulating blood volume as well as fluid and electrolyte balance. It is critical that each resident at risk for hydration deficit or imbalance, including the resident who has or is at risk of developing a PU/PI, be identified and assessed to determine appropriate interventions. Note: the surveyor should refer to the guidance at 42 CFR 483.2, 5G, F692, Assisted Nutrition and Hydration, for investigation of potential noncompliance with the nutrition and hydration requirements. A low albumin level combined with the facility's lack of supplementation, for example, is not by itself sufficient to cite a nutrition-related deficiency. Moisture. Both urine and feces contain substances that may irritate the epidermis and may make the skin more susceptible to breakdown and moisture-related skin damage. Fecal incontinence may pose a greater threat to skin integrity due to bile acids and enzymes in the feces. Irritation or maceration resulting from prolonged exposure to urine and feces may hasten skin breakdown, and moisture may make skin more susceptible to damage from friction and shear during repositioning. It may be difficult to differentiate dermatitis related to incontinence from partial thickness PU/PI. This differentiation should be based on the clinical evidence and review of presenting risk factors. The dermatitis may occur in the area where the incontinence brief or underpad has been used. Prevention and treatment strategies. The comprehensive assessment should provide the basis for defining approaches to address residents at risk of developing or already having a PU/PI. A determination that a resident is at risk for developing a PU/PI has significant implications for preventive and treatment strategies, but does not by itself indicate that development of a PU/PI was unavoidable. Effective prevention and treatment are based upon consistently providing routine and individualized interventions. Based upon the assessment and the resident's clinical condition, choices and identified needs, basic or routine care could include, but is not limited to, interventions to redistribute pressure such as repositioning, protecting and slash or offloading heels, etc. Minimize exposure to moisture and keep skin clean, especially of fecal contamination. Provide appropriate, pressure redistributing support surfaces, provide non-irritating surfaces, and maintain or improve nutrition and hydration status where feasible. Adverse drug reactions related to the resident's drug regimen may worsen risk factors for development of, or for non-healing PU/PIs, for example, by causing lethargy or anorexia, or creating increasing confusion, and should be identified and addressed. These interventions should be incorporated into the plan of care and revised as the condition of the resident indicates. Resident choices. In the context of the resident's choices, clinical condition, and physician input, the resident's care plan should establish relevant goals and approaches to stabilize or improve comorbidities, such as attempts to minimize clinically significant blood sugar fluctuations, and other interventions aimed at limiting the effects of risk factors associated with PU/PIs. Alternatively, facility staff and practitioners should document clinically valid reasons why such interventions were not appropriate or feasible. In order for a resident to exercise his or her right appropriately to make informed choices about care and treatment or to decline treatment, the facility and the resident, or if applicable, the resident representative must discuss the resident's condition, treatment options, expected outcomes, and consequences of refusing treatment. The facility is expected to address the resident's concerns and offer relevant alternatives if the resident has declined specific treatments. See Section 483.10c, F552, Planning and Implementing Care. Pressure injuries at end of life. Residents at the end of life, in terminal stages of an illness or having multiple system failures, may have written directions for his or her treatment goals, or a decision has been made by the resident's representative in accordance with state law. The facility's care must reflect the resident's goals for care and wishes as expressed in a valid advance directive, if one was formulated in accordance with state law. However, the presence of an advance directive does not absolve the facility from giving supportive and other pertinent care that is not prohibited by the resident's advance directive. It is important for surveyors to understand that when a facility has implemented individualized approaches for end-of-life care in accordance with the resident's wishes, the development, continuation, or worsening of a PU/PI may be considered unavoidable. If the facility has implemented appropriate efforts to stabilize the resident's condition, or indicted why the condition cannot or should not be stabilized, and has provided care to prevent or treat existing PU/PIs, including pertinent, routine, lesser aggressive approaches, such as cleaning, turning, repositioning. The PU/PI may be considered unavoidable and consistent with regulatory requirements. The Kennedy Terminal Ulcer KTU. The facility is responsible for accurately assessing and classifying an ulcer as a KTU or other type of PU/PI, and demonstrate that appropriate preventative measures were in place to prevent non-KTU pressure ulcers. KTUs have certain characteristics which differentiate them from pressure ulcers, such as the following. KTUs appear suddenly and within hours, usually appear on the sacrum and coccyx, but can appear on the heels, posterior. Calf muscles, arms, and elbows. Edges are usually irregular and are red, yellow, and black as the ulcer progresses. often described as pear, butterfly, or horseshoe-shaped, and often appear as an abrasion, blister, or darkened area and may develop rapidly to a Stage 2, Stage 3, or Stage 4 injury. Repositioning. Repositioning or relieving constant pressure is a common, effective intervention for an individual with a PU/PI or who is at risk of developing one. Assessment of a resident's skin integrity after pressure has been reduced or redistributed should guide the development and implementation of repositioning plans. Such plans should be addressed in the comprehensive care plan, consistent with the resident's need and goals. Repositioning is critical for a resident who is immobile or dependent upon staff for repositioning, as the resident is unable to make small movements on their own that would help to relieve prolonged pressure to one area. The care plan for a resident at risk of friction or shearing during repositioning may require the use of lifting devices for repositioning. Positioning the resident on an existing PU/PI should be avoided since it puts additional pressure on tissue that is already compromised and may impede healing. Determine repositioning frequency with consideration to the individual's level of activity and mobility, general medical condition, overall treatment objectives, skin condition, and comfort. The resident's skin condition and general comfort should be regularly assessed. The efficacy of repositioning must be monitored and revisions to the care plan considered if the individual is not responding as expected to the repositioning interventions. Facilities should consider the following repositioning issues. 1. The time an individual spends seated in a chair without pressure relief should be limited. Seated individuals should be repositioned so as to maintain stability and full range of activities. An acceptable seated posture minimizes the pressure and shear exerted on the skin and soft tissues, which may involve using pressure-relieving devices/cushions or adjusting the seat tilt, footrests, elevated leg rests, and other support devices to prevent prolonged pressure to areas of the body that may be at particular risk for developing a PU/PI. 2. If able, the resident should be taught to shift his or her weight while sitting in a chair. A resident who can change positions independently may need supportive devices to facilitate position changes. The resident also may need instruction about why repositioning is important and how to do it, encouragement to change positions regularly, and monitoring of frequency of repositioning. 3. Many clinicians recommend a position change, off-loading hourly for dependent residents who are sitting or who are in a bed or a reclining chair with the head of the bed or back of the chair raised 30 degrees or more. The resident may require more frequent position changes based on an assessment of their skin condition or their comfort. A micro-shift, meaning a small change in the resident's position for a short period of time, may not be adequate since this approach does not allow sufficient capillary refill and tissue perfusion for a resident at risk of developing PU/PIs. Ongoing monitoring of the resident's skin integrity and tissue tolerance is critical to prevent development or deterioration of PU/PIs. 4. Wheelchairs are often used for transporting residents, but they may severely limit repositioning options and increase the risk of PU/PI development. Therefore, wheelchairs with sling seats may not be optimal for prolonged sitting during activities or meals, etc. However, available modifications to the seating can provide a more stable surface and provide better pressure reduction. 5. The care plan for a resident who is reclining and is dependent on staff for repositioning should address position changes to maintain the resident's skin integrity. This may include repositioning at least every 2 hours or more frequently, depending upon the resident's condition and specific needs. Depending on the individualized assessment, more frequent repositioning may be warranted for individuals who are at higher risk for PU/PI development or who show evidence that repositioning at 2-hour intervals is inadequate. With rare exceptions such as when both sacral and ischial PU/PIs are present the resident should not be placed directly on the greater trochanter for more than momentary placement. Elevating the head of the bed or the back of a reclining chair to or above a 30-degree angle creates pressure comparable to that exerted while sitting, and requires the same considerations regarding repositioning as those for a dependent resident who is seated. Support surfaces and pressure redistribution. Pressure redistribution refers to the function or ability to distribute a load over a surface or contact area. Redistribution results in shifting pressure from one area to another and requires attention to all affected areas. Pressure redistribution has incorporated the concepts of both pressure reduction and pressure relief. Appropriate support surfaces or devices should be chosen by matching a device's potential therapeutic benefit with the resident's specific situation, such as multiple injuries, limited turning surfaces, ability to maintain position. The effectiveness of pressure redistribution devices such as gel mattresses, air fluidized mattresses, and low-loss air mattresses is based on their potential to address the individual resident's risk, the resident's response to the product, and the characteristics and condition of the product. For example, an overinflated overlay product, or one that bottoms out when the overlay is underinflated or loses inflation, creating less than 1 inch between the resident and support material, is unlikely to effectively reduce the pressure risk. These products are more likely to reduce pressure effectively if they are used in accord with the manufacturer's instructions. The effectiveness of each product used needs to be evaluated on an ongoing basis. Surveyors should consider the following pressure redistribution issues. Static pressure redistribution devices, such as a gel mattress, may be indicated when a resident is at risk for PU/PI development or delayed healing. A specialized pressure redistribution cushion or surface, for example, might be used to extend the time a resident is sitting in a chair. However, the cushion does not eliminate the necessity for periodic repositioning and skin assessment. Dynamic pressure reduction surfaces may be helpful when the resident cannot assume a variety of positions without bearing weight on a PU/PI. The resident completely compresses a static device that has retained its original integrity. Or the PU/PI is not healing as expected, and it is determined that pressure may be contributing to the delay in healing. Because the heels and elbows have relatively little surface area, it is difficult to redistribute pressure on these two surfaces. Therefore, it is important to pay particular attention to reducing the pressure on these areas for the resident at risk, in accord with residents' overall goals and condition. Pillows used to support the entire lower leg may effectively raise the heel from contact with the bed, but use of the pillows needs to take into account the resident's other conditions. The use of donut-type cushions is not recommended by the clinicians. A resident with severe flexion contractures also may require special attention to effectively reduce pressure on bony prominences or prevent breakdown from skin-to-skin contact. Some products serve mainly to provide comfort and reduce friction and shearing forces, e.g., sheepskin, heel, and elbow protectors. Although these products are not effective at redistributing pressure, they, in addition to pillows, foam wedges, or other measures, may be employed to prevent bony prominences from rubbing together or on other surfaces, such as armrests, the bed, or side rails. Monitoring. Staff should remain alert to potential changes in the skin condition and should evaluate, report, and document changes as soon as identified. For example, a resident's complaint about pain or burning at a site where there has been pressure or observation during the resident's bath that there is a change in skin condition should be reported so that the resident may be evaluated further. After completing a thorough evaluation, the interdisciplinary team should develop a relevant care plan that includes measurable goals for prevention and management of PU/PIs with appropriate interventions. Many clinicians recommend evaluating skin conditions, skin color, moisture, temperature, integrity, and turgor at least weekly, or more often if indicated, such as when the resident is using a medical device that may cause pressure. Defined interventions should be implemented and monitored for effectiveness. Assessment and treatment of pressure ulcers/injuries. It is important that each existing PU/PI be identified, whether present on admission or developed after admission, and that factors that influenced its development, the potential for development of additional PU/PIs, or the deterioration of the PU/PIs be recognized, assessed, and addressed. Any new PU/PI suggests a need to reevaluate the adequacy of prevention measures in the resident's care plan. When assessing the PU/PI itself, it is important that documentation addresses the type of injury, pressure-related versus non-pressure-related, because interventions may vary depending on the specific type of injury. The PU/PI stage, a description of the PU/PI's characteristics. The progress toward healing and identification of potential complications. If infection is present, the presence of pain, what was done to address it, and the effectiveness of the intervention, and a description of dressings and treatments. Types of injuries. 3 of the more common types of skin injuries are pressure, vascular insufficiency/ischemia venous stasis, and arterial ischemic ulcers and neuropathic. See Section 483.25, F684, Quality of Care, for definition and description of injury types other than PU/PIs. At the time of the assessment, clinicians, physicians, advanced practice nurses, physician assistants, and certified wound care specialists, etc., should document the clinical basis, for example, type of skin injury, location, shape, edges and wound bed, condition of surrounding tissues for any determination that an injury is not pressure-related, especially if the injury has characteristics consistent with a pressure injury, but is determined not to be one. Pressure ulcer/injury characteristics. It is important that the facility have a system in place to assure that the protocols for daily monitoring and for periodic documentation of measurements, terminology, frequency of assessment, and documentation are implemented consistently throughout the facility. When a PU/PI is present, daily monitoring, with accompanying documentation, when a complication or change is identified, should include an evaluation of the PU/PI if no dressing is present, an evaluation of the status of the dressing, if present whether it is intact, and whether drainage, if present, is or is not leaking, the status of the area surrounding the PU/PI that can be observed without removing the dressing, the presence of possible complications, such as signs of increasing area of ulceration or soft tissue infection, for example, increased redness or swelling around the wound or increased drainage from the wound, and whether pain, if present, is being adequately controlled. The amount of observation possible will depend upon the type of dressing that is used, since some dressings are meant to remain in place for several days, according to manufacturers' guidelines. With each dressing change, or at least weekly and more often when indicated by wound complications or changes in wound characteristics, an evaluation of the PU/PI should be documented. At a minimum, documentation should include the date observed and location and staging, size perpendicular measurements of the greatest extent of length and width of the PU/PI, depth, and the presence, location, and extent of any undermining or tunneling/sinus tract, exudate if present, type such as purulent/serous, color, odor, and approximate amount, pain if present, nature and frequency, e.g., whether episodic or continuous, wound bed, color and type of tissue/character including evidence of healing, e.g., granulation tissue or necrosis, slough or eschar, and description of wound edges and surrounding tissue, e.g., rolled edges, redness, hardness/induration, maceration as appropriate. Photographs may be used to support this documentation. If the facility has developed a protocol, consistent with professional standards and issues related to resident privacy and dignity, are considered and maintained. Healing pressure ulcers/injuries. Ongoing evaluation and research have indicated that PU/PIs do not heal in a reverse sequence. That is, the body does not replace the types and layers of tissue muscle, fat, and dermis that were lost during development. The healing process varies depending on the stage of the pressure injury. There are different types of clinical documentation to describe the progression of the healing PU/PI. Facilities are required to use the RAI. Directions on describing PU/PIs can be found in the RAI manual. These are intended for coding purposes of the MDS. Note, information on coding for the MDS is located on the CMS MDS website http://www.cms.gov/nursing home quality in its /45 NH KIMDs 30 training materials ASP #top of page. It is important to evaluate and modify interventions for a resident with an existing PU/PI, such as the following. Residents with PU/PIs on the sacrum/coccyx or ischia should limit sitting to 3 times a day in periods of 60 minutes or less. Consult a seating specialist to prescribe an appropriate seating surface and slash or positioning techniques to avoid or minimize pressure on the PU/PI. While sitting is important for overall health, every effort should be made to avoid or minimize pressure on the PU/PI. Residents with an ischial injury should not be seated in a fully erect posture in chair or in bed. Modify sitting time schedules and reevaluate the seating surface and the individual's posture if the PU/PI worsens or fails to improve. If a PU/PI fails to show some evidence of progress toward healing within 2 to 4 weeks, the area and the resident's overall clinical condition should be reassessed. Reevaluation of. The treatment plan includes determining whether to continue or modify the current interventions. Results may vary depending on the resident's overall condition and interventions/treatments used. The complexity of the resident's condition may limit responsiveness to treatment or tolerance for certain treatment modalities. The clinicians, if deciding to retain the current regimen, should document the rationale for continuing the present treatment to explain why some, or all, of the plan's interventions remain relevant despite little or no apparent healing. Pressure ulcers/injuries may progress or may be associated with complications, such as infection of the soft tissues around the wound cellulitis, infection of the bone osteomyelitis, infection of a joint septic arthritis, abscess, spread of bacteria into the bloodstream bacteremia/septicemia, chronic infection, or development of a sinus tract. Sometimes these complications may occur despite apparent improvement in the PU/PI itself. The physician's involvement is integral whenever significant changes in the nature of the wound or overall resident condition are identified. Infections. A PU/PI infection may be acute or chronic. In acute wounds, the classic signs of inflammation, redness, edema, pain, increased exudate, and periwound surface warmth persist beyond the normal time frame of 3 to 4 days. In residents who are immunosuppressed, the signs of inflammation often are diminished or masked because of an ineffective immune response. Often the only observable symptom of infection is a complaint of pain. All chronic wounds, including PU/PIs, have bacteria. Since bacteria reside in non-viable tissue, debridement of this tissue and wound cleansing are important to reduce bacteria and avoid adverse outcomes such as sepsis. The first sign of infection may be a delay in healing and an increase in exudates. In a chronic wound, the signs of infection may be more subtle. Signs may include the following: increase in amount or change in characteristics of exudate, decolorization and friability of granulation tissue, undermining, abnormal odor, epithelial bridging, a bridge of epithelial tissue across a wound bed at the base of the wound, or sudden pain. The physician diagnosis of infections present in a PU/PI are based on resident history and clinical findings, such as a wound culture. Pus, slough, or necrotic tissue should not be cultured. Findings such as an elevated white blood cell count, bacteremia, sepsis, or fever may signal an infection related to a PU/PI area or a coexisting infection from a different source. The treatment of an infection will depend on the type of infection present. Pain. The assessment and treatment of a resident's pain are integral components of PU/PI prevention and management. Pain that interferes with movement and or affects mood may contribute to immobility and contribute to the potential for developing or for delayed healing or non-healing of an already existing PU/PI. Refer to Section 483.25K, F697, for additional guidance related to pain management. Dressings and treatments. Determination of the need for treatment for a PU/PI is based upon the individual practitioner's clinical judgment, facility protocols, and current professional standards of practice. Product selection should be based upon the relevance of the specific product to the identified PU/PIS characteristics, the treatment goals, and the manufacturer's recommendations for use. Current literature does not indicate significant advantages of any single specific product over another, but does confirm that not all products are appropriate for all PU/PIs. Wound characteristics should be assessed throughout the healing process to assure that the treatments and dressings being used are appropriate to the nature of the wound. Evidence-based practice suggests that PU/PI dressing protocols may use clean technique rather than sterile, but that appropriate sterile technique may be needed for those wounds that recently have been surgically debrided or repaired. Clean technique, also known as non-sterile, involves approved hand hygiene and glove use, maintaining a clean environment by preparing a clean field, using clean instruments, and preventing direct contamination of materials and supplies. Clean technique is considered most appropriate for long-term care. For residents who are not at high risk for infection, and for residents receiving routine dressings for chronic wounds such as venous ulcers or wounds healing by secondary intention with granulation tissue. A facility should be able to show that its treatment protocols are based upon current professional standards of practice and are in accord with the facility's policies and procedures as developed with the medical director's review and approval. Investigative protocol. Use the pressure ulcer critical element C pathway, along with the above interpretive guidelines when determining if the facility meets requirements to ensure a resident receives care consistent with professional standards of practice to prevent pressure. Ulcers/injuries development. Prevent the development of additional pressure ulcers/injuries, and to promote the healing of existing pressure ulcers/injuries. Summary of skin integrity, investigative procedure. Briefly review the comprehensive assessments, care plans, and physician orders to identify whether the facility has practices in place to identify if a resident is at risk for a pressure ulcer/injury, evaluate a resident for pressure ulcers/injuries, and intervene to prevent and or heal pressure ulcers. During this review, identify the extent to which the facility has developed and implemented interventions in accordance with ensuring a resident receives care consistent with professional standards of practice. If the resident has been in the facility for less than 14 days before completion of all the resident assessment instrument RI is required, review the baseline care plan, which must be completed within 48 hours to determine if the facility is providing appropriate care and services based on information available at the time of admission. This information will guide observations and interviews to be made to corroborate concerns identified. Key elements of noncompliance to site deficient practice at F686. The surveyor's investigation will generally show that the facility failed to do one or more of the following. Provide preventive care consistent with professional standards of practice to residents who may be at risk for development of pressure injuries, or provide treatment consistent with professional standards of practice to an existing pressure injury, or ensure that a resident did not develop an avoidable PU/PI. Note, to cite F686, it is not necessary to prove that a PU/PI developed. F686 can be cited when it has been determined that the provider failed to implement interventions to prevent the development of a PU/PI for a resident identified at risk. Deficiency categorization. In addition to actual or potential physical harm, always consider whether psychosocial harm has occurred when determining severity level. See Appendix P, Section Roman 4, E, Psychosocial Outcomes Severity Guide. Examples of severity level 4 noncompliance. Immediate jeopardy to resident health or safety include, but are not limited to: the facility failed to implement interventions to prevent PU/PI development for a resident who was admitted without PU/PIs, but who had multiple comorbidities and was totally dependent on staff, placing her at increased risk for PU/PI development, and failed to provide ongoing skin assessments for the same. Resident. The resident developed a stage Roman 4 pressure ulcer on her heel within 3 weeks of her admission. Development of avoidable stage Roman 4 pressure ulcers. As a result of the facility's noncompliance, permanent tissue damage, whether or not healing occurs, has compromised the resident, increasing the potential for serious complications including osteomyelitis and sepsis. Admitted with a stage Roman 4 pressure ulcers that has shown no signs of healing or shows signs of deterioration. As a result of the facility's noncompliance, a stage Roman 4 pressure ulcer has shown signs of deterioration or a failure to progress towards healing, with an increased potential for serious complications including osteomyelitis and sepsis. Stage Roman 3 or Roman 4 pressure ulcers with associated soft tissue or systemic infection. As a result of the facility's failure to assess or treat a resident with an infectious complication of a pressure ulcer, the resident developed stage Roman 3 or Roman 4 pressure ulcers with associated soft tissue or systemic infection. See discussion in guidelines and definitions that distinguishes colonization from infection. Extensive failure in multiple areas of pressure ulcer care. As a result of the facility's extensive noncompliance in multiple areas of pressure ulcer care, the resident developed recurrent or multiple avoidable stage Roman 3 or stage Roman 4 pressure ulcers. Examples of severity level 3 noncompliance actual harm that is not immediate jeopardy include, but are not limited to: the facility failed to provide necessary equipment, interventions, monitoring, and care for a resident who was identified to be at risk for developing PU/PIs due to the presence of contractures and had no PU/PIs upon admission. The facility's occupational therapist assessed the resident and provided a pressure-relieving device for use on the resident's left hand, which was to be in place at all times except when daily hygiene was being provided. The interventions were not recorded on the resident's care plan. During observation and interviews with staff, the assistive device was unable to be located and was not in use. This resulted in the resident developing a stage Roman 3 pressure injury. The development of recurrent or multiple avoidable stage Roman 2 pressure ulcers. As a result of the facility's noncompliance, the resident developed multiple or recurrent avoidable stage Roman 2 ulcers. Failure to implement the comprehensive care plan for a resident who has a pressure ulcer. As a result of a facility's failure to implement a portion of an existing plan related to pressure ulcer care, such as failure to provide for pressure redistribution or inappropriate treatment/dressing changes, a wound increased in size or failed to progress towards healing as anticipated, or the resident experienced untreated pain. Examples of severity level 2, noncompliance, no actual harm, with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to. The facility failed to assure that a resident with a healed stage, IPI in the coccyx area, received care to prevent the development of another PU/PI. The resident's care plan identified the use of a pressure-relieving device while up in the chair and repositioning every 30 minutes. During observations, the pressure-relieving device was not present on the seat of the wheelchair, but staff did reposition resident every 30 minutes. The device was available, but the staff person interviewed stated that, although it was usually on his wheelchair, it had not been placed that day. The resident's skin was intact and did not indicate the presence of a stage IPI based on observation, but the likelihood existed of a PU/PI developing as a result of not implementing care as identified in the plan of care. The facility failed to assess the skin condition of a resident who used continual oxygen for management of a chronic respiratory disease. The resident's oxygen was provided via nasal cannula, and the resident voiced discomfort and irritation with the tubing on his nares. There was a small reddened area where the tubing contacted the nares. The resident had mentioned this to the staff, but was not addressed, and the resident continued to experience discomfort and irritation. Failure to implement an element of the care plan for a resident who has a pressure ulcer, however, there has been no evidence of decline or failure to heal. Failure to recognize or address the potential for developing a pressure ulcer. As a result of the facility's noncompliance, staff failed to identify the risks, develop a plan of care, and or consistently implement a plan that has been developed to prevent pressure ulcers. Severity level 1. No actual harm with potential for minimal harm. The failure of the facility to provide appropriate care and services to prevent pressure ulcers/injuries or heal existing pressure ulcers/injuries is more than minimal harm. Therefore, severity level 1 does not apply for this regulatory requirement. Potential tags for additional investigation. During the investigation of F686, the surveyor may have determined that concerns may also be present with related outcome, process, and or structure requirements. The surveyor is cautioned to investigate these related requirements before determining whether noncompliance may be present. Some examples of related requirements that should be considered include Section 483.20, Resident Assessment, Section 483.2, One Comprehensive Person, Centered Care Planning, Section 483.24, Quality of Life, Section 483.30, Physician Services, Section 483.35, Nursing Services, Section 483.70, Administration, and Section 483.75, CAPI. Tag F687. Section 483.2, 5B2 Foot Care. To ensure that residents receive proper treatment and care to maintain mobility and good foot health, the facility must I. Provide foot care and treatment in accordance with professional standards of practice, including to prevent complications from the resident's medical condition and Roman 2, if necessary, assist the resident in making appointments with a qualified person and arranging for transportation to and from such appointments. Intent to ensure that the foot care provided is consistent with professional standards of practice, and to clarify that foot care includes treatment to prevent complications from conditions such as diabetes, peripheral vascular disease, or immobility. Also includes assisting the resident in making necessary appointments with qualified healthcare providers, such as podiatrists, and arranging for transportation to and from such appointments. Guidance facilities are responsible for providing the necessary treatment and foot care to residents. Treatment also includes preventive care to avoid podiatric complications in residents with diabetes and circulatory disorders who are prone to developing foot problems. Foot care that is provided in the facility, such as toenail clipping for residents without complicating disease processes, should be provided by staff who have received education and training to provide this service. Foot care and treatment must be provided within professional standards of practice and state scope of practice, as applicable. Residents requiring foot care who have complicating disease processes must be referred to qualified professionals, such as those listed as examples below. Facilities are also responsible for providing residents access to qualified professionals who can treat foot disorders by making necessary appointments and arranging transportation. Examples include podiatrist, doctor of medicine, and doctor of osteopathy. Foot disorders which may require treatment include, but are not limited to, corns, neuromas, calluses, hallux valgus bunions, digiti flexus hammertoe, heel spurs, and nail disorders. The facility is also responsible for assisting residents in making appointments and arranging transportation to obtain needed services. Facility staff must follow proper infection prevention practices for foot care equipment/devices, including but not limited to nail clippers, scalers, files, and burr tools. Facility staff must separate used or contaminated foot care equipment from clean equipment. Reusable medical devices, e.g., scalers, electronic nail file, and surgical instruments that are used on one resident must be cleaned and reprocessed disinfection or sterilization for use according to manufacturer's instructions prior to use on another resident. If the manufacturer does not provide such instructions, the device may not be suitable for multi-patient use. Recommendations for the cleaning, disinfection, and sterilization of medical devices are available in CDC's Guideline for Disinfection and Sterilization in Healthcare Facilities, 2008, available at https://www.cdc.gov/infection control/guidelines/disinfection/index.html. Please see guidance at section 483.80, Infection Control, for more information. Note, for purposes of this guidance, staff includes employees, the medical director, podiatrists, consultants, contractors, and volunteers. Staff would also include caregivers who provide care and services to residents on behalf of the facility, students in the facility's nurse aid training program, and students from affiliated academic institutions, including therapy, social, and activity programs. Probes for residents selected for review determine the following. According to the medical record, does the resident have a diagnosis or condition that poses a risk to foot health, e.g., diabetes, peripheral vascular disease, ingrown toenails? Does the comprehensive care plan adequately address the resident's risk with appropriate interventions? Observe residents' feet for lack of nail care, presence of calluses, and slash or other foot problems. Are residents with foot concerns seen either within the facility or community by a qualified foot care specialist? Do residents with mobility concerns have foot care concerns, and did the facility address these concerns? Are qualified healthcare providers available to see residents either in the facility or in the community? What preventive foot care do staff provide, and to what resident population? Are staff providing foot care to the resident when needed and ordered? Do staff maintain separation of clean and contaminated podiatry equipment? If no, refer to section 483.80, Infection Control F880. Tag F688. Section 483.2, 5C Mobility. Section 483.2, 5C1, the facility must ensure that a resident who enters the facility without limited range of motion does not experience reduction in range of motion unless the resident's clinical condition demonstrates that a reduction in range of motion is unavoidable. And Section 483.2, 5C2, a resident with limited range of motion receives appropriate treatment and services to increase range of motion and slash, or to prevent further decrease in range of motion. Section 483.2, 5C3, a resident with limited mobility receives appropriate services, equipment, and assistance to maintain or improve mobility with the maximum practicable independence, unless a reduction in mobility is demonstrably unavoidable. To review the impact of the physical, mental, and or psychosocial aspects of the resident's ability to maintain, improve, or prevent avoidable decline in range of motion and mobility, the surveyor must review the provision of care and services and implementation of interventions under this tag. Intent Section 483.2, 5C, to review the impact of the physical, mental, and or psychosocial aspects of the resident's ability to maintain, improve, or prevent avoidable decline in range of motion and mobility. The surveyor must review the provision of care and services and implementation of interventions under this tag. The intent of this regulation, F688, is to ensure that the facility provides the services, care, and equipment to assure that a resident maintains and or improves to his or her highest level of range of motion ROM and mobility, unless a reduction is clinically unavoidable, and a resident with limited range of motion and mobility maintains or improves function, unless reduced range of motion ROM/mobility is unavoidable based on the resident's clinical condition. Definitions Section 483.2, 5C. Active ROM means the performance of an exercise to move a joint without any assistance or effort of another person to the muscles surrounding the joint. Active assisted ROM means the use of the muscles surrounding the joint to perform the exercise, but requires some help from the therapist or equipment such as a strap. Mobility refers to all types of movement, including walking, movement in a bed, transferring from a bed to a chair, all with or without assistance, or moving about an area either with or without an appliance chair, walker, cane, crutches, etc. Muscle atrophy means the wasting or loss of muscle tissue. Passive ROM means the movement of a joint through the range of motion with no effort from the patient. Range of motion ROM means the full movement potential of a joint. Guidance Section 483.2, 5C Assessment for Range of Motion. The resident's comprehensive assessment should include and measure, as appropriate, a resident's current extent of movement of his or her joints and the identification of limitations, if any, and opportunities for improvement. The assessment should address whether the resident had previously received treatment and services for ROM, and whether he/she maintained his or her ROM, whether the ROM declined, and why the treatment/services were stopped. In addition, the assessment should address, for a resident with limited ROM, if he/she is not receiving services, the reason for the services to not be provided. The resident-specific, comprehensive assessment should identify individual risks which could impact the resident's range of motion, including, but not limited to, immobilization, e.g., bedfast, reclining in a chair or remaining seated in a chair/wheelchair. Neurological conditions causing functional limitations such as cerebral vascular accidents, multiple sclerosis, amyotrophic lateral sclerosis ALS, or Lou Gehrig's disease, Guillain-Barré syndrome, muscular dystrophy, or cerebral palsy, etc. Any condition where movement may result in pain, spasms, or loss of movement such as cancer, presence of pressure ulcers, arthritis, gout, late stages of Alzheimer's, contractures, dependence on mechanical ventilation, etc. Or clinical conditions such as immobilized limbs or digits because of injury, fractures, or surgical procedures including amputations. Assessment for mobility. The resident's comprehensive assessment should include and measure, as appropriate, a resident's current mobility status, the identification of limitations, if any, and opportunities for improvement. The MDS tool provides an assessment of the resident's ability for movement, including to and from the lying position, turning and side-to-side movement in bed, positioning of the body, transfers between surfaces such as to and from bed or chair, standing and walking. The resident's comprehensive assessment should also address whether the resident had previously received treatment and services for mobility, and whether he/she maintained his or her mobility, whether there was a decline, and why the treatment/services were stopped. In addition, the assessment should address, for a resident with limited mobility, if he/she is not receiving services, the reason for the services to not be provided. In addition, the resident-specific comprehensive assessment may identify individual risks which could impact the resident's mobility, including, but not limited to include the risk factors in the above section for range of motion. Care plan for ROM and/or mobility based upon the comprehensive assessment. The resident's care plan must include specific interventions, exercises and/or therapy to maintain or improve the ROM and mobility, or to prevent, to the extent possible, declines or further declines in the resident's ROM or mobility. The resident/representative must be included in the development of the restorative/rehabilitative care plan and provided the risks and benefits of the treatments. The comprehensive assessment must identify the current status of the resident's ROM and mobility capabilities, which must be used to develop interventions. The decision on what type of treatments includes an evaluation of the cognitive ability of the resident to be able to independently participate, whether the resident requires assistance due to medical condition or cognitive impairments or loss of ability to follow treatment. Instructions. Care plan interventions may be delivered through the facility's restorative program or, as ordered by the attending practitioner, through specialized rehabilitative services. Also see F825 for specialized rehabilitative services. Based upon the assessment, the care plan interventions must include the provision of necessary equipment and/or services necessary, adapting the environment to meet the needs of the resident, the use of equipment for bed mobility, walkers, canes, splints, braces, or other rehabilitative equipment as prescribed by the attending practitioner and/or as allowed by state law, and PT/OT. Examples of interventions may include treatments such as active, passive, and/or active-assisted ROM, muscle strengthening and stretching exercises, land and/or water-based activities, and/or specific physical and/or occupational therapies. The care plan must identify the type of treatments, frequency, and duration, as well as the measurable objectives and resident goals. The measurable objectives describe what the resident is expected to achieve, such as mobility goals, and/or ROM measurements to be achieved within a specific timeframe. This enables the interdisciplinary team to determine progress, including whether or not a resident has been able to maintain or increase range of motion and/or mobility. The facility must assure that the care plan provides for increasing and/or promoting independence to the extent clinically possible for the resident in the areas of both ROM and mobility. The care plan must address the presence of any contractures and interventions required, and any dependence and/or declines in mobility and ROM. In some clinical conditions, a decline/reduction in ROM and/or mobility may occur even though the facility provides ongoing assessment, appropriate resident-specific care planning, and provides ongoing preventive care and interventions. Documentation must reflect the attempts made by the facility to implement the care plan and revise interventions to address the changing needs of the resident. In this type of situation, declines in ROM/mobility may be considered to be unavoidable. The comprehensive assessment may identify specific resident risks for complications. Examples of complications that may be related to decreased ROM and/or mobility may include, but are not limited to, the following: pain, skin integrity issues, deconditioning including decreased muscle strength and atrophy, unsteady gait and balance resulting in potential falls and fractures, contractures, or respiratory and circulatory complications such as postural hypotension, deep vein thrombosis, pneumonia, potential urinary incontinence, bowel constipation/impactions, etc. The care plan should reflect the specific resident risks for complications and include interventions to mitigate, to the extent possible, the potential complications. If resident-specific complications related to a decrease in ROM/mobility are present, the care plan must provide interventions to address the complications. In some clinical conditions, a decline/reduction in ROM and/or mobility may occur even though the facility provides ongoing assessment, appropriate resident-specific care planning, and provides ongoing preventive care and interventions. Documentation must reflect the attempts made by the facility to implement the care plan and revise interventions to address the changing needs of the resident. In this type of situation, declines in ROM/mobility may be considered to be unavoidable. Administrative review: the facility must develop resident care policies in collaboration with the medical director, director of nurses, and as appropriate, physical/occupational therapy consultant. This includes policies on restorative/rehabilitative treatments/services based on professional standards of practice, including who may provide specific treatments and modalities according to applicable state law and/or practice acts. Refer to F841, Medical Director. These policies should also address equipment use, cleaning, and storage. In situations where the survey team has concerns related to patterns or widespread noncompliance within the requirements for mobility, please see guidance at Section 483.75, CAPI/CA. Key elements of noncompliance to site deficient practice at F688. The surveyor's investigation will generally show that the facility failed to provide treatment/services, equipment, supplies, and/or assistance to prevent an avoidable reduction of ROM and/or mobility in residents admitted with full ROM and/or mobility status, or increase ROM or mobility status, or prevent further avoidable reduction of ROM and mobility, or maintain or improve ROM/mobility. Investigative summary: use the positioning, mobility, and range of motion ROM critical element C pathway, along with the above interpretive guidelines when determining if the facility provides the necessary care and services to meet the resident's needs. Summary of procedure: briefly review the most recent comprehensive assessments, comprehensive care plan, and orders to identify whether the facility has assessed and developed an individualized care plan based on professional standards of practice, and provided by qualified, competent staff. During this review, identify the extent to which the facility has implemented interventions in accordance with the resident's needs, goals for care, and professional standards of practice, consistently across all shifts. This information will guide observations and interviews to be made in order to corroborate concerns identified. Note: always observe for visual cues of psychosocial distress and harm. See Appendix P, Guidance on Severity and Scope Levels and Psychosocial Outcome Severity Guide. Tag F689. Section 483.2, 5D Accidents. The facility must ensure that Section 483.2, 5D1 the resident environment remains as free of accident hazards as is possible, and Section 483.2, 5D2, each resident receives adequate supervision and assistance devices to prevent accidents. Intent 483.2, 5D. The intent of this requirement is to ensure the facility provides an environment that is free from accident hazards over which the facility has control, and provides supervision and assistive devices to each resident to prevent avoidable accidents. This includes identifying hazardous and risks, evaluating and analyzing hazardous and risks, implementing interventions to reduce hazardous and risks, and monitoring for effectiveness and modifying interventions when necessary. Definitions 483.25d. Definitions are provided to clarify terms related to providing supervision and other interventions to prevent accidents. Accident refers to any unexpected or unintentional incident which results or may result in injury or illness to a resident. This does not include other types of harm, such as adverse outcomes that are a direct consequence of treatment or care that is provided in accordance with current professional standards of practice, e.g., drug side effects or reaction. Avoidable accident means that an accident occurred because the facility failed to identify environmental hazards and or assess individual resident risk of an accident, including the need for supervision and or assistive devices, and or evaluate and analyze the hazards and risks and eliminate them, if possible, or, if not possible, identify and implement measures to reduce the hazards risks as much as possible, and or implement interventions, including adequate supervision and assistive devices, consistent with a resident's needs, goals, care plan, and current professional standards of practice in order to eliminate the risk, if possible, and, if not, reduce the risk of an accident, and or monitor the effectiveness of the interventions and modify the care plan as necessary, in accordance with current professional standards of practice. Unavoidable accident means that an accident occurred despite sufficient and comprehensive facility systems designed and implemented to identify environmental hazards and individual resident risk of an accident, including the need for supervision, and evaluate and analyze the hazards and risks and eliminate them, if possible, and, if not possible, reduce them as much as possible. Implement interventions, including adequate supervision, consistent with the resident's needs, goals, plan of care, and current professional standards of practice in order to eliminate the risk, if possible, and if not, reduce the risk of an accident, and monitor the effectiveness of the interventions and modify the interventions as necessary, in accordance with current professional standards of practice. Assistance device or assistive device refers to any item, e.g., fixtures such as handrails, grab bars, and mechanical devices equipment such as standalone or overhead transfer lifts, canes, wheelchairs, and walkers, etc. that is used by or in the care of a resident to promote, supplement, or enhance the resident's function and or safety. Note, the currently accepted nomenclature refers to assistive devices. Although the term assistance devices is used in the regulation, the guidance provided in this document will refer to assistive devices. These terms mean the same thing and may be used interchangeably. Environment refers to any environment or area in the facility that is frequented by or accessible to residents, including but not limited to the residents' rooms, bathrooms, hallways, dining areas, lobby, outdoor patios, therapy areas, and activity areas. Fall refers to unintentionally coming to rest on the ground, floor, or other lower level, but not as a result of an overwhelming external force, e.g., resident pushes another resident. An episode where a resident lost his or her balance and would have fallen if not for another person or if he or she had not caught him herself is considered a fall. A fall without injury is still a fall. Unless there is evidence suggesting otherwise, when a resident is found on the floor, a fall is considered to have occurred. Refer to Resident Assessment Instrument User's Manual. Version 3.0, Chapter 3, page J27. Hazards refer to elements of the resident environment that have the potential to cause injury or illness. Hazards over which the facility has control are those hazards in the resident environment where reasonable efforts by the facility could influence the risk for resulting injury or illness. Free of accident hazards, as is possible, refers to being free of accident hazards over which the facility has control. Position change alarms are alerting devices intended to monitor a resident's movement. The devices emit an audible signal when the resident moves in a certain way. Types of position change alarms include chair and bed sensor pads, bedside alarmed mats, alarms clipped to a resident's clothing, seatbelt alarms, and infrared beam motion detectors. Point 1 position change alarms do not include alarms intended to monitor for unsafe wandering, such as door or elevator alarms. Risk refers to any external factor, facility characteristic, e.g., staffing or physical environment, or characteristic of an individual resident that influences the likelihood of an accident. Supervision/adequate supervision refers to an intervention and means of mitigating the risk of an accident. Facilities are obligated to provide adequate supervision to prevent accidents. Adequate supervision is determined by assessing the appropriate level and number of staff required, the competency and training of the staff, and the frequency of supervision needed. This determination is based on the individual resident's assessed needs and identified hazards in the resident environment. Adequate supervision may vary from resident to resident and from time to time for the same resident. Guidance Overview Section 483.2 5D. Numerous and varied accident hazards exist in everyday life. Not all accidents are avoidable. The frailty of some residents increases their vulnerability to hazards in the resident environment and can result in life-threatening injuries. It is important that all facility staff understand the facility's responsibility, as well as their own, to ensure the safest environment possible for residents. The facility is responsible for providing care to residents in a manner that helps promote quality of life. This includes respecting residents' rights to privacy, dignity, and self-determination, and their right to make choices about significant aspects of their life in the facility. An effective way for the facility to avoid accidents is to develop a culture of safety and commit to implementing systems that address resident risk and environmental hazards to minimize the likelihood of accidents. A facility with a commitment to safety acknowledges the high-risk nature of its population and setting, develops effective communication, including a reporting system that does not place blame on the staff member for reporting resident risks and environmental hazards, engages all staff, residents, and families in training on safety, and promotes ongoing discussions about safety with input from staff at all levels of the organization, as well as residents and families. Encourages the use of data to identify potential hazards, risks, and solutions related to specific safety issues that arise. Directs resources to address safety concerns, and demonstrates a commitment to safety at all levels of the organization. A systems approach. Processes in a facility's interdisciplinary systematic approach may include identification of hazards, including inadequate supervision, and a resident's risks of potentially avoidable accidents in the resident environment. Evaluation and analysis of hazards and risks, implementation of individualized, resident-centered interventions, including adequate supervision and assistive devices to reduce individual risks related to hazards in the environment, and monitoring for effectiveness and modification of interventions when necessary. A key element of a systematic approach is the consistent application of a process to address identified hazards and/or risks. Risks may pertain to individual residents, groups of residents, or the entire facility. Hazards may include, but are not limited to, aspects of the physical plant, equipment, and devices that are defective or are not used properly per manufacturer's specifications, are disabled/removed, or are not individually adapted or fitted to the resident's needs. An effective system not only proactively identifies environmental hazards and the resident's risk for an avoidable accident, but also evaluates the resident's need for supervision. Identifying and addressing risks, including the potential for accidents, includes consideration of the environment, the resident's risk factors, and the need for supervision, care, and assistive devices. This will allow the facility to communicate information about observed hazards, identify resident-specific information, develop and implement an individualized care plan based on the resident assessment instrument, RI, to address each resident's needs and goals, and to monitor the results of the planned interventions. The care plan should strive to balance the resident's wishes with the potential impact on the safety of the resident and other residents. A systematic approach enables the facility to evaluate safety throughout its environment and among all staff, and make appropriate adjustments in training and competency testing as required. Each resident and their family members or representatives should be aware of the risks and potential hazards related to falls and of various devices used to reduce fall risk. Furthermore, a systematic approach enables leadership and direct care staff to work together to revise policies and procedures based on feedback from workers who are most familiar with the residents and care processes. Effective facility systems address how to communicate the observations of hazards, record resident-specific information, and monitor data related to care processes that potentially lead to accidents. Identification of hazards and risks. Identification of hazards and risks is the process through which the facility becomes aware of potential hazards in the resident environment and the risk of a resident having an avoidable accident. All staff, e.g., professional, administrative, maintenance, etc., are to be involved in observing and identifying potential hazards in the environment, while taking into consideration the unique characteristics and abilities of each resident. The facility should make a reasonable effort to identify the hazards and risk factors for each resident. Various sources provide information about hazards and risks in the resident environment. These sources may include, but are not limited to, quality assessment and assurance CA activities, environmental rounds, MDS/CA data, medical history and physical exam, facility assessment as required in F838, and individual observation. This information is to be documented and communicated across all disciplines. Evaluation and analysis. Evaluation and analysis is the process of examining data to identify specific hazards and risks and to develop targeted interventions to reduce the potential for accidents. Interdisciplinary involvement is a critical component of this process. Analysis may include, for example, considering the severity of hazards, the immediacy of risk, and trends such as time of day, location, etc. Both the facility-centered and resident-directed approaches include evaluating hazards and accident risk data, which includes prior accidents/incidents, analysis to identify the root causes of each hazard and accident risk, and identifying or developing interventions based on the severity of the hazards and immediacy of risk. Evaluations also look at trends such as time of day, location, etc. Implementation of interventions. Implementation refers to using specific interventions to try to reduce a resident's risks from hazards in the environment. The process includes communicating the interventions to all relevant staff, assigning responsibility, providing training as needed, documenting interventions, e.g., plans of action developed through the QAA committee or care plans for the individual resident, and ensuring that the interventions are put into action. Interventions are based on the results of the evaluation and analysis of information about hazards and risks, and are consistent with professional standards, including evidence-based practice. Development of interim safety measures may be necessary if interventions cannot immediately be implemented fully. Facility-based interventions may include, but are not limited to, educating staff, repairing the device/equipment, and developing or revising policies and procedures. Resident-directed approaches may include implementing specific interventions as part of the plan of care, supervising staff and residents, etc. Facility records document the implementation of these interventions. Monitoring and modification. Monitoring is the process of evaluating the effectiveness of care plan interventions. Modification is the process of adjusting interventions as needed to make them more effective in addressing hazards and risks. Monitoring and modification processes include ensuring that interventions are implemented correctly and consistently, evaluating the effectiveness of interventions, modifying or replacing interventions as needed, and evaluating the effectiveness of new interventions. An example of facility-specific modification is additional training of staff when equipment has been upgraded, while a resident-specific modification is revising the care plan to reflect the resident's current condition and risk factors that may have changed since the previous assessment. For example, a facility implements a position change alarm for a newly admitted resident with a history of falls. After completing a comprehensive assessment of the resident, facility staff identify the resident's routines and patterns, remove the alarm, and implement more individualized interventions that address the actual cause of why a resident may be changing position, e.g. has been in one position too long, or is trying to reach for a personal item which could lead to a fall. Supervision. Supervision is an intervention and a means of mitigating accident risk. Facilities are obligated to provide adequate supervision to prevent accidents. Adequacy of supervision is defined by type and frequency, based on the individual resident's assessed needs and identified hazards in the resident environment. Adequate supervision may vary from resident to resident and from time to time for the same resident. Devices such as position change alarms may help to monitor a resident's movement temporarily, but do not eliminate the need for adequate supervision. The resident environment may contain temporary hazards, e.g., construction, painting, housekeeping activities, etc. that warrant additional supervision or alternative measures, such as barriers, to prevent access to affected areas of the resident environment. Adequate supervision to prevent accidents is enhanced when the facility accurately assesses a resident or the resident environment to determine whether supervision to avoid an accident is necessary, or determines that supervision of the resident was necessary, and provides supervision based on the individual resident's assessed needs and the risks identified in the environment. Resident smoking. Some facilities permit residents to smoke tobacco products. In these facilities, assessment of the resident's capabilities and deficits determines whether or not supervision is required. If the facility identifies that the resident needs assistance and supervision for smoking, the facility includes this information in the resident's care plan and reviews and revises the plan periodically as needed. The facility may designate certain areas for resident smoking. The facility must ensure precautions are taken for the resident's individual safety, as well as the safety of others in the facility. Such precautions may include smoking only in designated areas, supervising residents whose assessment and care plans indicate a need for assisted and supervised smoking, and limiting the accessibility of matches and lighters by residents who need supervision when smoking for safety reasons. Smoking by residents when oxygen is in use is prohibited, and any smoking by others near flammable substances is also problematic. Additional measures may include informing all visitors of smoking policies and hazards. Guidance concerning resident smoking regulations can be found in NFPA 101, 2012 edition, the Life Safety Code at 19.7.4, smoking, including requirements for signage, prohibiting smoking by residents classified as not responsible, and disposal of smoking materials. Electronic cigarettes. While electronic cigarettes, e-cigs, or vapor pens are not considered smoking devices, and their heating element does not pose the same dangers of ignition as regular cigarettes, they are not without risk. A review of literature by the Centers for Disease Control and Prevention (CDC), Food and Drug Administration (FDA), and Federal Emergency Management Agency (FEMA) shows that as electronic cigarette use has increased, risks associated with their use have also increased. Risks and concerns include potential health effects for the smoker, such as respiratory illness or lung injury, which may present with symptoms of breathing difficulty, shortness of breath, chest pain, mild to moderate gastrointestinal illness, fever, or fatigue. Secondhand aerosol exposure, nicotine overdose by ingestion or contact with the skin, and explosion or fire caused by the battery. Because these devices are not without risk and have accidents associated with them, facilities have a responsibility to oversee their use and provide supervision to maintain an accident-free environment. In August 2016, the World Health Organization recommended that electronic cigarettes be banned indoors or where smoking is prohibited because of the second-hand exposure to potentially toxic chemicals, and many local and state jurisdictions have begun enacting laws that prohibit electronic cigarette use everywhere that smoking is banned. Facilities that decide, in accordance with state and local laws, to allow e-cigarette use should develop and implement policies for safe use of e-cigarettes, along with policies for traditional cigarettes. Policies should include where e-cigarettes can be used and how to handle the devices, batteries, and refill cartridges. The FDA has published recommendations for safe handling at the following link: https://www.fda.gov/tobacco products/labeling/products ingredients components/UCM 5393/62 HTM-blue. Residents who wish to use e-cigarettes should be assessed for their ability to safely handle the device. Concerns related to resident safety with use of e-cigarettes should be investigated using the guidance at 42 CFR 483.25D, F689, Accidents and Supervision. Surveyors should also consider how facilities balance resident safety with a resident's right to use these devices, while also considering the rights of residents who do not want to be exposed to second-hand aerosol. For concerns related to resident choice to use e-cigarettes in facilities where the devices are permitted, and for residents who do not wish to be exposed to second-hand aerosol, surveyors should use guidance at 42 CFR 483.10C3, Right to Participate in Planning Care, F553 and 483.10F, F561, Self-Determination. For concerns about a facility's policies for e-cigarettes, use F926, 483.90I5, Smoking Policies. Resident-to-resident altercations. Note: a resident-to-resident altercation should be reviewed as a potential situation of abuse, which should be investigated under the guidance for 42 CFR Section 483.12, F600. The surveyor should not automatically assume that abuse did not occur for a resident identified as having a cognitive impairment or mental disorder, as it does not preclude the resident from deliberate willful or non-accidental actions. Willful, as defined at Section 483.5 and as used in the definition of abuse, means the individual must have acted deliberately, not that the individual must have intended to inflict injury or harm. Even though a resident may have a cognitive impairment, he/she could still commit a willful act. If during the investigation of an allegation of abuse, it is determined that the action was not willful, the surveyor must investigate whether the facility is in compliance with the requirement to maintain an environment as free of accident hazards as possible, and that each resident receives adequate supervision using guidance at this tag, F689. Accidents. It is important that a facility take reasonable precautions, including providing adequate supervision, when the risk of resident-to-resident altercation is identified or should have been identified. Certain situations or conditions may increase the potential for such altercations, including, but not limited to, a history of aggressive behaviors including striking out, verbal outbursts, or negative interactions with other residents, and/or Behavior that may disrupt or annoy others, such as constant verbalization, e.g., crying, yelling, calling out for help, making negative remarks, restlessness, repetitive behaviors, taking items that do not belong to them, going into other residents' rooms, drawers, or closets, and undressing in inappropriate areas. Although these behaviors may not be aggressive in nature, they may precipitate a negative response from others, resulting in verbal, physical, and or emotional harm. The facility is responsible for identifying residents who have a history of disruptive or intrusive interactions, or who exhibit other behaviors that make them more likely to be involved in an altercation. The facility should identify the factors, e.g., pain, specific triggers in the environment, etc., that increase the risks associated with individual residents, including those that could trigger an altercation. The interdisciplinary team reviews the assessment along with the resident and or his or her representative in order to address the underlying reasons for the behavioral manifestations and to identify interventions to try to prevent altercations. The interventions listed below include supervision and other actions that could address potential or actual negative interactions. Evaluating staffing levels to ensure adequate supervision if it is adequate. It is meeting the resident's needs. Refer to F725, Section 483.3, 5A12, to evaluate staffing levels for any nursing services not related to behavioral health care or dementia care, and F741, Section 483.40, for any staff caring for residents with dementia. Mental and psychosocial disorder, substance use disorder, or a history of trauma and or post-traumatic stress disorder. Evaluating staffing assignments to ensure consistent staff who are more familiar with the resident and who thus may be able to identify changes in a resident's condition and behavior. Providing safe supervised areas for unrestricted movement, eliminating or reducing underlying causes of distressed behavior such as boredom. And pain, monitoring environmental influences such as temperatures, lighting, and noise. Levels, and ongoing staff training, competencies, and supervision, including how to approach a resident who may be agitated, combative, verbally or physically aggressive, or anxious, and how and when to obtain assistance in managing a resident with behavior symptoms. Refer to F726, Section 483.3, 5A34C, to evaluate staff competency for any nursing services not related to behavioral health care or dementia care, and F741. Section 483.40, for any staff caring for residents with dementia, mental and psychosocial disorder, substance use disorder, or a history of trauma and or post-traumatic stress disorder. Risks and environmental hazards. This section discusses common, but not all, potential risks and hazards found in the resident environment. Note, the information included in the following sections is based on current professional standards of practice or best practice models as described in the literature. The physical plant, devices, and equipment described in this section may not be hazards by themselves, but can become hazardous when a vulnerable resident interacts with them. Some temporary hazards in the resident environment can affect most residents who have access to them, e.g., construction, painting, and housekeeping activities. Other situations may be hazardous only for certain individuals, e.g., accessible smoking materials. In order to be considered hazardous, an element of the resident environment must be accessible to a vulnerable resident. Resident vulnerability is based on risk factors including the individual resident's functional status, medical condition, cognitive abilities, mood, and health treatments, e.g., medications. Resident vulnerability to hazards may change over time. Ongoing assessment helps identify when elements in the environment pose hazards to a particular resident. Certain sharp items, such as scissors, kitchen utensils, knitting needles, or other items, may be appropriate for many residents but hazardous for others with cognitive impairments. Handrails, assistive devices, and any surface that a resident may come in contact with may cause injury. If the surface is not in good condition, free from sharp edges or other hazards, or not installed properly. Improper actions or omissions by staff can create hazards in the physical plant, e.g., building and grounds, environment and slash, or with devices and equipment. Examples of such hazards might include fire doors that have been propped open, disabled locks or latches, non-functioning alarms, buckled or badly torn carpets, cords on floors, irregular walking surfaces, improper storage and access to toxic chemicals, exposure to unsafe heating unit surfaces, and unsafe water temperatures. Other potential hazards may include furniture that is not appropriate for a resident, e.g., chairs or beds that are not the proper height or width for the resident to transfer to and from safely or unstable, as to present a fall hazard, and lighting that is either inadequate or so intense as to create glare. Devices for resident care, such as pumps, ventilators, and assistive devices, may be hazardous when they are defective, disabled, or improperly used, i.e., used in a manner that is not per manufacturer's recommendations or current professional standards of practice. Resident vulnerabilities. The responsibility to respect a resident's choices is balanced by considering the resident's right to direct the care they receive with the potential impact of these choices on their well-being, other residents, and on the facility's obligation to protect residents from harm. The facility has a responsibility to educate a resident, family, and staff regarding significant risks related to a resident's choices. When a resident's choice poses some risk, staff should work with the resident to understand reasons for the choice and discuss options for the facility to honor the choice. For example, a resident may express a desire to use a cane instead of a walker or wheelchair in order to maintain dignity and self-esteem. This preference should be discussed to review potential positive and negative consequences of possible courses of action, including potential negative consequences that may result from preventing the choice, and to find ways to develop a care plan in which staff honor the choice while mitigating risks. For resources on care planning to mitigate risk, see a process for care planning resident choice at https://www.pwnetworknet/wpcontent/uploads/2016/10/process for care planning for resident choice. PDF. Verbal consent or signed consent/waiver forms do not eliminate a facility's responsibility to protect a resident from an avoidable accident, nor does it relieve the provider of its responsibility to assure the health, safety, and welfare of its residents. While federal regulations affirm the resident's right to participate in care planning and to refuse treatment, the regulations do not create the right for a resident or representative to demand the facility use specific medical interventions or treatments that the facility deems inappropriate. The regulations hold the facility ultimately accountable for the resident's care and safety. Falls and unsafe wandering/elopement are of particular concern. The following section reviews these issues along with some common potential hazards. Falls. The MDS defines a fall as unintentionally coming to rest on the ground, floor, or other lower level, but not as a result of an overwhelming external force, e.g., resident pushes another resident. An episode where a resident lost his or her balance and would have fallen if not for another person or if he or she had not caught him/herself is considered a fall. A fall without injury is still a fall. Unless there is evidence suggesting otherwise, when a resident is found on the floor, a fall is considered to have occurred. Note, challenging a resident's balance and training him/her to recover from loss of balance is an intentional therapeutic intervention. The losses of balance that occur during supervised therapeutic interventions are not considered a fall. Some factors that may result in resident falls include, but are not limited to, environmental hazards, such as wet floors, poor lighting, incorrect bed height and/or width, or improperly fitted or maintained wheelchairs. unsafe or absent footwear and loose or improperly worn clothing, underlying chronic medical conditions such as arthritis, heart failure, anemia, and neurological disorders. Acute change in conditions such as fever, infection, delirium, medication side effects, orthostatic hypotension, lower extremity weakness, balance disorders, poor grip strength, functional impairments, difficulty rising from a chair, getting on or off toilet, etc., gait disorders, cognitive impairment, visual deficits, pain, and incontinence. Older persons have both a high incidence of falls and a high susceptibility to injury. 2 Serious potential consequences of falls include physical injuries, pain, increased risk of death, impaired function, fear of falling, and self-imposed limitations on activities leading to social isolation. 3 Evaluation of all of the causal factors leading to a resident fall assists the facility in developing and implementing relevant, consistent, and individualized interventions to prevent future occurrences. Proper actions following a fall include ascertaining if there were injuries and providing treatment as necessary, determining what may have caused or contributed to the fall, including ascertaining what the resident was trying to do before he or she fell, addressing the risk factors for the fall such as the resident's medical conditions, facility environment issues, or staffing issues, and revising the resident's plan of care and or facility practices as needed to reduce the likelihood of another fall. Note, a fall by a resident does not necessarily indicate a deficient practice, because not every fall can be avoided. Position change alarms. Facilities often implement position change alarms as a fall prevention strategy or in response to a resident fall. The alarms are designed to alert staff that the resident has changed position, increasing the risk for falling. However, the efficacy of alarms to prevent falls has not been proven, and a study of hospitalized patients concluded these devices may only alert staff that a fall has already occurred. The same study also noted false alarms are a common problem leading to alarm fatigue, where staff no longer respond to the sound of an alarm. 4 A study on bed exit alarms concluded the alarms are not a substitute for staff assisting residents, and bed exit alarms may not always function reliably for residents who weigh less than 100 pounds or who are restless. 5 Individual facility efforts to reduce use of alarms have shown falls actually decrease when alarms are eliminated and replaced with other interventions such as purposeful checks to proactively address resident needs, adjusting staff to cover times of day when most falls occur, assessing resident routines, and making individualized environmental or care changes that suit each resident. 6 For example, brighter lighting might help a resident with macular degeneration ambulate more easily in his or her room, but would cause glare and make walking more difficult for a resident with cataracts. 7 Facilities must implement comprehensive, resident-centered fall prevention plans for each resident at risk for falls or with a history of falls. While position change alarms are not prohibited from being included as part of a plan, they should not be the primary or sole intervention to prevent falls. If facility staff choose to implement alarms, they should document their use aimed at assisting the staff to assess patterns and routines of the resident. Use of these devices, like any care planning intervention, must be based on assessment of the resident and monitored for efficacy on an ongoing basis. Position change alarms have been used to monitor a resident's movement in chairs or beds, etc. However, there must be sufficient staff and supervision to meet the resident's needs, and staff must be vigilant in order to respond to alarms in a timely manner. Alarms do not replace necessary supervision. Facilities must take steps to identify issues that place the resident at risk for falls and implement approaches to address those risks in a manner that enables the resident to achieve or maintain his or her highest practicable physical, mental, and psychosocial well-being. Wandering and elopement. Wandering is random or repetitive locomotion. This movement may be goal-directed, e.g., the person appears to be searching for something such as an exit, or may be non-goal-directed or aimless. Non-goal-directed wandering requires a response in a manner that addresses both safety issues and an evaluation to identify root causes to the degree possible. Moving about the facility aimlessly may indicate that the resident is frustrated, anxious, bored, hungry, or depressed. Goal-directed wandering may fulfill a resident's need for exercise or provide sensory stimulation. This goal-directed wandering should also require staff supervision and a facility response to address safety issues. Wandering may become unsafe when a resident becomes overly tired or enters an area that is physically hazardous or that contains potential safety hazards, e.g., chemicals, tools, and equipment, etc. Entering into another resident's room may lead to an altercation or contact with hazardous items. Unsafe wandering can be associated with an increased risk for falls and injuries. While wander, door, or building alarms can help to monitor a resident's activities, staff must be vigilant in order to respond to them in a timely manner. Alarms do not replace necessary supervision and require scheduled maintenance and testing to ensure proper functioning. A situation in which a resident leaves the premises or a safe area without the facility's knowledge and supervision, if necessary, would be considered an elopement. This situation represents a risk to the resident's health and safety and places the resident at risk of heat or cold exposure, dehydration and or other medical complications, drowning, or being struck by a motor vehicle. Facility policies that clearly define the mechanisms and procedures for assessing or identifying, monitoring and managing residents at risk for elopement can help to minimize the risk of a resident leaving a safe area without the facility's awareness and or appropriate supervision. In addition, the resident at risk should have interventions in their comprehensive plan of care to address the potential for elopement. Furthermore, a facility's disaster and emergency preparedness plan should include a plan to locate a missing resident. Safety for residents with substance use disorder (SUD). Residents with a history of substance use disorder may be at increased risk for leaving the facility without notification and or for illegal or prescription drug overdose if the resident continues using substances while residing in the nursing home. Residents with a history of substance use disorder should be assessed for these risks, and care plan interventions should be implemented to ensure the safety of all residents. For example, residents with substance use disorder may leave the facility to satisfy an addiction to alcohol, prescription drugs, or illegal substances. Care planning interventions should address this risk by providing appropriate diversions for residents and encouraging residents to seek out facility staff to discuss their plan of care, including discharge planning, rather than leaving to seek out substances which could endanger the resident's health and or safety. The facility should advise residents of the risks of leaving the facility to seek out substances and or early, unplanned discharge, and provide appropriate referrals and discharge instructions whenever possible. Facilities are responsible for identifying and assessing a resident's risk for leaving the facility without notification to staff and developing interventions to address this risk. A situation in which a resident with decision-making capacity leaves the facility intentionally would generally not be considered an elopement unless the facility is unaware of the resident's departure and or whereabouts. A resident who leaves the facility prior to his or her planned discharge, but with facility knowledge of the departure and despite facility efforts to explain the risks of leaving, would be leaving against medical advice (AMA). Documentation in the medical record should show that facility staff attempted to provide other options to the resident and informed the resident of potential risks of leaving AMA. Documentation should also identify the time the facility became aware of the resident leaving the facility. Note, This guidance is not intended to restrict a resident's ability to leave and return to the facility in accordance with the resident's medical orders, care plan, facility policy, and Section 483.10C6, F3, and F8. Additionally, residents with SUD may try to continue using substances during their stay in the nursing home. Facility staff should assess the resident for the risk for substance use in the facility and have knowledge of signs and symptoms of possible substance use, such as frequent leaves of absence with or without facility knowledge, odors, new needle marks, and changes in resident behavior such as unexplained drowsiness, slurred speech, lack of coordination, and mood changes, particularly after interaction with visitors or absences from the facility. Efforts to prevent substance use may include providing substance use treatment services, such as behavioral health services, medication-assisted treatment MAT, Alcoholics/Narcotics Anonymous meetings, working with the resident and the family, if appropriate, to address goals related to their stay in the nursing home, and increased monitoring and supervision. When investigating overdose occurrences, surveyors should evaluate whether the facility assessed and identified that the resident who experienced an overdose had a history of substance use and was at risk for using substances which could lead to an overdose while in the facility. If there is a history of SUD, the resident's comprehensive care plan should contain interventions, if appropriate, to prevent substance use in the facility as well as interventions for when substance use is suspected or identified. Facility staff should implement care plan interventions, which should include increased monitoring and supervision of the resident, increased supervision of visitors, and notification of the resident's physician or non-physician practitioner. For example, a resident displays changes in behavior or unexplained lethargy after his or her visitor's leave, or other residents report observing the use of substances. When substance use is suspected, in the facility or upon return from an absence from the facility which could lead to overdose, facility staff should implement the care plan interventions. Facilities and surveyors should be aware that relapses of substance use can be common in individuals with SUD and may result in a drug overdose. Facilities that accept residents with SUD are typically doing so to treat a medical-related issue and are not expected to fully cure individuals with SUD of their underlying addictive behaviors while in the facility. However, facility staff should be prepared to address emergencies related to substance use by providing increased monitoring, maintaining and having knowledge of administering opioid reversal agents like naloxone, initiating CPR as appropriate, and contacting emergency medical services as soon as possible. The United States Surgeon General has recommended that naloxone be kept on hand where there is a risk for an opioid overdose. Information on safe naloxone administration may be found on this document developed by the Substance Abuse and Mental Health Administration SAMHSA, https://storsamsagov/system/files/SMA18 to 4742, PDF. Note: surveyors should be aware that the occurrence of an overdose does not automatically mean that non-compliance exists. As noted above, drug overdoses can be expected with individuals with SUD, and facilities are not expected to fully cure these residents of their underlying disease or SUD. For example, a resident with a known history of SUD and drug-seeking behaviors when off-site returns from an absence from the facility. Evidence shows the facility took steps to increase its monitoring of the resident, and despite this effort, the resident overdosed between checks or immediately upon return before increased monitoring had begun. Additionally, the facility attempted CPR and administered naloxone. This example demonstrates a negative outcome. However, noncompliance with this requirement does not exist. Conversely, if the same resident returns from an absence, but the facility did not take steps to increase monitoring, noncompliance with the requirements at Section 483.2, 5D may exist due to failure to identify the resident's risk for overdose and implement interventions. Physical plant hazards. Note: refer to guidance at 483.71 F 838 for facility responsibilities regarding the facility's physical environment. Supervision and or containment of hazards are needed to protect residents from harm caused by environmental hazards. Examples of such hazards can range from common chemical cleaning materials to those caused by adverse water temperatures or improper use of electrical devices. Chemicals and toxins, various materials in the resident environment, can pose a potential hazard to residents. Hazardous materials can be found in the form of solids, liquids, gases, mists, dusts, fumes, and vapors. The routes of exposure for toxic materials may include inhalation, absorption, or ingestion. For a material to pose a safety hazard to a resident, it must be toxic, caustic, or allergenic, accessible and available in a sufficient amount to cause harm. Toxic materials that may be present in the resident environment are unlikely to pose a hazard unless residents have access or are exposed to them. Some materials that would be considered harmless when used as designed could pose a hazard to a resident who accidentally ingests or makes contact with them. Examples of materials that may pose a hazard to a resident include, but are not limited to, chemicals used by the facility staff in the course of their duties, e.g., housekeeping chemicals, cleaning and sanitizing agents and chemicals, or other materials brought into the resident environment by staff, other residents, or visitors. Drugs and therapeutic agents, plants and other natural materials found in the resident environment or in the outdoor environment, e.g., poison ivy. One source of information concerning the hazards of a material that a facility may obtain is the Safety Data Sheet SDS.8. The Occupational Safety and Health Administration, OSHA, requires employers to have a SDS available for all hazardous materials that staff use, while performing their duties. 9 SDSs are available online for numerous chemicals and non-toxic materials and should be reviewed carefully to determine if the material is toxic and poses a hazard. Poison control centers are another source of information for potential hazards, including non-chemical hazards such as plants. Note: toxicological profiles for a limited number of hazardous materials are accessible on the Agency for Toxic Substances and Disease Registry website at http://www.cdc.gov/. Water temperature. Water may reach hazardous temperatures in hand sinks, showers, tubs, and any other source or location where hot water is accessible to a resident. Burns related to hot water/liquids may also be due to spills and or immersion. Many residents in long-term care facilities have conditions that may put them at increased risk for burns caused by scalding. These conditions include decreased skin thickness, decreased skin sensitivity, peripheral neuropathy, decreased agility, reduced reaction time, decreased cognition or dementia, decreased mobility, and decreased ability to communicate. 10. The degree of injury depends on factors including the water temperature, the amount of skin exposed, and the duration of exposure. Some states have regulations regarding allowable maximum water temperature. Table 1 illustrates damage to skin in relation to the temperature of the water and the length of time of exposure. 11. Table 1. Time and temperature relationship to serious burns. Water temperature. Section 155, F. 68C. Section 148, F. 64C. Section 140, F. 60C. Section 133, F. 56C. Section 127, F. 52C. Section 124, F. 51C. Section 120, F. 48C. Section 100, F. 37 C. Time required for a third-degree burn to occur 1 sec, 2 sec, 5 sec, 15 sec, 1 min, 3 min, 5 min. Safe temperatures for bathing. C note. Note, burns can occur even at water temperatures below those identified in the table, depending on an individual's condition and the length of exposure. Based upon the time of the exposure and the temperature of the water, the severity of the harm to the skin is identified by the degree of burn, as follows. 12. First-degree burns involve the top layer of skin, e.g., minor sunburn. These may present as red and painful to touch, and the skin will show mild swelling. Second-degree burns involve the first 2 layers of skin. These may present as deep reddening of the skin, pain, blisters, glossy appearance from leaking fluid, and possible loss of some skin. Third-degree burns penetrate the entire thickness of the skin and permanently destroy tissue. These present as loss of skin layers. Often painless pain may be caused by patches of first- and second-degree burns surrounding third-degree burns and dry, leathery skin. Skin may appear charred or have patches that appear white, brown, or black. Electrical safety. Any electrical device, whether or not it needs to be plugged into an electric outlet, can become hazardous to the residents through improper use or improper maintenance. Electrical equipment, such as electrical cords, can become tripping hazards. Halogen lamps or heat lamps can cause burns or fires if not properly installed away from combustibles in the resident environment. The Life Safety Code prohibits the use of portable electrical space heaters in resident areas. Extension cords should not be used to take the place of adequate wiring in a facility. If extension cords are used, the cords should be properly secured and not be placed overhead, under carpets or rugs, or anywhere that the cord can cause trips, falls, or overheat. Extension cords should be connected to only one device to prevent overloading of the circuit. The cord itself should be of a size and type for the expected electrical load, and made of material that will not fray or cut easily. Electrical cords, including extension cords, should have proper grounding if required, and should not have any grounding devices removed, or should not be used without the grounding devices. Power strips may not be used as a substitute for adequate electrical outlets in a facility. Power strips may be used for a computer, monitor, and printer. Power strips are not designed to be used with medical devices in patient care areas. Precautions needed if power strips are used include installing internal ground fault and overcurrent protection devices, preventing cords from becoming tripping hazards, and using power strips that are adequate for the number and types of devices used. Overload on any circuit can potentially cause overheating and fire. The use of ground fault circuit interruption (GFCI) may be required in locations near water sources to prevent electrocution of staff or residents. 13. The proper use of electric blankets and heating pads is essential to avoid thermal injuries. These items should not be tucked in or squeezed. Constriction can cause the internal wires to break. A resident should not go to sleep with an electric blanket or heating pad turned on. Manufacturers' instructions for use should be followed closely. Injuries and deaths have been related to burns and fires related to the use of heating pads. Most deaths are attributable to heating pads that generated fires, but most injuries are burns from prolonged use or inappropriate temperature setting. Prolonged use on one area of the body can cause a severe burn, even when the heating pad is at a low temperature setting. Lighting. The risk of an accident increases when there is insufficient light or too much light, which often results in glare. Vision among older persons varies widely. Therefore, no single level of illumination can ensure safety for all residents. The proper amount of light depends on the resident's visual needs and the task he/she is performing. An older person typically needs more light to see. However, a resident with cataracts or glaucoma may be overly sensitive to bright light, and excessive lighting could make it more difficult to see clearly. and thereby increase his or her fall risk 0.14, creating transitional zones between light and dark spaces, helps to improve sight recovery and enable safer mobility. Providing extra visual cues that clearly define needed items or spaces in areas with limited or variable light can help to enable safe performance of tasks, e.g., turning on a light. Providing supplemental light near beds for residents who are mobile may assist in safe mobility at night. 15. Note: refer to guidance under 42 CFR 483.10I5, F584, Safe Environment regarding adequate and comfortable lighting. Assistive devices/equipment hazards. Assistive devices also can help to prevent accidents. Assistive devices and equipment can help residents move with increased independence, transfer with greater comfort, and feel physically more secure. However, there are risks associated with the use of such devices and equipment, particularly if or when they are not properly maintained, and these risks need to be balanced with the benefits gained from their use. Training of staff, residents, family members, and volunteers on the proper use of assistive devices/equipment is crucial to prevent accidents. It is also important to communicate clearly the approaches identified in the care plan to all staff, including temporary staff. It is important to train staff regarding resident assessment, safe transfer techniques, and the proper use of mechanical lifts, including device weight limitations. Note: the Safe Medical Devices Act of 1990, SMDA, requires hospitals, nursing homes, and other user facilities to report deaths, serious illnesses, and injuries associated with the use of medical devices to manufacturers and the Food and Drug Administration. Assistive devices for mobility devices include all types of assistive devices, such as, but not limited to, canes, standard and rolling walkers, manual or non-powered wheelchairs, and powered wheelchairs. 3 primary factors that may be associated with an increased accident risk related to the use of assistive devices include: 1. Resident condition. Lower extremity weakness, gait disturbances, decreased range of motion, and poor balance may affect some residents. These conditions, combined with cognitive impairment, can increase the accident risks of using mobility devices. Unsafe behavior, such as failure to lock wheelchair brakes and trying to stand or transfer from a wheelchair unsafely, can result in falls and related injuries. 2. Personal fit and device condition. Devices can pose a hazard if not fitted and or maintained properly. 0.16 Personal fit, or how well the assistive device meets the individual needs of the resident, may influence the likelihood of an avoidable accident. And 3. Staff practices. Mobility devices that a resident cannot readily reach may create a hazardous situation. Unsafe transfer technique used by staff may result in an accident. Inadequate supervision by staff of a resident during the initial trial period of assistive device use, or after a change in the resident's functional status, can increase the risk of falls and or injury. Additionally, staff needs to ensure assistive devices properly fit the resident, and the resident has received proper training in the use of the assistive device. Assistive devices for transfer. Mechanical assistive devices for transfer include, but are not limited to, portable and stationary total body lifts, sit-to-stand devices, and transfer or gait belts. The resident assessment helps to determine the resident's degree of mobility and physical impairment and the proper transfer method. For example, whether one or more caregivers or a mechanical device is needed for a safe transfer. Residents who become frightened during transfer in a mechanical lift may exhibit resistance movements that can result in avoidable accidents. Communicating with the resident and addressing the resident's fear may reduce the risk. Factors that may influence a resident's risk of accident during transfer include staff availability, resident abilities, staff training, and competency. The resident's ability to communicate and identify physical limitations or to aid in the transfer will help determine the need for an assistive device, such as a mechanical lift. The Occupational Safety and Health Administration (OSHA) provides information and guidelines on identifying problems and implementing solutions relating to handling residents during transfers. 17. Devices associated with entrapment risks. Devices can be therapeutic and beneficial. However, devices are not necessarily risk-free, so it is important to weigh the relative risks and benefits of using certain devices. For example, while physical restraints may be used to treat a resident's medical symptom, the devices may create a risk for entrapment. Physical restraints are defined as any manual method, physical or mechanical device/equipment or material that meets all of the following criteria: is attached or adjacent to a resident's body, cannot be removed easily by the resident, and restricts the resident's freedom of movement or normal access to his or her body. Serious injuries, as well as death, have been reported as a result of using physical restraints. Some physical restraints carry a risk of severe injury, strangulation, and asphyxiation. Restrained residents may be injured or die when they try to remove restraints, to ambulate while restrained, or due to an improperly fitted or used device. Evidence shows that physical restraints cause more harm than good and seriously infringe upon a person's autonomy, as explained in this article, in the Journal of Medical Ethics. Use of physical restraint in nursing homes, clinical ethical considerations. 18. The Food and Drug Administration (FDA) also provides guidance on bed rail safety and reducing entrapment. https://www.fda.gov/medical devices/hospital beds/guide bed safety bed rail hospitals nursing homes and home health care facts. A guide to bed safety bed rails in hospitals, nursing homes and home health care. The facts. https://www.fda.gov/medical devices/bed rail safety/recommendations healthcare providers about bed rails. Recommendations for healthcare providers about bed rails. https://www.fda.gov/regulatory information/search FDA guidance documents/hospital bed system dimensional and assessment guidance reducing entrapment, guidance for industry and FDA staff, hospital bed system dimensional and assessment guidance to reduce entrapment. Regardless of the purpose for use, bed rails, also referred to as side rails, bedside rails, and safety rails, and other bed accessories, e.g. transfer bar, bed enclosures, while assisting with transfer and positioning, can increase resident safety risk. Bed rails include rails of various sizes, e.g. full-length rails, half rails, quarter rails that may be positioned in various locations on the bed. Residents most at risk for entrapment are those who are frail or elderly, or those who have conditions such as agitation, delirium, confusion, pain, uncontrolled body movement, hypoxia, fecal impaction, acute urinary retention, etc. That may cause them to move about the bed or try to exit from the bed. The failure to provide timely assistance with using the bathroom, inappropriate bed positioning, and other care-related activities can contribute to the risk of entrapment. The FDA provides detailed information about bed rails, including recommendations for healthcare providers. 19. Entrapment may occur when a resident is caught between the mattress and bed rail or in the bed rail itself. Technical issues, such as the proper sizing of mattresses, fit and integrity of bed rails, or other design elements, e.g. wide spaces between bars and the bed rails, can also affect the risk of resident entrapment. 20. Note: Section 483.25 N F700 requires that facilities attempt appropriate alternatives before installing/using bed rails. And if a bed or side rail is used, the facility must ensure correct installation, use, and maintenance of bed rails. The use of a specialty air-filled mattress or a therapeutic air-filled bed may also present an entrapment risk that is different from rail entrapment with a regular mattress. The high compressibility of an air-filled mattress compared to a regular conventional mattress requires appropriate precautions when used for a resident at risk for entrapment. An air-filled mattress compresses on the side to which a person moves, thus raising the center of the mattress and lowering the side. This may make it easier for a resident to slide off the mattress or against the rail. Mattress compression widens the space between the mattress and rail. When a resident is between the mattress and rail, the mattress can re-expand and press the chest, neck, or head against the rail. While using air therapy to prevent and treat pressure ulcer/injuries, facilities should also take precautions to reduce the risk of entrapment. Precautions may include following manufacturer equipment alerts and increasing supervision. 21. Note: Section 483.12 F604 applies to the use of physical restraints. This guidance at Section 483.2 5D F689 applies to assistive devices that create hazards, e.g., devices that are defective, not used properly or according to manufacturer's specifications, disabled or removed, not provided or do not meet the resident's needs, poor fit or not adapted, and / or used without adequate supervision when required. Section 483.25 F700 applies to the installation of bed rails. Key elements of noncompliance. To cite deficient practice at F689, the surveyor's investigation will generally show that the facility failed to do one or more of the following: identify and eliminate all known and foreseeable accident hazards in the resident's environment to the extent possible, or, to the extent possible, reduce the risk of all known or foreseeable accident hazards that cannot be eliminated, or provide appropriate and sufficient supervision to each resident to prevent an avoidable accident, or provide assistance devices necessary to prevent an avoidable accident from occurring. Investigative summary. Use the accident's critical element C pathway, along with the above interpretive guidelines, when determining if the facility meets the requirements to ensure that the resident's environment remains as free from accident hazards as possible, and that each resident receives adequate supervision and assistance devices to prevent accidents. Summary of accident and supervision investigative procedure. Observe the general environment of the facility to determine if the facility provides an environment that is free from accident hazards over which the facility has control, and provides supervision and assistive devices to each resident to prevent avoidable accidents. During observation of the facility, the survey team should observe the environment for the presence of potential/actual hazards. For a resident with an identified concern, briefly review the assessment and plan of care to determine whether the facility identified resident risks and implemented interventions as necessary. If the resident has been in the facility for less than 14 days before completion of all the resident assessment instrument RI is required, review the baseline care plan, which must be completed within 48 hours to determine if the facility is providing appropriate care and services based on information available at the time of admission. Deficiency categorization. In addition to actual or potential physical harm, always consider whether psychosocial harm has occurred when determining severity level. See Psychosocial Outcome Severity Guide. Examples of severity level 4 noncompliance immediate jeopardy to resident health or safety include, but are not limited to: the facility failed to keep corrosive cleaning supplies out of the reach of ambulatory residents with dementia, resulting in one resident ingesting drain opener and sustaining esophageal damage. The facility failed to provide supervision to a unit which had ambulatory cognitively impaired residents. The facility failed to keep these residents from gaining access to the employee locker room. When the surveyor conducted her tour of the facility, she found a confused resident who was trapped in the employee locker room. The facility failed to keep a resident free from hazards and provide the necessary monitoring and supervision for a resident with known substance use disorder and history of using illicit substances when outside of the facility. Through an interview with a certified nurse aide CNA, the surveyor discovered the resident left the facility for approximately 5 hours with facility knowledge of the absence. Upon return to the facility, the resident went to his room. Facility staff did not assess the resident's condition for several hours and then found the resident unresponsive. Medical records showed that the resident had sustained an overdose. Examples of severity level 3 noncompliance actual harm that is not immediate jeopardy include, but are not limited to: the facility failed to apply a smoking apron to a resident while smoking, which was necessary and documented on the care plan. The resident sustained a second-degree burn after the cigarette fell onto his or her lap. The facility failed to use a 2-person transfer, as determined necessary by the comprehensive care plan, during a transfer from the resident's bed to wheelchair, resulting in the resident falling to the floor, sustaining a laceration requiring sutures. Examples of severity level 2 noncompliance no actual harm with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to: the facility failed to remove clutter and building materials from a construction area immediately adjacent to a walkway used by residents and their families, creating a hazard which poses a risk for more than minimal harm. A cognitively intact resident with known SUD, but no other safety concerns, was observed lingering by doors that were not monitored. After interviewing staff, the survey team identified that the facility did not have a consistent process for how residents notify the facility when they leave the facility, or have a process to identify when residents leave the facility if the resident does not notify facility staff. Severity level 1 noncompliance, no actual harm with potential for minimal harm. The failure of the facility to provide a safe environment and adequate supervision places residents at risk for more than minimal harm. Therefore, severity level 1 does not apply for this regulatory requirement. Note: references to non-CMS/HHS sources or sites on the Internet included above or later in this document are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services. CMS is not responsible for the content of pages found at these sites. URL addresses were current as of the date of this publication. Other resources which may be useful: Falls National Council on Aging National Falls Prevention Resource Center at https://www.ncoorg/professionals/health/Center for Healthy Aging/National Falls Prevention Resource Center Centers for Disease Control and Prevention at http://www.cdc.gov/Home and Recreational Safety/Falls/World Health Organization Fall Prevention in Older Age at https://www.huint/ Falls and Fall Prevention https://www.neonegov/health/topics/Falls and Falls Prevention Wandering and Elopement Resources National Council of Certified Dementia Practitioners at http://www.nccdpor. 2 Bressler, K., Redfern, R.E., and Brown, M., 2011. Elimination of Position Change Alarms in an Alzheimer's and Dementia Long-Term Care Facility. MJ Alzheimer's Dis Other Demen 268, 599. 3-Panel on Prevention of Falls in Older Persons, American Geriatrics Society and British Geriatrics. 2010. Summary of the updated American Geriatrics Society/British Geriatrics Society Clinical Practice Guideline for Prevention of Falls in Older Persons. J.M. Geriater Soc, 2011, 59-1, 148-57. 4 Taylor J.A., Parmalee P., Brown H., and Auslander J. The Falls Management Program, Equality. Improvement Initiative for Nursing Facilities. Agency for Healthcare Research and Quality, 2005, https://www.gov/patient safety/settings/long-term care/resource/injuries Folsks HTML. 5 Shore R. Rye, Chandler M., Mian L.C., Waters T.M., Liu M., Daniels M.J., Kessler L.A., and Miller S.D., 2012. Effects of an intervention to increase bed alarm use to prevent falls in hospitalized patients. Annals of Internal Medicine 15710 698. 6 Capesudi E. Brush B.L., Lane S., Rabinovitz H.U., and Sesic M., 2009. Bed exit alarm. Effectiveness. Arch Gerontal Geriater 409127-31. 7 Maspro ND. Nursing Home Alarm Elimination Program. It's possible to reduce falls by eliminating resident alarms. 8 Becker C. Rapp K. 2010 Fall Prevention in Nursing Homes. Clinics in Geriatric Medicine 264693,704. 9 U.S. Department of Health and Human Services, Agency for Toxic Substances and Disease Registry, Toxicological Profiles, http://www.cdc.gov/toxprofiles/indexasp. 10 U.S. Department of Labor, Occupational Safety and Health Standards, 29 CFR 1910.1200 G1 and 2. 11 Catcher L.K., 1981. Scald burns from hot tap water. Journal of a Metasoc, 246-11-1219-1222. 12 Moritz A.R., Henriques F.C., J.R., 1947. Studies of Thermal Injury, Roman II. The relative importance of time and surface temperatures in the causation of cutaneous burns. M.J. Pathology, 23, 695-720. 13 U.S. Department of Health and Human Services, Centers for Disease Control and Prevention, Emergency Preparedness and Response, https://www.cdc.gov/mastroma/factsheets/public/burns PDF. 14 Electrical Safety Foundation International Resource Library. 15 Tidix R. 1998. Falls in Older Persons, Prevention and Management 2nd edition. Baltimore, M.D., Health Profession Press. 16 Warren M., 2001, Occupational Therapy Practice Guidelines for Adults with Low Vision, the American Occupational Therapy Association, Inc. 17 Taylor, J.A., Brown, A.K., Meredith S., Ray W.A., 2002, The Fall Reduction Program, a comprehensive program for reduction of falls and injuries in long-term care residents. Nashville, T.N., Department of Preventive Medicine, Vanderbilt University School of Medicine. 18 U.S. Department of Labor, Occupational Safety and Health Administration. Guidelines for Nursing Homes revised March 2009. https://www.oshagov/ergonomics/guidelines/nursing-home/final NH Guidelines HTML. 19 Gassmans, C. and Melisons, K. March 2006. Use of Physical Restraint in Nursing Homes, Clinical Ethical Considerations. J. Med Ethics, 32-3, 148 Section 152. Food and Drug Administration, Bed Rail Safety, http://www.fda.gov/medical-devices/products and medical procedures/general hospital devices and supplies/hospital beds/UCM 123,676, HTM. 21 U.S. Department of Health and Human Services, Food and Drug Administration, Recommendations for Consumers and Caregivers. http://www.fda.gov/medical-devices/products and medical procedures/home health and consumer/consumer products/bed rail safety/UCM 362,843, HTM. 22 Miles, S., June 2002. Death between bedrails and air-pressured mattresses. J.M. Geriater Soc, 56, 1124-5. Tag F690. Section 483.2, 5E Incontinence. Section 483.2, 5E1, the facility must ensure that a resident who is continent of bladder and bowel on admission receives services and assistance to maintain continence, unless his or her clinical condition is or becomes such that continence is not possible to maintain. Section 483.2, 5E2 for a resident with urinary incontinence. Based on the resident's comprehensive assessment, the facility must ensure that a resident who enters the facility without an indwelling catheter is not catheterized unless the resident's clinical condition demonstrates that catheterization was necessary. II, a resident who enters the facility with an indwelling catheter or subsequently receives one is assessed for removal of the catheter as soon as possible, unless the resident's clinical condition demonstrates that catheterization is necessary. And III, a resident who is incontinent of bladder receives appropriate treatment and services to prevent urinary tract infections and to restore continence to the extent possible. Section 483.2, 5E3 for a resident with fecal incontinence. Based on the resident's comprehensive assessment, the facility must ensure that a resident who is incontinent of bowel receives appropriate treatment and services to restore as much normal bowel function as possible. Intent. The intent of this requirement is to ensure that each resident who is continent of bladder receives the necessary services and assistance to maintain continence, unless it is clinically not possible. Each resident who is incontinent of urine is identified, assessed, and provided appropriate treatment and services to achieve or maintain as much normal bladder function as possible. An indwelling catheter is not used unless there is valid medical justification for catheterization, and the catheter is discontinued as soon as clinically warranted. A resident, with or without an indwelling catheter, receives the appropriate care and services to prevent urinary tract infections to the extent possible. Services are provided to restore or improve normal bladder function to the extent possible after the removal of the indwelling catheter, and a resident with fecal incontinence is identified, assessed, and provided appropriate treatment and services to restore as much normal bowel function as possible, unless it is not clinically possible. Note, F690 includes the appropriate treatment and services to restore bowel function for a resident with fecal incontinence. However, for concerns related to bowel management such as constipation, fecal impaction, refer to F684, quality of care. Definitions. Bacteremia is the presence of bacteria in the bloodstream. Bacteriuria is defined as the presence of bacteria in the urine. Continence refers to any void that occurs voluntarily or as the result of prompted, assisted, or scheduled use of the bathroom. Sepsis is the body's overwhelming and life-threatening response to an infection which can lead to tissue damage, organ failure, and death. Urinary incontinence is the involuntary loss or leakage of urine. Urinary retention is the inability to completely empty the urinary bladder by micturition. Urinary tract infection (UTI) is a clinically detectable condition associated with invasion by disease-causing microorganisms of some part of the urinary tract, including the urethra urethritis, bladder cystitis, ureters ureteritis, and / or kidney pyelonephritis. An infection of the urethra or bladder is classified as a lower tract UTI, and infection involving the ureter or kidney is classified as an upper tract UTI. Guidance Section 483.2, 5E. A resident who is continent of bladder on admission must receive care, including assistance and services to maintain continence, unless his or her clinical condition is or becomes such that continence is not possible to maintain. If a resident is admitted with incontinence of bladder, he/she receives appropriate treatment and services to prevent urinary tract infections and to restore as much normal bladder function as possible. Urinary incontinence generally involves a number of transitory or progressive factors that affect the bladder and / or the urethral sphincter. Any condition, medication, or factor that affects lower urinary tract function, bladder capacity, urination, or the ability to toilet can predispose residents to urinary incontinence and may contribute to incomplete bladder emptying. Assessment: a resident should be assessed at admission regarding continence status, and whenever there is a change in urinary tract function, such as if a resident is admitted who is continent of urine and subsequently becomes incontinent. The identification of reversible and irreversible, e.g., bladder tumors, spinal cord disease causes of incontinence, including the type of incontinence, provides direction for the development of appropriate interventions. It is important that staff, when completing the comprehensive assessment, consider the following: prior history of bladder functioning, including status of continence, history of urinary incontinence, including onset, duration, and characteristics, precipitants of urinary incontinence, associated symptoms, e.g., dysuria, polyuria, hesitancy, and previous treatment and or management, including the response to the interventions and the occurrence of persistent or recurrent UTI. Voiding patterns such as frequency, volume, nighttime or daytime, quality of stream, and, for those already experiencing urinary incontinence, voiding patterns over several days. Medication review, particularly those that might affect continence, such as medications with anticholinergic properties, may cause urinary retention and possible overflow incontinence. Sedatives/hypnotics may cause sedation leading to functional incontinence. Diuretics may cause urgency, frequency, overflow incontinence. Narcotics. Alpha-adrenergic agonists may cause urinary retention in men, or antagonists may cause stress incontinence in women. Calcium channel blockers may cause urinary retention. Patterns of fluid intake, such as amounts, time of day, alterations, and potential complications, such as decreased or increased urine output. Use of urinary tract stimulants or irritants, e.g., frequent caffeine intake, pelvic and rectal examination to identify physical features that may directly affect urinary continence, such as prolapsed uterus or bladder, prostate enlargement, significant constipation or fecal impaction, use of a urinary catheter, atrophic vaginitis, distended bladder or bladder spasms, functional and cognitive capabilities that could enhance urinary continence and limitations that could adversely affect continence, such as impaired cognitive function or dementia, impaired immobility, decreased manual dexterity, the need for task segmentation, decreased upper and lower extremity muscle strength, decreased vision, pain with movement, type and frequency of physical assistance necessary to assist the resident to access the toilet, commode, urinal, etc., and the types of prompting needed to encourage urination. Pertinent diagnoses such as congestive heart failure, stroke, diabetes mellitus, obesity, and neurological disorders, e.g., multiple sclerosis, Parkinson's disease, or tumors that could affect the urinary tract or its function. Identification of or potential of developing complications, such as skin irritation or breakdown. Tests or studies indicated to identify the types of urinary incontinence, e.g., post-void residual S for residents who have or are at risk of urinary retention. Results of any urine culture, if the resident has clinically significant systemic or urinary symptoms, or evaluations assessing the resident's readiness for bladder rehabilitation programs, and environmental factors and assistive devices that may restrict or facilitate a resident's ability to access the toilet, e.g., grab bars, raised or low toilet seats, inadequate lighting, distance to toilet or bedside commodes, and availability of urinals, use of bed rails or restraints, or fear of falling. Types of urinary incontinence. Identifying the nature of the incontinence is a key aspect of the assessment and helps identify the appropriate programs/interventions to address incontinence. There are several types of urinary incontinence, and the individual resident may experience more than one type at a time. Some of the more common types include: urge incontinence is associated with detrusor muscle, overactivity, excessive contraction of the smooth muscle in the wall of the urinary bladder, resulting in a sudden, strong urge, also known as urgency, to expel moderate to large amounts of urine before the bladder is full. It is characterized by abrupt urgency, frequency, and noxuria, part of the overactive bladder diagnosis. It may be age-related or have neurological causes, e.g., stroke, diabetes mellitus, Parkinson's disease, multiple sclerosis, or other causes such as bladder infection, urethral irritation, etc. The resident can feel the need to void, but is unable to inhibit voiding long enough to reach and sit on the commode. It is the most common cause of urinary incontinence in elderly persons. Stress incontinence outlet incompetence is associated with impaired urethral closure malfunction of the urethral sphincter, which allows small amounts of urine leakage when intra-abdominal pressure on the bladder is increased by sneezing, coughing, laughing, lifting, standing from a sitting position, climbing stairs, etc. Urine leakage results from an increase in intra-abdominal pressure on a bladder that is not over-distended and is not the result of detrusor contractions. It is the second most common type of urinary incontinence in older women. Mixed incontinence is the combination of urge incontinence and stress incontinence. Many elderly persons, especially women, will experience symptoms of both urge and stress. Overflow incontinence is associated with leakage of small amounts of urine when the bladder has reached its maximum capacity and has become distended from urine retention. Symptoms of overflow incontinence may include weak stream, hesitancy or intermittency, dysuria, noxuria, frequency, incomplete voiding, frequent or constant dribbling. Urine retention may result from outlet obstruction, e.g., benign prostatic hypertrophy, BPH, prostate cancer, and urethral stricture, hypotonic bladder detrusor underactivity, or both. Hypotonic bladder may be caused by outlet obstruction, impaired or absent contractility of the bladder, neurogenic bladder, or other causes. Neurogenic bladder may also result from neurological conditions such as diabetes mellitus, spinal cord injury, or pelvic nerve damage from surgery or radiation therapy. In overflow incontinence, post-void residual PVR, volume, the amount of urine remaining in the bladder within 5 to 10 minutes following urination, exceeds 200 milliliters ml. Normal PVR is usually 50 ml or less. A PVR of 150 to 200 may suggest a need for retesting to determine if this finding is clinically significant. Overflow incontinence may mimic urge or stress incontinence, but is less common than either of those. Functional incontinence refers to loss of urine that occurs in a resident whose urinary tract function is sufficiently intact that he/she should be able to maintain continence, but who cannot remain continent because of external factors other than inherently abnormal urinary tract function. Examples may include the failure of staff to respond to a request for assistance to the toilet or the inability to utilize the toilet facilities in time. It may also be related to physical weakness or poor mobility/dexterity, e.g., due to poor eyesight, arthritis, deconditioning, stroke, contracture. Cognitive problems, e.g., confusion, dementia, unwillingness to toilet. Medications, e.g., anticholinergics, diuretics, or environmental impediments including excessive distance from the toilet. Facilities, poor lighting, low chairs that are difficult to get out of, physical restraints, and toilets that are difficult to access. Refer to Section 483.10E3, F684, Accommodation of Needs for Issues Regarding Unmet Environmental Needs, e.g., handicap toilet, lighting, assistive devices. Note, treating the physiological causes of incontinence without attending to functional components that may have an impact on the resident's continence may fail to solve the incontinence problem. Transient incontinence refers to temporary or occasional incontinence that may be related to a variety of causes, for example, delirium, infection, atrophic urethritis or vaginitis, some pharmaceuticals such as sedatives/hypnotics, diuretics, anticholinergic agents, increased urine production, restricted mobility, or fecal impaction. The incontinence is transient because it is related to a potentially improvable or reversible cause. Interventions. A number of factors may contribute to the development of incontinence, or decline or lack of improvement in urinary continence, such as an underlying medical condition and inaccurate assessment of the resident's type of incontinence, or lack of knowledge about the resident's voiding patterns. This may contribute to inappropriate interventions or unnecessary use of an indwelling catheter. Facility practices that may promote achieving the highest practicable level of functioning may prevent the development of incontinence or minimize a decline or lack of improvement in degree of continence, include providing treatment and services to address factors that are potentially modifiable, such as managing pain and slash, or providing adaptive equipment to improve function for residents suffering from arthritis, contractures, neurological impairments, etc. Removing or improving environmental impediments that affect the resident's level of continence, e.g., improved lighting, use of a bedside commode, or reducing the distance to the toilet. Treating underlying conditions that have a potentially negative impact on the degree of continence, e.g., delirium causing urinary incontinence related to acute confusion. Possibly adjusting medications affecting continence, e.g., medication cessation, dose reduction, selection of an alternate medication, change in time of administration, and implementing a fluid and slash or bowel management program to meet the assessed needs. Options for managing urinary incontinence in nursing home residents include primarily behavioral programs and medication therapy. Other measures and supportive devices used in the management of urinary incontinence and slash or urinary retention may include intermittent catheterization, pelvic organ support devices, pessaries, biofeedback. The use of incontinence products, garments, and an external collection system for men and women, and environmental accommodation and slash or modification. Behavioral programs. Interventions involving the use of behavioral programs are among the least invasive approaches to address urinary incontinence and have no known adverse complications. Behavior programs involve efforts to modify the resident's behavior and slash or environment. Critical aspects of a successful behavioral program include education of the caregiver and the resident, availability of the staff, and the consistent implementation of the interventions. Note: it is important for the comprehensive assessment to identify the essential skills the resident must possess, such as the resident's ability to comprehend and follow instructions, identify urinary urge, control the urge to void until reaching a toilet, and slash or respond to prompts to void. Voiding records help detect urinary patterns or intervals between incontinence episodes and facilitate planning, care to avoid or reduce the frequency of episodes. Programs that require the resident's cooperation and motivation in order for learning and practice to occur include the following. Bladder rehabilitation/bladder retraining is a behavioral technique that requires the resident to resist or inhibit the sensation of urgency, the strong desire to urinate, to postpone or delay voiding, and to urinate according to a timetable rather than to the urge to void. Depending upon the resident's successful ability to control the urge to void, the intervals between voiding may be increased progressively. Bladder training generally consists of education, scheduled voiding with systematic delay of voiding, and positive reinforcement. This program is difficult to implement in cognitively impaired residents and may not be successful in frail, elderly, or dependent residents. The resident who may be appropriate for a bladder rehabilitation retraining program is usually fairly independent in activities of daily living, has occasional incontinence, is aware of the need to urinate void, may wear incontinence products for episodic urine leakage, and has a goal to maintain his or her highest level of continence and decrease urine leakage. Successful bladder retraining usually takes at least several weeks. Residents who are assessed with urge or mixed incontinence and are cognitively intact may be candidates for bladder retraining. This is not to be confused with habit training/scheduled voiding, see below, and pelvic floor muscle rehabilitation, also called Kegel and pelvic floor muscle exercise, is performed to strengthen the voluntary periurethral and perivaginal muscles that contribute to the closing force of the urethra and the support of the pelvic organs. These exercises are helpful in dealing with urge and stress incontinence. Pelvic floor muscle exercises, PFME, strengthen the muscular components of urethral supports and are the cornerstone of non-invasive treatment of stress urinary incontinence. PFME requires residents who are able and willing to participate and the implementation of careful instructions and monitoring provided by the facility. Poor resident adherence to the exercises may occur even with close monitoring. Programs that are dependent on staff involvement and assistance, as opposed to resident function, include the following. Prompted voiding is a behavioral technique appropriate for use with dependent or more cognitively impaired residents. Prompted voiding has 3 components: regular monitoring with encouragement to report continence status, prompting to toilet on a scheduled basis, and praise and positive feedback when the resident is continent and attempts to toilet. These methods require training, motivation, and continued effort by the resident and caregivers to ensure continued success. Prompted voiding focuses on teaching the resident, who is incontinent, to recognize bladder fullness or the need to void, to ask for help, or to respond when prompted to toilet. Residents who are assessed with urge or mixed incontinence and are cognitively impaired may be candidates for prompted voiding. As the resident's cognition changes, the facility should consider other factors, such as mobility, when deciding to conduct a voiding trial to determine feasibility of an ongoing program to use the bathroom. And habit training/scheduled voiding is a behavioral technique that calls for scheduled use of the bathroom at regular intervals on a planned basis to match the resident's voiding habits. Unlike bladder retraining, there is no systematic effort to encourage the resident to delay voiding and resist urges. This is not considered to be a bladder rehabilitation/retraining program. Habit training includes timed voiding with the interval based on the resident's usual voiding schedule or pattern. Scheduled voiding is timed voiding, usually every 3 to 4 hours. While awake, residents who cannot self-toilet may be candidates for habit training or scheduled voiding programs. Intermittent catheterization, sterile insertion, and removal of a catheter through the urethra every 3 to 6 hours for bladder drainage may be appropriate for the management of acute or chronic urinary retention. See additional discussion below in catheterization. Medication therapy. Medications are often used to treat specific types of incontinence, including stress incontinence and those categories associated with an overactive bladder, which may involve symptoms including urge incontinence, urinary urgency, frequency, and noxuria. The current literature identifies classifications and names of medications used for various types of incontinence. When using medications, potentially problematic anticholinergic and other side effects must be recognized. The use of medication therapy to treat urinary incontinence may not be appropriate for some residents because of potential adverse interactions with their other medications or other comorbid conditions. The resident/representative must be provided with the risks and benefits of using medications for continence management. Pessary. A pessary is an intravaginal device used to treat pelvic muscle relaxation or prolapse of pelvic organs. Women whose urine retention or urinary incontinence is exacerbated by bladder or uterine prolapse may benefit from placement of a pessary. Female residents may be admitted to the nursing home with a pessary device. The assessment should note whether the resident has a pessary in place or has had a history of successful pessary use. If a pessary is used, the plan of care must address the use, care, and ongoing management of the pessary, including monitoring for complications. Absorbent products, devices, and external collection devices. Absorbent incontinence products include perineal pads or panty liners for slight leakage, undergarments and protective underwear for moderate to heavy leakage, guards and drip collection pouches for men, and products called adult briefs for moderate or heavy loss. Absorbent products can be a useful, rational way to manage incontinence. However, every absorbent product has a saturation point. Factors contributing to the selection of the type of product to be used should include the severity of incontinence, gender, fit, and ease of use. Advantages of using absorbent products to manage urinary incontinence include the ability to contain urine. Some may wick the urine away from the skin, provide protection for clothing, and preserve the resident's dignity and comfort. Note, although many residents have used absorbent products prior to admission to the nursing home, and the use of absorbent products may be appropriate, absorbent products should not be used as the primary long-term approach to continence management until the resident has been appropriately evaluated and other alternative approaches have been considered. It is important that residents using various devices, absorbent products, external collection devices, etc., be checked and changed as needed on a schedule based upon the resident's voiding pattern, professional standards of practice, and the manufacturer's recommendations. Skin-related complications, skin problems associated with incontinence and moisture, can range from irritation to increased risk of skin breakdown. Moisture may make the skin more susceptible to damage from friction and shear during repositioning. For a resident with an external catheter, compromise to the skin may also occur. One form of early skin breakdown is maceration or the softening of tissue by soaking. Macerated skin has a white appearance and a very soft, sometimes soggy texture. The persistent exposure of perineal skin to urine and slash or feces can irritate the epidermis and can cause severe dermatitis, skin erosion, and slash or ulcerations. Skin erosion is the loss of some or all of the epidermis comparable to a deep chemical peel, leaving a slightly depressed area of skin. Because frequent washing with soap and water can dry the skin, the use of a perineal rinse may be indicated. Catheterization. Sections 483.2 5E2I and Roman II. Incontinence requires that a resident who enters the facility without an indwelling catheter is not catheterized unless the resident's clinical condition demonstrates that catheterization was necessary, or that a resident who enters the facility with an indwelling urinary catheter or subsequently receives one is assessed for removal of the catheter as soon as possible, unless the resident's clinical condition demonstrates that catheterization is necessary. The facility is responsible for the assessment of the resident at risk for urinary catheterization and the ongoing assessment for the resident who currently has a catheter, including the removal of the catheter as soon as possible when the resident's clinical condition demonstrates the catheter is no longer necessary. While the use of a catheter may promote skin integrity and assessment of output, it is also associated with the increased risk of catheter-associated urinary tract infections (CAUTI), including the development of sepsis. A catheter that is used for appropriate indications and in a dignified manner may enhance an individual's independence and dignity. Conversely, an improperly or indiscreetly used catheter may negatively impact independence and dignity. Note, for concerns related to the care for a resident with a urostomy or nephrostomy, refer to Section 483.2, 5F colostomy, urostomy, or ileostomy care at tag F691. In addition, according to the Centers for Disease Control and Prevention (CDC), the definition of a suprapubic catheter is one that is surgically inserted into the bladder through an incision above the pubis. For care of a resident with a suprapubic catheter, refer to current professional guidelines. Assessment regardless of the admission status. A comprehensive assessment should address those factors that predispose the resident to the development of urinary incontinence and the use of an indwelling urinary catheter. An admission evaluation of the resident's medical history and a physical examination helps identify the resident at risk for requiring the use of an indwelling urinary catheter. This evaluation is to include detection of reversible causes of incontinence and identification of individuals with incontinence caused by conditions that may not be reversible, such as bladder tumors and spinal cord diseases. The assessment of continence/incontinence is based upon a comprehensive, interdisciplinary review and assessment. The comprehensive assessment should include identifying the underlying factors which support the clinical indication for the initiation and continuing need for catheter use, determination of which factors can be modified or reversed or rationale for why those factors should not be modified, and the development of a plan for removal. The clinician's decision to use an indwelling catheter in the elderly should be based on valid clinical indicators. For the resident with an indwelling catheter, the facility's documented assessment and staff knowledge of the resident should include information to support the use of an indwelling catheter. Because of the risk of substantial complications with the use of indwelling urinary catheters, they should be reserved primarily for short-term decompression of acute urinary retention. The assessment should include consideration of the risks and benefits of an indwelling suprapubic or urethral catheter, the potential for removal of the catheter, and consideration of complications resulting from the use of an indwelling catheter, such as symptoms of blockage of the catheter with associated bypassing of urine, expulsion of the catheter, pain, discomfort, and bleeding. Intermittent catheterization. Intermittent catheterization can often manage overflow incontinence effectively. Residents who have new onset incontinence from a transient, hypotonic/atonic bladder, usually seen following indwelling catheterization in the hospital, may benefit from intermittent bladder catheterization until the bladder tone returns, e.g., up to approximately 7 days. Avoiding trial and post-void residual can help identify when bladder tone has returned. Indwelling urinary catheter use if the facility provides care for a resident with an indwelling catheter, in collaboration with the medical director and director of nurses, and based upon current professional standards of practice, resident care policies and procedures must be developed and implemented that address catheter care and services, including, but not limited to, documentation of the involvement of the resident and/or resident representative in the discussion of the risks and benefits of the use of a catheter, removal of the catheter when criteria or indication for use is no longer present, and the right to decline the use of the catheter. Timely and appropriate assessments related to the indication for use of an indwelling catheter. Identification and documentation of clinical indications for the use of a catheter, as well as criteria for the discontinuance of the catheter when the indication for use is no longer present. Insertion, ongoing care, and catheter removal protocols that adhere to professional standards of practice and infection prevention and control procedures. Response of the resident during the use of the catheter, and ongoing monitoring for changes in condition related to potential CAUTI and recognizing, reporting, and addressing such changes. See note below for examples of clinical indications for use. The resident's record must include how and when the resident/representative was involved and informed of care and treatment, including the potential use and indications for the need for a catheter, how long use is anticipated, and when and why a catheter must be removed. The resident/representative must be included in the development of the care plan, including the use of the catheter and associated interventions. In addition, the resident/representative has the right to decline the treatment. Based on current professional standards of practice, information and education of the resident/representative representative on the identification of risks and benefits for the use of a catheter must be documented. Anecdotally, it has been reported that residents or their representatives have requested the use of or declined to allow the removal of an indwelling urinary catheter. The record must contain documentation as to why a resident/representative chooses to have or chooses to continue to use a catheter in the absence of clinical indications for use. After determining the reasons, staff and the attending practitioner must document the provision of counseling to assist the resident in understanding the clinical implications and risks associated with the use of a catheter without an indication for continued use. The care plan must be revised to address the education being provided, including interventions to restore as much urinary function as possible without the use of catheter. Documentation in the resident's record must reflect the attending practitioner's valid clinical indication to support the use of an indwelling catheter. Note, the following table from the CDC includes examples for appropriate indications for indwelling catheter use and includes both acute and long-term care. This table has been adapted to include only those examples relevant for a long-term care setting. For the full table, and for guidance related to indwelling catheter management and care, refer to http://www.cdc.gov/HICPAC/CAUTI/02CAUTI 2009, A. Examples of appropriate indications for indwelling urethral catheter use. Resident has acute urinary retention or bladder outlet obstruction. Need for accurate measurements of urinary output to assist in healing of open sacral or perineal wounds in incontinent residents. Resident requires prolonged immobilization, e.g. potentially unstable thoracic or lumbar spine, multiple traumatic injuries such as pelvic fractures, and to improve comfort for end-of-life care, if needed. B. Examples of inappropriate uses of indwelling catheters as a substitute for nursing care of the resident with incontinence, and as a means of obtaining urine for culture or other diagnostic tests when the resident can voluntarily void. Note, these above indications are based on expert consensus. Additional care practices related to catheterization include recognizing and assessing for complications and their causes, and maintaining a record of any catheter-related problems. Attempts to remove the catheter as soon as possible when no indications exist for its continuing use. Monitoring for excessive post-void residual after removing a catheter that was inserted for obstruction or overflow incontinence. Keeping the catheter anchored to prevent excessive tension on the catheter, which can lead to urethral tears or dislodging the catheter, and securing the catheter to facilitate flow of urine, preventing kinking of the tubing and position below the level of the bladder. Also refer to F880, infection control for policies and procedures related to care of the catheter and equipment, such as tubing, bags, etc. Note, refer to the CDC site for current information on catheter use, management, and care at http://www.cdc.gov/HAI/CAUTI/UDHTML. Catheter-related complications. An indwelling catheter may be associated with significant complications, including bacteremia, febrile episodes, bladder stones, fistula formation, erosion of the urethra, epididymitis, chronic renal inflammation, and pyelonephritis and sepsis related to urinary tract infections. In addition, indwelling catheters are prone to blockage. Risk factors for catheter blockage include alkaline urine, poor urine flow, proteinuria, and pre-existing bladder stones. Some residents with indwelling catheters experience persistent leakage around the catheter. Examples of factors that may contribute to leakage include irritation by a large balloon or by catheter materials, excessive catheter diameter, fecal impaction, and improper catheter positioning. Changing indwelling catheters or drainage bags at routine, fixed intervals is not recommended. Refer to https://www.cdc.gov/HICPAC/PDF/CAUTI/guideline 2009, final PDF. Catheterization is an important, potentially modifiable risk factor for UTI. The potential for complications can be reduced by identifying specific clinical indications for the use of an indwelling catheter, assessing whether other treatments and services would appropriately address those conditions, and assessing whether residents are at risk for other possible complications resulting from the continuing use of the catheter, such as obstruction resulting from catheter encrustation, urethral erosion, bladder spasms, hematuria, and leakage around the catheter. Urinary tract infections. Catheter-related bacteriuria and UTIs bacteriuria e.g. Puria alone in a catheterized individual should not be treated with antibiotics. Someone with nonspecific symptoms such as a change in function or mental status, foul smelling, or cloudy urine and slash, or bacteriuria e.g. puria, does not necessarily warrant antibiotic treatment. The decision to treat a UTI is based upon the attending practitioner conducting a thorough evaluation and assessment of the resident and providing documentation of a rationale for the indication of use of an antibiotic. Note, for a non-catheterized resident with symptoms associated with a UTI, the attending practitioner should order a urine culture prior to the initiation of antibiotic therapy to help guide treatment. According to current standard of practice, an accurate urine culture for a non-catheterized resident should be obtained by a clean catch or midstream specimen for residents who are able to follow instructions. For those unable to provide a clean catch, a specimen may be obtained preferably by a freshly placed condom catheter for males, or in and out catheterization for females or males unable to provide a specimen by a condom catheter. If the resident has a long-term indwelling urethral catheter, a specimen should be obtained from a freshly placed indwelling catheter. Reference the IDSA guidelines for evaluation of fever and infection in older adult residents of long-term care facilities. Hai et al. Clinical Infectious Diseases, 2009, 48 to 149 to 71. The surveyor should determine if facility policy for obtaining urine for cultures is based upon current standards of practice, understanding that these standards may be revised and updated over time. The facility should be able to provide the most current standard that supports the policy that they have developed and implemented. Also refer to F880 infection control and F881 for antibiotic stewardship program for infection assessment tools. Unnecessary treatment of a UTI with antibiotics may lead to the development of multi-drug-resistant organisms, e.g. methicillin-resistant Staphylococcus aureus, and other complications, such as the development of Clostridium difficile infection, which may predispose the person to prolonged treatment potential hospitalization and may pose a threat of infection to other residents. Also refer to F881 for antibiotic stewardship program for infection assessment tools. Note, standards of practice may be revised and updated over time. One current professional standard of practice that addresses criteria for use of antibiotics for UTIs includes minimum criteria for initiating antibiotics for an indication of urinary tract infection were considered for residents with no indwelling urinary catheters and for residents with chronic indwelling catheters. 1-2. For residents who do not have an indwelling catheter, minimum criteria for initiating antibiotics include 105 CFU/ml positive or pending urine culture and dysuria alone or two or more of the following. Fever 37.9, C100, F or 1.5, C2.4, F increase above baseline temperature on 2 occasions over last 12 hours, new or worsening urgency. Frequency, suprapubic pain, gross hematuria, costovertebral angle tenderness, flank pain, urinary incontinence, or shaking chills. 2. For residents who have an indwelling catheter or a suprapubic catheter, minimum criteria for initiating antibiotics include the presence of 105 CFU/ml positive or pending urine culture, and one or more of the following: fever 37.9, C100, F or 1.5, C2.4, F increase above baseline temperature on 2 occasions over last 12 hours. New costovertebral tenderness, rigors, shaking, chills, or new onset of delirium. Reference Loeb M., Brazil K., Lofeld L., et al. Effect of a multifaceted intervention on number of antimicrobial prescriptions for suspected urinary tract infections in residents of nursing homes. Cluster Randomized Controlled Trial. BMJ. 2005, 331, 669. PMC Free Article PubMed. Note, reference Loeb M., Brazil K., Lofeld L., et al. Effect of a multifaceted intervention on number of antimicrobial prescriptions for suspected urinary tract infections in residents of nursing homes. Cluster Randomized Controlled Trial. BMJ. 2005, 331, 669. PMC Free Article PubMed. Follow-up of UTIs. The goal of treating a UTI is to alleviate systemic or local symptoms, not to eradicate all bacteria. Therefore, a post-treatment urine culture is not necessary, but may be useful if UTI signs and symptoms continue or do not respond to antibiotic treatment. Continued bacteriuria without residual symptoms does not warrant repeat or continued antibiotic therapy. Recurrent UTIs 2 or more in 6 months in a non-catheterized individual may warrant additional evaluation, such as a determination of an abnormal post-void residual PVR urine volume or a referral to a urologist to rule out structural abnormalities such as enlarged prostate, prolapsed bladder, periurethral abscess, strictures, bladder calculi. Polyps and tumors. Recurrent UTIs in a catheterized individual should lead the facility to look for possible impairment of free urine flow through the catheter, to reevaluate the techniques being used for catheter care, and for perineal hygiene, including the removal of fecal soiling, and to reconsider the relative risks and benefits of continuing the use of an indwelling catheter. Because the major factors other than an indwelling catheter that predispose individuals to bacteriuria, including physiological aging changes and chronic comorbid illnesses, cannot be modified readily, the facility should demonstrate that they employ infection prevention and control practices, e.g., standard precautions in managing catheters and associated drainage system. Keep the resident and catheter clean of feces to minimize bacterial migration into the urethra and bladder, e.g., cleaning fecal material away from, rather than towards, the urinary meatus. However, routine perineal care with an antiseptic is not recommended. Maintain free urine flow through any indwelling catheter, and assess for fluid needs and implement a fluid management program using alternative approaches as needed based on those assessed needs. Fecal incontinence. Fecal incontinence (FI) involves the unintentional loss of solid or liquid stool. A resident experiencing FI may experience feelings of shame, embarrassment, loss of independence, may tend to isolate himself/herself, creating a decrease in social interactions/activities due to fear of accidents with associated odors, leakage and soiling of clothing or furnishings. It is important for the facility and the attending practitioner to complete a comprehensive assessment and determine, with the resident/representative, potential treatment and care plan interventions, and to provide ongoing evaluation of the response to those interventions. The resident should be reevaluated whenever there is a change in bowel function. If the resident has FI that has already been investigated, documented, and determined to be irreversible or not significantly improvable, additional studies may be of limited value, unless there has been advancement in available treatments. Risk factors for fecal incontinence. Risk factors for FI may include aging and dependency in daily activities, smoking and pulmonary disease, arthritis in adults over 75 years of age, older adults with rectal cancer, comorbidities such as kidney disease, transient ischemic attacks in men, women with arterial hypertension. Acute stroke FI may depend on the severity of a stroke, functional dependency and need for assistance with toilet access 3 months after stroke in men and women, and poor general health and dementia. http://archive.gov/downloads/pubs/evidence/pdf/FUYAD/FUYAD-PDF. Assessment. To ensure that a resident who is incontinent of bowel receives appropriate treatment and services, the facility must conduct an assessment to identify the presenting symptoms and type of FI, including the potential reversible/irreversible causes and risks. Symptoms or types of FI may include as noted in http://s3 georg/physicians/guidelines/fecal incontinence PDF. Passive incontinence, which is the involuntary discharge of fecal matter or flatus without any awareness. This suggests a loss of perception and or impaired rectonal reflexes, either with or without sphincter dysfunction. Urge incontinence, which is the discharge of fecal matter or flatus in spite of active attempts to retain these contents. Here, there is a predominant disruption of the sphincter function or the rectal capacity to retain stool, and or fecal seepage, which is the undesired leakage of stool, often after a bowel movement with otherwise normal continence and evacuation. This condition is mostly due to incomplete evacuation of stool and or impaired rectal sensation. The sphincter function and pudendal nerve function are mostly intact. Causes and treatment of fecal incontinence. For reference, the following potential causes and treatments of FI have been adapted from the National Institute of Diabetes and Digestive and Kidney Diseases, NIDC, to address the long-term care setting. For the full description of causes and treatment for FI, refer to https://www.nidcnigov/healthinformation/digestive diseases/bowel control problems fecal incontinence/. Potential causes for FI may include diarrhea, constipation, muscle damage or weakness, trauma, childbirth injuries, cancer surgery and hemorrhoid surgery, nerve damage, loss of stretch in the rectum, childbirth by vaginal delivery, hemorrhoids and rectal prolapse, rectosal and inactivity. Potential treatment/interventions for FI should be based upon the type of FI. Potential treatment options and interventions may include eating increased amounts of fiber, drinking sufficient liquids, use of medications to develop more solid stools that are easier to control, pelvic floor exercises and biofeedback that strengthen the pelvic floor muscles. May improve bowel control. Success with pelvic floor exercises depends on the cause of fecal incontinence, its severity, and the person's motivation and ability to follow the healthcare provider's recommendations. Surgery may be an option for fecal incontinence that fails to improve with other treatments, or for fecal incontinence caused by pelvic floor or anal sphincter muscle injuries. Electrical stimulation, also called sacral nerve stimulation or neuromodulation, involves placing electrodes in the sacral nerves to the anus and rectum and continuously stimulating the nerves with electrical pulses. Care plan. For the resident with fecal incontinence, the care plan must reflect the results of the resident's assessment and include resident-specific interventions for any potential reversible causes, and, if irreversible, appropriate interventions for management of fecal incontinence. Interventions and the provision of care should address treating the resident with respect, enhancing dignity and self-worth, and reducing embarrassment and shame in relation to FI. Based upon the increased risk for transmission of infection resulting from fecal contamination, the care plan should also identify the PPE appropriate for use during the delivery of care. Complications potentially related to fecal incontinence. Complications related to fecal incontinence may include, but are not limited to, emotional distress, loss of self-esteem, social isolation, physical complications such as skin irritation/excoriation, itching, pain, and in addition, frequent loose stool may be an indicator of fecal impaction. Key elements of noncompliance to site-deficient practice at F690. The surveyor's investigation will generally show that the facility failed to do one or more of the following. Provide appropriate and sufficient services and assistance. 2. Maintain bladder continence and / or bowel function in continent residents. Or restore bladder continence and / or bowel function as possible, based on a comprehensive assessment and clinical condition. Or prevent urinary tract infections to the extent possible. Ensure that a resident is not catheterized unless required by his or her clinical condition. Or ensure that a urinary catheter is removed as soon as possible unless the catheter is necessary because of the resident's clinical condition. Investigative protocol. Use the bladder and bowel incontinence critical element C pathway and / or urinary catheter and UTI-CE pathway for the condition being evaluated, along with the above interpretive guidelines when determining if the facility provides the necessary care and services to meet the resident's needs. Summary of procedure. Briefly review the most recent comprehensive assessments, comprehensive care plan, and orders to identify whether the facility has assessed and developed an individualized care plan based on professional standards of practice, and provided by qualified, competent staff. During this review, identify the extent to which the facility has implemented interventions in accordance with the resident's needs, goals for care, and professional standards of practice, consistently across all shifts. This information will guide observations and interviews to be made in order to corroborate concerns identified. Note: always observe for visual cues of psychosocial distress and harm. See Appendix P, Guidance on Severity and Scope Levels, and Psychosocial Outcome Severity Guide. Deficiency categorization. In addition to actual or potential physical harm, always consider whether psychosocial harm has occurred when determining severity level. See Appendix P, Section Roman 4, E, Psychosocial Outcome Severity Guide. An example of severity level 4 noncompliance immediate jeopardy to resident health or safety includes, but is not limited to, the facility failed to ensure that a resident who entered the facility with an indwelling catheter was assessed for removal of the catheter as soon as possible, resulting in the resident continuing to have the catheter in place for 3 weeks and developing a urinary tract infection, leading to sepsis. The facility failed to provide appropriate treatment and services for a resident with fecal incontinence, resulting in the resident having severely excoriated and ulcerated areas of skin around the rectal area, with odor and purulent exudate. The resident expressed severe pain and refused to leave her room. Examples of severity level 3 noncompliance actual harm that is not immediate jeopardy includes, but is not limited to, the facility failed to assure that a resident who entered the facility with an indwelling catheter was assessed for removal of the catheter as soon as possible, unless the resident's clinical condition demonstrates that catheterization is necessary. During the survey, a resident was identified as having an indwelling urinary catheter in place for several months. The resident was currently being treated with an antibiotic for a symptomatic urinary tract infection. Staff interviewed were unable to provide the clinical indication for use for the catheter, and the record did not contain documentation for the initial use of the catheter or for the continued use of a urinary catheter. The resident was unable to be interviewed, but his representative was interviewed but did not know why the catheter was in place, except that the resident had a problem with incontinence. Record review indicated that the resident had experienced repeated complications, such as recurrent symptomatic UTIs, which required treatment with antibiotics. The facility failed to assure that a resident who was incontinent of bladder received the appropriate treatment and services to restore continence to the extent possible. A resident was identified as incontinent of bladder. Based upon the resident's assessment and identification of the type of urinary incontinence, the facility developed interventions for a restorative program to restore continence. However, based on observations, staff were not implementing the interventions on the care plan, did not respond to the resident's request for assistance with use of the bathroom, and were not monitoring the progress of the interventions. The resident stated that she was frustrated and embarrassed regarding the odors and wetness that occurred as a result of the incontinence episodes. She also stated that she did not attend activities or go for meals, as she needed close access to the toilet, and that she didn't want to be around others when she had incontinent episodes. She stated that she felt that she was not improving with her bladder continence, and that it was worse now than when she started the restorative program. Staff interviewed stated that they were aware of the program, but they were not able to implement the program consistently on all shifts, as they had other residents and duties assigned during their shifts and were unable to respond. The record reflected a decline in continence since the program began, also cited at sufficient staffing at F726. Examples of severity level 2 considerations. No actual harm with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to. The facility failed to provide appropriate treatment and services for care of a resident with a clinically justified indwelling catheter. During observations of care for a resident with an indwelling catheter, urine was noted to be leaking. Staff interviewed stated that they were not sure why the catheter leaked, but that they kept the resident as dry as possible. In addition, it was observed several times throughout the survey that the catheter drainage bag and tubing were placed directly on the floor in the resident's room. There were no indications of skin maceration and slash or irritation, or symptoms of a UTI symptoms. The facility failed to provide appropriate treatment and services for care of a resident who had intermittent fecal incontinence. During the survey, a resident was observed to stay in her room, did not attend activities, and had meals served in her room. The resident was identified as alert and aware of her care needs. She stated that she had problems with intermittent fecal incontinence and was on a bowel management program that included extra fiber and liquids. She stated that recently there were changes in meal service and she was not receiving the extra fiber. She also stated that staff were to assist her with hygiene when incontinence episodes occurred, but they had not consistently provided the care. She stated that when she had the fecal incontinence episodes, she did not attend activities she enjoyed attending, and was irritated that she was unable to attend due to not receiving hygiene when needed. Severity Level 1. No actual harm with potential for minimal harm. The failures of the facility to provide appropriate care and services to maintain or improve continence, manage indwelling catheters, and minimize negative outcome places residents at risk for more than minimal harm. Therefore, Severity Level 1 does not apply for this regulatory requirement. Resources. Research into appropriate practices to prevent, manage, and treat urinary incontinence, urinary catheterization, and UTI continues to evolve. Many recognized clinical resources on the prevention and management of urinary incontinence, infection, and urinary catheterization exist. Some of these resources include https://www.vumcorg/sites/vumcorg/CQA/files/public files/Vanderbilt%20 Incontinence %20 Management %20 Module PDF. Association for Professionals in Infection Control and Epidemiology, APIC, at www.apic.org. Centers for Disease Control at www.cdc.gov. The Annals of Long-Term Care Publications. http://www.annalsoflongtermcare.com/search keywords =urinary %20 catheters. Urology Care Foundation, the official foundation of the American Urological Association. http://www.urologyhealth.org/ the American Geriatrics Society at www.americangeriatrics.org, http://www.ncbinlmnigov/PMC/articles/PMC3538836/ Surveillance definitions of infections in long-term care facilities, revisiting the Mujir criteria. Resources for fecal incontinence, https://www.fascrs.org, http://www.ncbinlmnigov/PMC/articles/PMC2614622/ Tag F691. Section 483.2, 5F colostomy, urostomy, or ileostomy care. The facility must ensure that residents who require colostomy, urostomy, or ileostomy services receive such care consistent with professional standards of practice, the comprehensive person-centered care plan, and the resident's goals and preferences. Intent Section 483.2, 5F. The intent of this provision is that the resident receives the necessary care and treatment, including medical and nursing care and services, when they need colostomy, urostomy, or ileostomy care. Procedures and Probes Section 483.2, 5F refer to appropriate sections of the MDS, as applicable. Identify if the resident triggers any care area assessments for urinary incontinence, nutritional status, and slash or pressure injuries, skin care. If appropriate, is the resident provided with self-care instructions? Does the staff member observe and respond to any signs of the residents? Discomfort about the ostomy or its care. Is skin surrounding the ostomy free of excoriation, abrasion, breakdown? If excoriation is present, does the clinical record indicate an onset and a plan to treat the excoriation? Tag F692. Section 483.2, 5G assisted nutrition and hydration. Includes nasogastric and gastrostomy tubes, both percutaneous endoscopic gastrostomy and percutaneous endoscopic jejunostomy, and enteral fluids. Based on a resident's comprehensive assessment, the facility must ensure that a resident. Section 483.2, 5G1 maintains acceptable parameters of nutritional status, such as usual body weight or desirable body weight range and electrolyte balance, unless the resident's clinical condition demonstrates that this is not possible or resident preferences indicate otherwise. Section 483.2, 5G2 is offered sufficient fluid intake to maintain proper hydration and health. Section 483.2, 5G3 is offered a therapeutic diet when there is a nutritional problem, and the health care provider orders a therapeutic diet. Intent Section 483.2, 5G. The intent of this requirement is that the resident maintains, to the extent possible, acceptable parameters of nutritional and hydration status, and that the facility provides nutritional and hydration care and services to each resident, consistent with the resident's comprehensive assessment. Recognizes, evaluates, and addresses the needs of every resident, including but not limited to the resident at risk or already experiencing impaired nutrition and hydration, and provides a therapeutic diet that takes into account the resident's clinical condition and preferences when there is a nutritional indication. Definitions Section 483.2, 5G definitions are provided to clarify clinical terms related to nutritional status. Acceptable parameters of nutritional status refers to factors that reflect that an individual's nutritional status is adequate relative to his or her overall condition and prognosis, such as weight, food/fluid intake, and pertinent laboratory values. Artificial nutrition and hydration are medical treatments and refer to nutrition that is provided through routes other than the usual oral route, typically by placing a tube directly into the stomach, the intestine, or a vein. Clinically significant refers to effects, results, or consequences that materially affect or are likely to affect an individual's physical, mental, or psychosocial well-being either positively by preventing, stabilizing, or improving a condition or reducing a risk, or negatively by exacerbating, causing, or contributing to a symptom, illness, or decline in status. Dietary supplements refers to herbal and alternative products that are not regulated by the Food and Drug Administration, and their composition is not standardized. Dietary supplements must be labeled as such and must not be represented for use as a conventional food or as the sole item of a meal or the diet. Healthcare provider includes a physician, physician assistant, nurse practitioner, or clinical nurse specialist, or a qualified dietitian or other qualified nutrition professional acting within their state scope of practice, and to whom the attending physician has delegated the task. For issues related to delegation to dietitians, refer to Section 483.60E2, F808. Nutritional status includes both nutrition and hydration status. Nutritional supplements refers to products that are used to complement a resident's dietary needs, e.g., calorie or nutrient-dense drinks, total parenteral products, enteral products, and meal replacement products. Therapeutic diet refers to a diet ordered by a physician or other delegated provider that is part of the treatment for a disease or clinical condition, to eliminate, decrease, or increase certain substances in the diet, e.g., sodium or potassium, or to provide mechanically altered food when indicated. Tube feeding refers to the delivery of nutrients through a feeding tube directly into the stomach, duodenum, or jejunum. It is also referred to as an enteral feeding. Guidance Section 483.25G. It is important to maintain adequate nutritional status, to the extent possible, to ensure each resident is able to maintain the highest practicable level of well-being. The early identification of residents with, or at risk for, impaired nutrition or hydration status may allow the interdisciplinary team to develop and implement interventions to stabilize or improve nutritional status before complications arise. Body weight and laboratory results can often be stabilized or improved with time, but may not be correctable in some individuals. Intake alone is not the only factor that can affect nutritional status. Resident conditions and comorbidities may prevent improved nutritional or hydration status, despite improved intake. Many factors can influence weight and nutritional status as one ages. The body may not absorb or use nutrients as effectively. There may be changes in the ability to taste food too, or there may be a decreased sensation for thirst or hunger. The resident's medical condition can also affect how well they maintain weight, such as changes in muscle mass 3, cognitive status 4, nearing end of life, or a disease process, such as kidney disease or congestive heart failure, which may cause the resident to retain fluids in the body. While impaired nutritional status is not necessarily expected as one ages, there could be times where efforts to maintain good nutrition may pose extra challenges. Failure to identify residents at risk for compromised nutrition and hydration may be associated with an increased risk of mortality and other negative outcomes, such as impairment of anticipated wound healing, decline in function, fluid and electrolyte imbalance/dehydration, and unplanned weight change. 5. While food intake may be considered, ensuring a resident receives the fluids they require can more easily be overlooked. Individuals who do not receive adequate fluids are more susceptible to urinary tract infections, pneumonia, pressure injuries, skin infections, confusion, and disorientation. A systematic approach can help staff's efforts to optimize a resident's nutritional status. This process includes identifying and assessing each resident's nutritional status and risk factors, evaluating/analyzing the assessment information, developing and consistently implementing pertinent approaches, and monitoring the effectiveness of interventions and revising them as necessary. Weight loss, poor nutritional status, or dehydration should be considered avoidable unless the facility can prove it has assessed/reassessed the resident's needs, consistently implemented related care planned interventions, monitored for effectiveness, and ensured coordination of care among the interdisciplinary team. Assessment: a comprehensive nutritional assessment should be completed on any resident identified as being at risk for unplanned weight loss/gain and or compromised nutritional status. Through a comprehensive nutritional assessment, the interdisciplinary team clarifies nutritional issues, needs, and goals in the context of the resident's overall condition. Completion of the RAI does not remove the facility's responsibility to document a more detailed resident assessment when indicated to identify possible effective interventions. The nutritional assessment may utilize existing information from sources such as the RAI, assessments from other disciplines, the existing medical record, observation, direct care staff interviews, and resident and family interviews. The assessment should identify those factors that place the resident at risk for inadequate nutrition/hydration. The nutritional assessment may include the following information. General appearance. General appearance includes a description of the resident's overall appearance, e.g., robust, thin, obese, or cachectic. Other findings that may affect or reflect a resident's nutritional status may be included, such as the resident's cognitive status, affect, oral health and dentition, ability to use the hands and arms, and the condition of hair, nails, and skin. Height. Measuring a resident's height provides information that is relevant in conjunction with his or her weight to his or her nutritional status. There are various ways to estimate height if standing height cannot be readily measured. 6. A protocol for determining height helps to ensure that it will be measured as consistently as possible. Weight. Weight can be a useful indicator of nutritional status when evaluated within the context of the individual's personal history and overall condition. Weight goals should be based on a resident's usual body weight or desired body weight. The facility should have a procedure in place that includes, but is not limited to, establishing a consistent method of weighing a resident, e.g., using the same scale, wearing the same clothes, weighing at the same time of day, adjusting for use of a prosthetic, etc. Verifying the resident's weight upon admission, monitoring a resident's weight over time to identify weight loss/gain, verifying weight measurements when changes in weight occur, and reassessing interventions when appropriate. Current professional standards of practice recommend weighing the resident on admission or readmission to establish a baseline weight, weekly for the first 4 weeks after admission, and at least monthly thereafter to help identify and document trends such as slow and progressive weight loss. Weighing may also be pertinent if there is a significant change in condition, food intake has declined and persisted, e.g., for more than a week, or there is other evidence of altered nutritional status or fluid and electrolyte imbalance. In some cases, weight monitoring is not indicated, e.g., the individual is terminally ill and requests only comfort care. Examples of other factors that may impact weight and the significance of apparent weight changes include the resident's usual weight through adult life, current medical conditions, diet and supplement orders, recent changes in dietary intake, and edema. Suggested parameters for evaluating significance of unplanned and undesired weight loss are: interval 1 month, 3 months, 6 months. Significant loss, 5%, 7.5%, 10%. Severe loss, greater than 5%, greater than 7.5%, greater than 10%. The following formula determines percentage of weight loss. Percent of body weight loss equals usual weight actual weight / usual weight x 100. Interviews with key staff members. The facility may identify key individuals who should participate in the assessment of nutritional status and related causes and consequences. For example, nursing staff provide details about the resident's nutritional intake. Physicians and non-physician practitioners help identify relevant diagnoses, identify causes of weight changes, tailor interventions to the resident's specific causes and situation, and monitor the continued relevance of those interventions. Qualified dietitians help identify nutritional risk factors and recommend nutritional interventions based on each resident's medical condition, needs, preferences, and goals. Consultant pharmacists can help the staff and practitioners identify medications and medication interactions that may affect nutrition. Food and fluid intake. The nutritional assessment includes an estimate of calorie, nutrient, and fluid needs, and whether intake is adequate to meet those needs. It also includes information such as the route oral, enteral, or parenteral of intake, any special food formulation, meal and snack patterns including the time of supplement or medication consumption in relation to the meals, dislikes, and preferences including ethnic foods and form of foods such as finger foods. Meal/snack patterns and preferred portion sizes. While there is no reliable calculation to determine an individual's fluid needs, an assessment should take into account those characteristics pertinent to the resident, such as age, medical diagnoses, activity level, etc. Fluid loss or retention. Fluid loss or retention can cause short-term weight change. Much of a resident's daily fluid intake comes from meals. Therefore, when a resident has decreased appetite, it can result in fluid/electrolyte imbalance. Abrupt weight changes, change in food intake, or altered level of consciousness are some of the clinical manifestations of fluid and electrolyte imbalance. Laboratory tests, e.g., electrolytes, BUN, creatinine, and serum osmolality, can help greatly to identify, manage, and monitor fluid and electrolyte status. 7. Altered nutrient intake, absorption, and utilization. Poor intake, continuing or unabated hunger, or a change in the resident's usual intake that persists for multiple meals may indicate an underlying condition or illness. Examples of causes include, but are not limited to, the inability to consume meals provided as a result of cognitive or functional decline, difficulty with chewing or swallowing food, an inadequate amount of food or fluid, including insufficient tube feedings, an uncomfortable or disruptive dining environment, the lack of adequate assistance or supervision, adverse consequences related to medications, and diseases and conditions such as cancer, diabetes mellitus, advanced or uncontrolled heart or lung disease, infection and fever, liver disease, kidney disease, hyperthyroidism, mood disorders, gastrointestinal disorders, pressure injuries or other wounds, and repetitive movement disorders, e.g., wandering, pacing, or rocking. The use of diuretics and other medications may cause weight loss that is not associated with nutritional issues. This may result in a planned weight loss, e.g., the reduction of edema, but can also cause fluid and electrolyte imbalance/dehydration that causes a loss of appetite and weight if unmonitored. Early identification of these factors, regardless of the presence of any associated weight changes, can help the facility choose appropriate interventions to minimize any subsequent complications. Often, several of these factors affecting nutrition coexist. Laboratory/diagnostic evaluation. Laboratory tests are sometimes useful to help identify underlying causes of impaired nutrition, or when the clinical assessment alone is not enough to define someone's nutritional status. An additional assessment of other resident risk factors is often needed to confirm if a treatable clinical problem exists. 8. For example, low serum albumin levels may indicate malnutrition, but may also be the result of an acute illness for reasons unrelated to nutrition. Therefore, albumin levels may not improve, despite consumption of adequate amounts of calories and protein. The decision to order laboratory tests by the healthcare provider and the interpretation of subsequent results is best done in light of a resident's overall condition and prognosis. 9. Although laboratory tests such as albumin and prealbumin may help in some cases in deciding to initiate nutritional interventions. there is no evidence that they are useful for the serial follow-up of undernourished individuals. Point 9. Note, if laboratory tests were done prior to or after admission to the facility and the test results are abnormal, the physician or other licensed health care practitioner, in collaboration with the interdisciplinary team, reviews the information and determines whether to intervene or order additional diagnostic testing. Care planning information gathered from the nutritional assessment and current dietary standards of practice are used to develop an individualized care plan to address the resident's specific nutritional concerns and preferences. The care plan must address, to the extent possible, identified causes of impaired nutritional status, reflect the resident's personal goals and preferences, and identify resident-specific interventions and a time frame and parameters for monitoring. The care plan should be updated as needed, such as when the resident's condition changes, goals are met, interventions are determined to be ineffective, or as new causes of nutrition-related problems are identified. If nutritional goals are not achieved, the care-planned interventions must be reevaluated for effectiveness and modified as appropriate. Examples of goals may include, but are not limited to, a target weight range, desired fluid intake, the management of an underlying medical condition, e.g. diabetes, kidney disease, wound healing, heart failure, or infection, the prevention of unintended weight loss or gain. Weight stability, rather than weight gain, may sometimes be the most pertinent short-term or long-term objective for the nutritionally at risk or compromised resident. After an acute illness or as part of an advanced or end-stage medical condition, the resident's weight and other nutritional parameters may not return to previous levels and may stabilize at a lower level, sometimes indefinitely. Note, there should be a documented clinical basis for any conclusion that nutritional status or significant weight change are unlikely to stabilize or improve, e.g. physician's documentation as to why weight loss is medically unavoidable. The resident or the resident's representative's involvement in the development of the care plan helps to ensure it is individualized and meets their personal goals and preferences. See F551, Resident Representative. F553, Right to Participate in Care Planning, or Section 483.21, Comprehensive Resident-Centered Care Plans, for additional guidance. When preferences are not specified in an advance directive, decisions related to the possible provision of supplemental or artificial nutrition should be made in conjunction with the resident's family, and or representative in accordance with state law, taking into account relevant considerations such as condition, prognosis, and the resident's known values and choices. Note, the presence of a Do Not Resuscitate DNR order does not by itself indicate that the resident is declining other appropriate treatment and services. It only indicates that the resident has chosen not to be resuscitated if cardiopulmonary functions cease. Interventions related to a resident's nutritional status must be individualized to address the specific needs of the resident. Examples of care plan development considerations can include, but are not limited to, diet liberalization. Based on the resident's assessment, it could be beneficial to minimize restrictions, such as therapeutic or mechanically altered diets, and provide preferred foods before using supplementation. However, it is the responsibility of the facility to talk with the resident, their family and representative whenever possible, and provide information pertaining to the risks and benefits of a liberalized diet. Work with the resident's physician and other nursing home professionals' dietary manager, nurses, speech therapists, etc., using the care planning process to determine the best plan for the resident and accommodate the resident's needs, preferences, and goals. Weight-related interventions. For at-risk residents, the care plan should include nutritional interventions to address underlying risks and causes of unplanned weight loss or unplanned weight gain, based on the comprehensive or any subsequent nutritional assessment. The development of these interventions should involve the resident or the resident representative to ensure the resident's needs, preferences, and goals are accommodated. Environmental factors. Appetite is often enhanced by the appealing aroma, flavor, form, and appearance of food. Resident-specific facility practices that may help improve intake include providing a pleasant dining experience, e.g., flexible dining environments, styles, and schedules, providing meals that are palatable, attractive, and nutritious, e.g., prepare food with seasonings, serve food at proper temperatures, etc. And making sure that the environment where residents eat, e.g., dining room or residence room, is conducive to dining. Disease processes. A resident's clinical condition may have a significant impact on the types of interventions considered. The facility is responsible for identifying relevant diagnoses, e.g., wound healing, anorexia, end of life, etc., and appropriate interventions to address specific needs, as applicable. Functional factors. These include resident conditions that interfere with their ability to physically perform the task of eating or drinking adequately, such as the ability to use one's hands, vision, chewing and swallowing capabilities, or the ability to reposition one's self at the table. The underlying causes should be assessed to identify which interventions may be most effective. For example, a resident may experience a decline in his or her ability to chew food. If the underlying cause is poorly fitting dentures that are causing pain or are loose in the mouth, the intervention of modifying the food texture would not address the primary cause. The interventions used to address functional factors will depend on the resident's specific areas of concern and can vary. Some interventions used to address functional factors include using specialized dishes and utensils, having eyeglasses or hearing aids in use, ensuring dentures are securely placed, participating in a restorative eating program, or having direct assistance by staff or family. Other interventions may include ensuring food and drinks are readily accessible and in close physical proximity to individuals with mobility impairments. Modification of food and fluid consistency may be an appropriate intervention. However, it may unnecessarily decrease quality of life and impair nutritional status by affecting appetite and reducing intake. 1 Too many factors influence whether a swallowing abnormality eventually results in clinically significant complications, such as aspiration pneumonia. 13 Identification of a swallowing abnormality alone does not necessarily warrant dietary restrictions or food texture modifications. No interventions consistently prevent aspiration, and no tests consistently predict who will develop aspiration pneumonia. 14 For example, tube feeding may be associated with aspiration and is not necessarily a desirable alternative to allowing oral intake, even if some swallowing abnormalities are present. 1516 Medications. Medications may be helpful in improving a resident's nutritional status. Some ways medications may help a resident can be to increase appetite, reduce acid reflux, or reduce nausea. Some medications may have the unintended effect of impairing a resident's nutritional or hydration status, and the resident may experience a lack of appetite, nausea, dry mouth, or other unintended effects. Interventions may be required to address these. For example, a resident may require frequent sips of a drink during a meal if they experience dry mouth. It may also be appropriate to consider changing, stopping, or reducing the doses of those medications as appropriate. 17 For additional guidance related to medications, refer to Section 483.45d, F757, Unnecessary Drugs, or Section 483.45e, F758, Psychotropic Drugs. Food intake. Improving intake with wholesome foods is generally preferable to adding nutritional supplements. However, if the resident is not able to eat recommended portions at meal times, to consume between meals snacks/nourishments, Or if she prefers the nutritional supplement, supplements may be tried to increase calorie and nutrient intake. Taking a nutritional supplement during medication administration may also increase caloric intake without reducing the resident's appetite at mealtime. Examples of other interventions to improve food intake include fortification of foods, e.g., adding protein, fat, and or carbohydrate to foods such as hot cereal, mashed potatoes, casseroles, and desserts, offering smaller, more frequent meals, providing between-meal snacks or nourishments, or increasing the portion sizes of a resident's favorite foods and meals, and providing nutritional supplements. To date, the evidence is limited about benefits from appetite stimulants. While their use may be appropriate in specific circumstances, they are not a substitute for appropriate investigation of potentially modifiable risk factors and underlying causes of weight loss. Maintaining fluid and electrolyte balance. Poor fluid intake, abnormal lab values for electrolytes, some medications, and resident conditions may all affect a resident's fluid/electrolyte balance. Offering a variety of fluids during and between meals, assisting residents with drinking, keeping beverages available and within reach, and evaluating medications for placing a resident at risk for dehydration are examples of interventions that may be used to improve a resident's fluid balance. Alternate fluids, such as popsicles, gelatin, and ice cream, may also be offered. For some residents, a fluid restriction may be required to address conditions, such as edema or congestive heart failure, and may place them at greater risk for dehydration. Feeding tubes. Feeding tubes may be used to provide adequate nutrition to a resident who is not able to achieve it with other interventions. The liquid nourishment that is administered through a feeding tube is complete nourishment that must be prescribed to meet all the nutritional needs of the resident. Use F692 to guide the investigation into concerns regarding the nutritional adequacy of the prescribed formula. Concerns regarding care of feeding tubes and or complications related to their use should be investigated at F693. Note, for residents with end-stage dementia, the use of tube feeding does not necessarily extend life, prevent aspiration pneumonia, improve function, or limit suffering. For additional guidance related to feeding tubes, see 42 CFR Section 483.2, 5G45, F693, Enteral Nutrition. Total Parenteral Nutrition, TPN. TPN is a method of providing nutrition where a liquid formula is given into a vein through an intravenous catheter Roman IV to provide most of the nutrients a resident needs. This method is used when a resident cannot or should not eat or drink by mouth. A resident with TPN may require additional monitoring, such as more frequent weights, to ensure the treatment is effective. For additional guidance, see 42 CFR Section 483.2, 5H, F694, Parenteral Fluids. Note, if the resident and or the resident's representative exercises his or her right to choose and declines interventions designed to improve or maintain their nutritional or hydration status, the facility is responsible for discussing the risks and benefits associated with that decision and offer alternatives as appropriate. The comprehensive care plan should describe any interventions offered, but declined by the resident or resident's representative. CF 656, Comprehensive Care Plans. Ongoing monitoring of care-planned interventions is necessary for all residents. Ongoing monitoring should include, but is not limited to, interviewing the resident and or resident representative to determine if their personal goals and preferences are being met, directly observing the resident, interviewing direct care staff to gain information about the resident, the interventions currently in place, what their responsibilities are for reporting on these interventions, and possible suggestions for changes, if necessary. Reviewing the resident-specific factors identified as part of the comprehensive resident assessment and any supplemental nutrition assessment. as needed to determine if they are still relevant or if new concerns have emerged, such as new diagnoses or medications. Evaluating the care plan to determine if current interventions are being implemented and are effective. This can include reviewing weight records, meal monitors, intake and output logs, nurses' notes, lab values, and physician or dietitian assessments. Investigative protocol: use the nutrition and hydration critical element C pathway for the concerns being evaluated, along with the above interpretive guidelines when determining if the facility provides the necessary care and services to meet the residents' needs. Summary of procedure: briefly review the most recent comprehensive assessments, comprehensive care plan, and orders to determine whether the facility has assessed, identified, and addressed as appropriate the residents' nutritional and hydration needs. This information will guide observations and interviews to be made in order to corroborate concerns identified. Note: always observe for visual cues of psychosocial distress and harm. See Appendix P, Guidance on Severity and Scope Levels and Psychosocial Outcome Severity Guide. Key elements of noncompliance to site deficient practice at F692. The surveyor's investigation will generally show that the facility failed to do one or more of the following: accurately and consistently assess a resident's nutritional status on admission and as needed thereafter. Identify a resident at nutritional risk and address risk factors for impaired nutritional status to the extent possible. Identify, implement, monitor, and modify interventions as appropriate, consistent with the resident's assessed needs, choices, preferences, goals, and current professional standards of practice, to maintain acceptable parameters of nutritional status. Notify the physician as appropriate in evaluating and managing causes of the resident's nutritional risks and impaired nutritional status. Identify and apply relevant approaches to maintain acceptable parameters of residents' nutritional status, including fluids. Provide a therapeutic diet when ordered. Offer sufficient fluid intake to maintain proper hydration and health. Note: weight loss, abnormal protein and electrolyte lab values, and dehydration are not, by themselves, sufficient to support noncompliance at F692. Additionally, a resident does not need to experience weight loss, abnormal protein levels, or dehydration to show noncompliance. Deficiency categorization: in addition to actual or potential physical harm, always consider whether psychosocial harm has occurred when determining severity level. See Appendix P, Section Roman 4, E, Psychosocial Outcome Severity Guide. Examples of Severity Level 4 noncompliance: immediate jeopardy to resident health or safety include, but are not limited to, repeated, systemic failure to assess and address a resident's nutritional status and to implement pertinent interventions based on such an assessment, resulted in continued significant or severe weight loss and functional decline. Repeated failure to assist a resident who required assistance with meals and drink, resulted in or made likely the development of life-threatening symptoms, or the development or continuation of severely impaired nutritional status. Dietary restrictions or downgraded diet textures, such as mechanical soft or pureed textures, were provided by the facility against the residents' expressed preferences and resulted in substantial and ongoing decline in food intake, resulting in significant or severe unplanned weight loss with accompanying irreversible functional decline, to the point where the resident was placed on hospice. Or the failure to provide an ordered potassium-restricted therapeutic diet resulted in evidence of cardiac dysrhythmias or other changes in medical condition due to hyperkalemia. Examples of Severity Level 3 noncompliance: actual harm that is not immediate jeopardy includes, but are not limited to, the failure to revise and or implement the care plan addressing the resident's impaired ability to feed him/herself, resulted in significant, not severe, unplanned weight change and impaired wound healing not attributable to an underlying medical condition. The failure to identify a decrease in food intake, which resulted in a significant, unintended weight loss from declining food and fluids, which resulted in the resident becoming weakened and unable to participate in activities of daily living. The failure to assess the relative risks and benefits of restricting or downgrading diet and food consistency, or to accommodate a resident's choice to accept the related risk, resulted in declining food/fluid intake and significant weight loss. The failure to accommodate documented resident food dislikes and preferences resulted in poor food/fluid intake and a decline in function. Or the failure to provide a gluten-free diet, one free of wheat, barley, and rye products, as ordered for a resident with known celiac disease damage to the small intestine related to gluten allergy, resulted in the resident developing persistent gastrointestinal symptoms including significant, not severe, weight loss, chronic diarrhea, and occasional vomiting. Examples of severity level 2 noncompliance. No actual harm with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to: failure to obtain accurate weigh tests and to verify weigh tests as needed. The facility's intermittent failure to provide required assistance with eating resulted in poor intake. However, the resident met identified weight goals. Failure to provide additional nourishment when ordered for a resident. However, the resident did not experience significant or severe weight loss, and failure to provide a prescribed sodium-restricted therapeutic diet unless declined by the resident or the resident's representative, or not followed by the resident. However, the resident did not experience medical complications such as heart failure related to sodium excess. Severity level 1. No actual harm with potential for minimal harm. The failure of the facility to provide appropriate care and services to maintain acceptable parameters of nutritional status, which includes hydration, and minimize negative outcomes, places residents at risk for more than minimal harm. Therefore, severity level 1 does not apply for this regulatory requirement. Potential tags for additional investigation. During the investigation of F692, the surveyor may have determined that concerns may also be present with related outcome, process, and or structure requirements. The surveyor is cautioned to investigate these related requirements before determining whether noncompliance may be present. Some examples of related requirements that should be considered include Section 483.20, Resident Assessment, Section 483.2, 1 Comprehensive Person-Centered Care Planning, Section 483.24, Quality of Life, Section 483.3, 0 Physician Services, Section 483.35, Nursing Services, Section 483. And Section 483.75 CAPI. Tag F693. Section 483.2, 5G, Assisted Nutrition and Hydration. Includes nasogastric and gastrostomy tubes, both percutaneous endoscopic gastrostomy and percutaneous endoscopic jejunostomy, and enteral fluids. Based on a resident's comprehensive assessment, the facility must ensure that a resident. Section 483.2, 5G45 Enteral Nutrition Section, 483.2, 5G4 A resident who has been able to eat enough alone, or with assistance, is not fed by enteral methods, unless the resident's clinical condition demonstrates that enteral feeding was clinically indicated and consented to by the resident. And Section 483.2, 5G5 A resident who is fed by enteral means receives the appropriate treatment and services to restore, if possible, oral eating skills, and to prevent complications of enteral feeding including, but not limited to aspiration pneumonia, diarrhea, vomiting, dehydration, metabolic abnormalities, and nasopharyngeal ulcers. Definitions. Section 483.2, 5G45 Bolus feeding is the administration of a limited volume of enteral formula over brief periods of time. Continuous feeding is the uninterrupted administration of enteral formula over extended periods of time. Enteral feeding, also referred to as tube feeding, is the delivery of nutrients through a feeding tube directly into the stomach, duodenum, or jejunum. Feeding tube refers to a medical device used to provide liquid nourishment, fluids, and medications by bypassing oral intake. There are two basic categories, nasogastric and gastrostomy. The type of feeding tube used must be based on clinical assessment and needs of the resident, since there are various kinds of feeding tubes within each category. Gastrostomy tube. G-tube is a tube that is placed directly into the stomach through an abdominal wall incision for administration of food, fluids, and medications. The most common type is a percutaneous endoscopic gastrostomy PEG tube. Jejunostomy tube, aka percutaneous endoscopic jejunostomy, PEG, or J-tube, is a feeding tube placed directly into the small intestine. Nasogastric feeding tube. NG tube is a tube that is passed through the nose and down through the nasopharynx and esophagus into the stomach. Transgastric jejunal feeding tube. GJ tube is a feeding tube that is placed through the stomach into the jejunum, and that has dual ports to access both the stomach and the small intestine. Guidance Section 483.2, 5G45. A decision to use a feeding tube has a major impact on a resident and his or her quality of life. It is important that any decision regarding the use of a feeding tube be based on the resident's clinical condition and wishes, as well as applicable federal and state laws and regulations for decision-making about life-sustaining treatments. Considerations regarding the use of feeding tubes. The regulations at Section 483.2, 5G4, require that a feeding tube is not used unless there is a valid clinical rationale, and the resident, or if applicable, his or her representative has consented to its use. Consent implies that a discussion has occurred between the resident or representative and the physician or other member of the treatment team, explaining the process of receiving the tube and the risks and benefits. Several factors may be involved in the decision to use a feeding tube, including medical conditions that impair the resident's ability to maintain appropriate nutritional parameters, e.g., cerebrovascular accident, esophageal cancer, delirium, reconstructive facial or oral surgery. The need to improve the resident's nutritional status or level of comfort are also factors that may be involved in the decision to use a feeding tube. The duration of use of a feeding tube may vary, depending on the clinical situation and resident choice. The interdisciplinary team, with support and guidance from the physician, is responsible for assuring the ongoing review, evaluation, and decision-making regarding the continuation or discontinuation of all treatments, devices, or approaches implemented to care for the resident. Involving the resident, family, and or the resident's representative in discussions about the indications, use, potential benefits, and risks of tube feeding, types of approaches, and alternatives helps support the resident's right to make an informed decision to use or not use artificial nutrition and hydration. A clinically pertinent rationale for using a feeding tube includes, but is not limited to, an assessment of the resident's nutritional status, which may include usual food and fluid intake, pertinent laboratory values, appetite, and usual weight and weight changes. An assessment of the resident's clinical status, which may include the ability to chew, swallow, and digest food and fluid, underlying conditions affecting those abilities, e.g., coma, stroke, esophageal stricture, potentially correctable malnutrition that cannot be improved sufficiently by oral intake alone. Factors affecting appetite and intake, e.g., medications known to affect appetite, taste, or nutrition utilization, and prognosis. Relevant functional and psychosocial factors, e.g., inability to sufficiently feed self, stroke, or neurological injury that results in loss of appetite, psychosis that prevents eating, and interventions attempted prior to the decision to use a feeding tube and the resident's response to them. The use of a feeding tube may potentially benefit or may adversely affect a resident's clinical condition and or psychosocial well-being. Examples of some possible benefits of using a feeding tube may include addressing malnutrition and dehydration, promoting wound healing, and allowing the resident to gain strength, receive appropriate interventions that may help restore the resident's ability to eat, and perhaps return to oral feeding. Examples of some possible adverse effects of using a feeding tube may include diminishing socialization, including, but not limited to, the close human contact associated with being assisted to eat or being with others at mealtimes, not having the opportunity to experience the taste, texture, and chewing of foods, causing tube-associated complications, and reducing the freedom of movement related to efforts to prevent the resident from pulling on the tube or other requirements related to the tube or the tube feeding. In order to assure that the resident being fed by a feeding tube maintains the highest degree of quality of life possible, it is important to minimize possible social isolation or negative psychosocial impact to the degree possible, e.g., continuing to engage in appropriate activities, socializing in the dining room. Because of the possible side effects and discomfort associated with the use of nasogastric tubes, there should be clinically pertinent documentation for extended use of nasogastric tubes, e.g., greater than 30 days. Nutrition and feeding issues and their underlying causes in the resident with advanced dementia or other chronic neurological disorders, such as Parkinson's disease, present a particular set of issues and considerations that are discussed in F692. The extended use of enteral feeding tubes in individuals with advanced dementia does not necessarily extend life and remains controversial. The literature regarding enteral feeding of these individuals suggests that there is little evidence that enteral feeding improves clinical outcomes, e.g., prevents aspiration or reduces mortality. Consent of feeding tube should not be placed unless consented to by the resident or, if applicable, appropriately authorized resident representative. The resident has the right to make an informed decision about the treatment they receive. If a resident had a feeding tube placed prior to admission or in another care setting, the physician and interdisciplinary care team must review the basis, e.g., precipitating illness or condition change for the initial placement of the feeding tube and the resident's current condition. This is to determine if there is a continued rationale for its use and to ensure that its continued use is consistent with the resident's treatment goals and wishes. Decisions to continue or discontinue the use of a feeding tube are made through collaboration between the resident or a representative for a resident who lacks capacity to make and communicate such decisions, the physician, and the interdisciplinary care team. This includes a discussion of the relevance of a feeding tube to attaining a resident's goals, e.g., whether the nutritional intervention is likely to have a significant impact on the individual's underlying condition or overall status. Technical and nutritional aspects of feeding tubes. It is important that staff providing care and services to the resident who has a feeding tube are aware of, competent in, and utilize facility protocols regarding feeding tube nutrition and care. These protocols are required to be developed with the medical director in order to assure staff implement and provide care and services according to resident needs and professional standards of practice. Facility policies and procedures regarding the technical aspects of feeding tubes must be developed and implemented, which address monitoring the feeding tube, how to verify that the tube is functioning before beginning a feeding and before administering medications, which may include checking gastric residual volume, GRV-O not recommended for individuals who are alert and able to report symptoms that indicate a feeding is not well tolerated. O may be appropriate when initiating tube feedings or for individuals who are unable to report symptoms such as bloating, nausea, or abdominal pain. O actions to take based upon the amount of GRV vary depending on the individual and the clinical condition. O pH of GRV may indicate correct placement, i.e. pH 5, generally indicates gastric contents versus intestinal contents, but medications and feeding formulas can alter pH levels. O changes in GRV appearance may also be helpful in confirming placement, but should not be used in isolation. Observing changes in external length of tubing may indicate a change in position, but can only be used if the exit site was marked upon initial placement. This method does not apply to low-profile G-tubes tube that sits at skin level. Note, auscultation is no longer recommended for checking placement of the feeding tube. Movement of air would likely be heard whether the tube was in the correct or incorrect location. X-ray confirmation is the most accurate method for verification of tube placement when concerns arise regarding dislodgement or placement. Additional information regarding monitoring of feeding tubes may be found at https://www.ismporg/tools/articles/aspen PDF. Note, references to non-CMS/HHS sources or sites on the Internet included above or later in this document are provided as a services and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services. CMS is not responsible for the content of pages found at these sites. URL addresses were current at the date of this publication. Care of the feeding tube, securing a feeding tube externally, providing needed personal, skin, oral, and nasal care to the resident, examining and cleaning the insertion site in order to identify, lessen, or resolve possible skin irritation and local infection. Using infection control precautions and related techniques to minimize the risk of contamination, for example, in connecting the tube and the tube feeding, and defining the frequency of and volume used for flushing, including flushing for medication administration, and when a prescriber's order does not specify. Feeding tube replacement. Direction for staff regarding the conditions and circumstances under which a tube is to be changed, such as when to replace and slash or change a feeding tube, generally replaced either as planned/scheduled, or as needed, such as when a long-term feeding tube comes out unexpectedly, or a tube is worn or clogged. How and when to examine a feeding tube, and the infusion plug to identify splits or cracks that could produce leakage. Instances when a tube can be replaced within the facility and by whom. Instances when a tube must be replaced in another setting, e.g., hospital, ambulatory surgery center, and notification of the practitioner when the need for a tube change arises. Unexpectedly. Nutritional aspects of feeding tubes. When a resident is receiving nutrition via a feeding tube, the practitioner and the interdisciplinary team identify the resident's nutritional needs and facility procedures that direct staff in providing care and services to the resident. The practitioner's orders related to tube feeding typically include the following components: kind of feeding and its caloric value, volume, duration, and mechanism of administration, e.g., gravity or pump, and frequency of flush. Facility procedures regarding the nutritional aspects of feeding tubes include, but are not limited to, enteral nutrition, direction to staff regarding the nutritional product and meeting the resident's nutritional needs, such as types of enteral nutrition, formulas available for use, how to determine whether the tube feedings meet the resident's nutritional needs, and when to adjust them accordingly. How to balance essential nutritional support with efforts to minimize complications related to the feeding tube. Ensuring that the selection and use of enteral nutrition is consistent with manufacturers' recommendations. Ensuring that the administration of enteral nutrition is consistent with and follows the practitioner's orders, and ensuring that the product has not exceeded the expiration date, ensuring that additional water ordered for flushes or for additional hydration is administered per orders. Flow of feeding. Direction for staff regarding how to manage and monitor the rate of flow, such as use of gravity flow, use of a pump, periodic evaluation of the amount of feeding being administered for consistency. With practitioner's orders, calibration of enteral feeding pumps to ensure that pump settings accurately. Provide the rate and volume consistent with the resident's care plan, and periodic maintenance of feeding pumps consistent with manufacturers. Instructions to ensure proper mechanical functioning. Complications related to the feeding tube. An enteral feeding tube may be associated with significant complications, including aspiration, leaking around the insertion site, abdominal wall abscess, or erosion at the insertion site, including the nasal areas. Feeding tubes can perforate the stomach or small intestine, with resultant peritonitis. Esophageal complications of feeding tubes may also occur, including esophagitis, ulcerations, strictures, and tracheoesophageal fistulas. The use of tubes not designed or intended for enteral feeding may increase the risk of complications. 0.16. 17 tubes may clog for various reasons, including plugging by formula, pill fragments, or the precipitation of medications incompatible with the formula. 0.18. Flushing feeding tubes regularly and in association with medication administration. As indicated by current professional standards of practice and provided in the resident care policies, can help reduce the risk of clogging. Complications related to the administration of the enteral nutrition product. The administration of an enteral nutrition product may be associated with other complications, including, but not limited to, nausea, vomiting, diarrhea, abdominal cramping, inadequate nutrition, and aspiration. Additionally, interactions between the formula and various medications can affect the absorption and or effectiveness of the medication. For example, the effectiveness of phenytoin sodium dilantin, Phenitec, may be reduced by the drug binding with the enteral feeding's protein component, leading to less free drug availability and possibly inadequate therapeutic levels. Metabolic complications related to tube feeding may include inadequate calorie or protein intake, altered hydration, hypo or hyperglycemia, and altered electrolyte and nutrient levels. These risks may be reduced by calculating the nutritional needs of the resident, taking into account comorbid conditions and medications that affect these balances, monitoring for adequate nutritional status and complications, and adjusting the tube feeding accordingly. While a feeding tube may be initiated with the intent to address certain medical conditions, the use of a feeding tube does not necessarily decrease the risk of aspiration for individuals with other risk factors, such as moderate or less severe swallowing abnormalities. Aspiration risk may potentially be affected by factors such as diminished level of consciousness, improper positioning of the resident during administration of the feeding, and failure to assure the feeding tube is correctly positioned within the stomach or intestine. The evidence is inconsistent and conflicting regarding any connection between gastric residual volume (GRV) and the risk or occurrence of aspiration. 0.19. Risk of aspiration should be assessed individually and appropriate interventions, e.g., proper positioning, rate of flow implemented accordingly. There may be situations where other coexisting factors influence decisions about elevating the head of the bed. For example, a resident being fed by a tube who may be at risk for shearing by sliding down the sheets when the head of the bed is elevated to a recommended angle. Complications management. The facility is expected to identify and address actual or potential complications related to the feeding tube or tube feeding, and to notify and involve the practitioner in evaluating and managing care to address these complications and risk factors. Procedures Section 483.2. 5G45 use the tube feeding critical element C pathway, along with the above guidance, when determining if the facility utilized a feeding tube, only after adequate assessment of the resident's clinical condition to ensure this intervention is medically necessary and with the resident's consent. The surveyoress should use the following: observations, interviews, and record reviews to determine if a feeding tube is utilized, only if the resident's clinical condition makes this intervention medically necessary, and with the resident's consent. The surveyor must determine if a feeding tube is utilized in accordance with current professional standards of practice, and if services are provided to prevent complications to the extent possible. Additionally, for a resident whose goal is to restore normal eating skills to the extent possible, the surveyor must determine if the necessary care and services were provided to reach this goal. If there are concerns regarding the facility's use and care of feeding tubes, review facility policies and practices with regard to the use and care of feeding tubes. Key elements of noncompliance. To cite deficient practice at F693, the surveyor's investigation will generally show that the facility failed to do one or more of the following: ensure enteral feeding was clinically indicated, or ensure enteral feeding was consented to by the resident, or ensure a resident receiving enteral feeding received appropriate care and services. To restore oral eating skills, if possible, or ensure a resident receiving enteral feeding received appropriate care and services. To prevent complications of enteral feeding. Deficiency categorization, in addition to actual or potential physical harm. Always consider whether psychosocial harm has occurred when determining severity level. See Appendix P, Section Roman 4, E, Psychosocial Outcome Severity Guide. An example of Severity Level 4 noncompliance. Immediate jeopardy to resident health or safety includes but is not limited to: the facility failed to properly set up the tube feeding pump and to monitor a cognitively impaired resident receiving the tube feeding, resulting in the resident receiving too much liquid nourishment at a rate too fast to be absorbed. The resident was found to be unresponsive, with excess liquid nourishment coming from his or her nose and mouth. An example of Severity Level 3 considerations. Actual harm that is not immediate jeopardy includes, but is not limited to: the facility failed to monitor for complications related to a resident's feeding tube and tube feeding. As a result, the resident experienced significant but not serious tube feeding-related complications. Or, examples of Severity Level 2 noncompliance. No actual harm with potential for more than minimal harm that is not immediate jeopardy includes, but is not limited to: as a result of staff failure to anchor a feeding tube properly, the resident had leakage and irritation around the tube insertion site that required topical treatment and resolved without complications. As a result of staff failure to manage a tube feeding pump properly, the resident did not receive the calculated amount of tube feeding, without resulting in significant weight loss or other GI complications. Or, as a result of staff failure to consistently flush a resident's feeding tube as ordered, the tube clogged and had to be replaced, but there were no other complications. Severity Level 1. No actual harm with potential for minimal harm. The failure of the facility to provide appropriate care and services for feeding tubes places the resident at risk for more than minimal harm. Therefore, Severity Level 1 does not apply for this regulatory requirement. Potential tags for additional investigation. If there are concerns identified regarding the resident receiving adequate nutrition/hydration when receiving tube feeding, review F692, Assisted Nutrition and Hydration, for further investigation. If there is lack of consent related to the placement of a feeding tube, cite those deficiencies here instead of the resident rights, since this regulatory language is specific to consent for a feeding tube. Tag F694. Section 483.2, 5H Parenteral Fluids. Parenteral fluids must be administered consistent with professional standards of practice and in accordance with physician orders, the comprehensive person-centered care plan, and the resident's goals and preferences. Intent Section 483.2, 5H. The intent of this requirement is that the facility assures that each resident receives care and services for the provision of parenteral fluids consistent with professional standards of practice in order to provide safe administration of parenteral fluids by qualified, competent, and trained staff in accordance with state laws/practice acts. Care consistent with the resident's input, goals, and preferences as delineated in the care plan, and ongoing support of the resident during parenteral treatments, including monitoring the resident's status, monitoring for complications, and assuring the provision of appropriate infection control practices. Definition Section 483.2. 5H parenteral fluid is the delivery of fluid or medication through an intravenous, subcutaneous, intramuscular, or mucosal route. Taber's Online Medical Dictionary. https://www.tabers.com/tabersonline/ to maintain adequate hydration, restore and or maintain fluid volume, re-establish lost electrolytes, or provide nutrition, which includes total parenteral nutrition (TPN). Intravenous Roman IV therapy is the administration of parenteral fluids or medications through an Roman IV catheter to treat a condition. Note: references to non-CMS/HHS sources or sites on the Internet included above or later in this guidance are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services. CMS is not responsible for the content of pages found at these sites. URL addresses were current at the date of this publication. Guidance Section 483.2. 5H. There is no requirement that a facility must offer Roman IV therapy. If the facility has an arrangement with an outside contractor for the provision of Roman IV therapy, the facility must inform each resident before or at the time of admission, and periodically during the resident's stay, of such services if available in the facility. Residents of a facility may receive Roman IV therapy through options such as the following. The facility provides the Roman IV therapy either directly or under contract with individuals to provide the services. However, these individuals must be qualified, trained, and competent in accordance with professional standards of practice, licensure, and state practice acts/laws. Or, if a current resident needs and agrees to receive Roman IV therapy, and the facility does not allow such services to be administered on-site, the facility must assist the resident with the transfer to another facility or with the relocation to another setting, e.g. private home or residential/assisted living facility of his or her choice that provides Roman IV therapy. For facilities who offer Roman IV therapy, the facility must develop and implement resident care policies based upon current professional standards of practice for the preparation, insertion, administration, maintenance, and discontinuance of Roman IV, as well as for the prevention of infection at the site to the extent possible. The procedures must include the care and use of all equipment, such as pumps, tubing, syringes, fluids, etc. The facility minimizes risks to a resident receiving Roman IV therapy by developing and implementing policies that adhere to professional standards of practice, which may include, but are not limited to, use of appropriate hand hygiene during all aspects of Roman IV therapy, use of aseptic technique when placing a venous access device, use of appropriate antiseptic, e.g., chlorhexidine, povidone iodine, and iodophor, or 70% alcohol, which is recommended in CDC guidelines to scrub Roman IV ports, needleless connectors, and hubs prior to access or use. Use of personal protective equipment, PPE, based on potential for exposure to blood, bodily fluids, and infectious agents. Competency of staff to use infusion equipment, accurately perform Roman IV insertion and maintain vascular access, and assess for complications. Administration of solutions according to orders. Correct solution, administration route, central/peripheral line, duration, frequency, and infusion rate, labeling and dating, as appropriate, infusion fluids and lines. Frequency of assessment of Roman IV catheter to assess the insertion site for signs and symptoms of infection or inflammation, i.e., at least daily or with each use. Frequency may depend upon such factors as the ability of resident to report symptoms of pain, redness, etc. Type of infusion, is it an irritant or vesicant? Location of Roman IV catheter, is it inserted in an area of flexion? And facility policy based on long-term care pharmacy Roman IV policies and procedures. Assessment of continued need for the catheter if not being used for Roman IV fluids or medications. According to the CDC, the following terminology has been used to describe Roman IV catheters. Terminology and estimates of risk. The terminology used to identify different types of catheters is confusing because many clinicians and researchers use different aspects of the catheter for informal reference. A catheter can be designated by the type of vessel it occupies, e.g., peripheral venous, central venous, or arterial, its intended lifespan, e.g., temporary or short-term versus permanent or long term, its site of insertion, e.g., subclavian, femoral, internal jugular, peripheral, and midline or peripherally inserted central catheter PIC, its pathway from skin to vessel, e.g., tunneled versus non-tunneled, its physical length, e.g., long versus short, or some special characteristic of the catheter, e.g., presence or absence of a cuff, impregnation with heparin, antibiotics or antiseptics, and the number of lumens. To accurately define a specific type of catheter, all of these aspects should be described. Table 1. https://www.cdc.gov/hi/pdfs/bsi guidelines 2011 PDF. Complications/risks of intravenous fluid administration of Roman IV fluids may be required to restore or maintain adequate hydration, replace electrolytes, or provide partial nutrition. However, because it is invasive, administration of Roman IV fluids has associated risks such as infiltration, bruising, embolism, air or blood, phlebitis, fluid overload, electrolyte imbalance, and infection cellulitis, septicemia. Note: refer to Centers for Disease Control (CDC) guidelines for the prevention of intravascular catheter-related infections found at https://www.cdc.gov/hi/pdfs/bsi guidelines 2011 PDF. In addition to adhering to professional standards of practice, facilities are responsible to administer Roman IV therapy according to the resident-centered care plan and in accordance with physician's orders and the resident's goals, preferences, and advance directives, as applicable and according to state law. Investigative procedures. Observations. Observe the resident to determine: are there signs of inflammation or infiltration at the insertion site, and has site been changed according to current, professional standards of practice? If the rate of parenteral fluid being administered reflects that which was ordered by the physician. If the resident received the amount of fluid during the past 24 hours that she should have received according to the physician's orders, allow flexibility up to 150 cc, unless an exact fluid intake is critical for the resident. Observe staff accessing the port and changing the Roman IV site, tubing, or bottle/bag, if possible. Determine if the central venous or peripheral access port, needleless connector, and hub was scrubbed with an appropriate antiseptic prior to access or use. Determine whether aseptic technique is maintained in accordance with current, professional standards of practice. Record review. Review the medical record and comprehensive care plan, or baseline, if the resident's admission was within 14 days of the review for residents receiving Roman IV therapy to determine if the clinical record includes documentation to support the need for Roman IV therapy. If the resident has orders for parenteral fluid, note the solution type, administration route, frequency, and infusion rate to compare to observations. How frequently staff are to change Roman IV tubing. Review facility policies and procedures related to Roman IV therapy to determine if policies and or procedures address aseptic technique for Roman IV insertion, maintenance of Roman IV site, frequency of Roman IV site, tubing and bag changes, and do they reflect current professional standards of practice, documentation for the continued need for the Roman IV catheter if no longer being used. For Roman IV fluid or medication. Interviews. Interview the resident or, if applicable, the resident representative to determine if they understand why the resident is receiving parenteral fluid, if the resident has had any complications or concerns related to the Roman IV therapy. Interview staff to determine if there are specific qualifications and or competencies required for staff who perform Roman IV insertion, Roman IV maintenance, and parenteral fluid administration. Deficiency Categorization Section 483.2 5H examples of severity level 4 noncompliance immediate jeopardy to resident health or safety include, but are not limited to, facilities' failure to adhere to sterile technique during maintenance of Roman IV therapy that lead to sepsis and resulted in the resident's hospitalization or death. Facilities' failure to monitor administration of fluid that resulted in overload of cardiovascular system, resulting in hospitalization or death. Examples of severity level 3 noncompliance actual harm that is not immediate jeopardy include, but are not limited to, facilities' failure to monitor for complications related to Roman IV therapy, resulting in infiltration of the Roman IV, causing the resident to experience pain and swelling. Facilities' failure to ensure a resident received fluids as ordered, resulting in dehydration, which was later reversed after staff became aware. Examples of severity level 2, noncompliance, no actual harm with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to, facilities' failure to consistently flush a resident's Roman IV site, resulting in the Roman IV becoming clogged and requiring replacement. Facilities' failure to anchor the Roman IV needle and tubing, resulting in leakage around the Roman IV site that required topical treatment and resolved without complications. Severity level 1 noncompliance, no actual harm with potential for minimal harm. The failures of the facility to provide appropriate care and services related to parenteral fluids places the resident at risk for more than minimal harm. Therefore, severity level 1 does not apply for this regulatory requirement. Potential tags for additional investigation. If noncompliance with parenteral therapy is related to staff competency issues, also consider F725, Section 483.3 5A3, Nursing Services. If noncompliance with parenteral therapy is related to accuracy of fluid type or amount, also consider F755, Section 483.45 Pharmacy Services. If noncompliance with parenteral therapy is related to lack of equipment such as Roman IV tubing, pumps, etc., also consider F907 Section 483.9 0D space and equipment. If noncompliance with parenteral therapy is related to the provision of adequate nutrition/hydration, also consider F692 Section 483.2 5G. Assisted nutrition and hydration. Tag F695. Section 483.2 5I respiratory care, including tracheostomy care and tracheal suctioning. The facility must ensure that a resident who needs respiratory care, including tracheostomy care and tracheal suctioning, is provided such care, consistent with professional standards of practice, the comprehensive person-centered care plan, the resident's goals and preferences, and 483.65 of this subpart. Intent Section 483.25 I. The intent of this provision is that each resident receives necessary respiratory care and services that is in accordance with professional standards of practice, the resident's care plan, and the resident's choice. Definitions Section 483.25I, Automatic Self-Adjusting Positive Airway Pressure APAP. A PAP is a non-invasive ventilation machine that automatically adjusts the air pressure according to the patient's requirement at a particular time. Bilevel Positive Airway Pressure BiPAP. BiPAP is a non-invasive ventilation machine that is capable of generating two adjustable pressure levels: inspiratory positive airway pressure, IPAP, high amount of pressure, applied when the patient inhales, and a low expiratory positive airway pressure, EPAP, during exhalation. Continuous positive airway pressure, CPAP. CPAP is a non-invasive ventilation machine that involves the administration of air, usually through the nose, by an external device at a predetermined level of pressure. Hypoxia means decreased perfusion of oxygen to the tissues. Hypoxemia means decreased oxygen level in arterial blood. Intermittent positive pressure breathing, IP, is a technique used to provide short-term or intermittent mechanical ventilation for the purpose of augmenting lung expansion, delivering aerosol medication, or assisting ventilation, and can include pressure and time-limited as well as pressure, time, and flow-cycled ventilation, and may be delivered to artificial airways and non-intubated patients. Mechanical ventilation may be defined as a life support system designed to replace or support normal ventilatory lung function. Point 1. Non-invasive ventilation (NIV) refers to the administration of ventilatory support without using an invasive artificial airway, endotracheal tube, or tracheostomy tube. 1. Obstructive sleep apnea (OSA) refers to apnea syndromes due primarily to collapse of the upper airway during sleep. Oxygen therapy is the administration of oxygen at concentrations greater than that in ambient air, 20.9%, with the intent of treating or preventing the symptoms and manifestations of hypoxia. Respiratory therapy service are services that are provided by a qualified professional respiratory therapists, respiratory nurse for the assessment, treatment, and monitoring of residents with deficiencies or abnormalities of pulmonary function. See Section 483.65, Specialized Rehabilitative Services. Tracheotomy or tracheostomy is an opening surgically created through the neck into the trachea windpipe to allow direct access to the breathing tube, and is commonly done in an operating room under general anesthesia. A tube is usually placed through this opening to provide an airway and to remove secretions from the lungs. Breathing is done through the tracheostomy tube rather than through the nose and mouth. The term tracheotomy refers to the incision into the trachea windpipe that forms a temporary or permanent opening, which is called a tracheostomy. However, the terms are sometimes used interchangeably. Ventilator-assisted individual VI requires mechanical aid for breathing to augment or replace spontaneous ventilatory efforts to achieve medical stability or maintain life. 2. Guidance Section 483.25I. Changes in the respiratory system related to aging may lead to the development of or difficulty/challenges in treating diseases in the respiratory system, and may impact treatments/interventions. The Minimum Data Set (MDS) has identified the most frequent respiratory diseases/syndromes that a resident may have been admitted with or required after admission to a nursing home, including but not limited to pneumonia, asthma, chronic obstructive pulmonary disease (COPD), chronic lung disease, chronic bronchitis, and restrictive lung diseases such as asbestosis, respiratory failure, shortness of breath, dyspnea with exertion, or when sitting at rest, lying flat, or during an illness such as influenza. In addition, residents have been admitted with or previously had acute respiratory distress syndrome (ARDS), lung cancer, obstructive sleep apnea, or a history of tuberculosis. Various modalities/treatments for respiratory care identified on the MDS include respiratory treatments/therapy, Oxygen therapy, the use of BiPAP/CPAP, tracheostomy and slash or suctioning, and some facilities provide chest tube and mechanical ventilation services/care. Based upon its facility assessment, the resident population, diagnosis, staffing, resources, and staff skills/knowledge, the facility must determine whether it has the capability and capacity to provide the needed respiratory care/services for a resident with a respiratory diagnosis or syndrome that requires specialized respiratory care and/or services. This includes, at a minimum, sufficient numbers of qualified professional staff, established resident care policies, and staff trained and knowledgeable in respiratory care before admitting a resident that requires those services. Resident care policies. The facility, in collaboration with the medical director, director of nurses, and respiratory therapist, as appropriate, must assure that resident care policies and procedures for respiratory care and services are developed according to professional standards of practice. Prior to admission of a resident requiring specific types of respiratory care and services. Also refer to F841, Section 483.70G Medical Director, the policies and procedures, based on the type of respiratory care and services provided, may include, but are not limited to, oxygen services, including the safe handling, humidification, cleaning, storage, and dispensing of oxygen. Types of respiratory exercises provided such as coughing/deep breathing, and if provided therapeutic percussion/vibration and bronchopulmonary drainage. Aerosol drug delivery systems, nebulizers/metered dose inhalers, and medications preparation and/or administration used for respiratory treatments. BiPAP/CPAP treatments, delineation for all aspects of the provision of mechanical ventilation/tracheostomy care, including monitoring, oversight, and supervision of mechanical ventilation, tracheostomy care and suctioning, and how to set, monitor, and respond to ventilator alarms. Emergency care, which includes staff training and competency for implementation of emergency interventions for, at a minimum, cardiac/respiratory complications, and include provision of appropriate equipment at the resident's bedside for immediate access, such as for unplanned extubation. Procedures to follow in the advent of adverse reactions to respiratory treatments or interventions, including mechanical ventilation, tracheostomy care, and provision of oxygen. Respiratory assessment, including who can conduct each aspect of the assessment, what is contained in an assessment, when and how it is conducted, the type of documentation required. Maintenance of equipment for respiratory care in accordance with the manufacturer specifications and consistent with federal, state, and local laws and regulations, such as oxygen equipment or equipment for mechanical ventilation if provided, how and by whom the equipment is serviced and how it is maintained. Emergency power for essential equipment such as mechanical ventilation, if provided. Infection control measures during implementation of care, handling, cleaning, storage, and disposal of equipment. Supplies, biohazardous waste and including infection control practices for mechanical ventilation/tracheostomy care, including the use of humidifiers, and posting of cautionary and safety signs indicating the use of oxygen, and staffing and qualified personnel. Refer to Section 483.65, Specialized Rehabilitative Services, for review of provision of services by qualified personnel. When providing respiratory care, the facility must, based on professional standards of practice, have sufficient numbers of trained, competent, qualified staff, consistent with State Practice Act/laws, and identify who is authorized to perform each type of respiratory care service, such as responding to mechanical ventilator alarms, suctioning, and tracheostomy care. Note: surveyors are expected to determine the scope of practice and state laws regarding who may provide mechanical ventilation and/or tracheostomy care in their state. Monitoring and documentation of respiratory services / response. Staff should document, based on current professional standards of practice, the assessment and monitoring of the resident's respiratory condition, including response to therapy provided and any changes in the respiratory condition. Depending on the type of respiratory services the resident receives, physician orders, and the individualized respiratory care plan, documentation should include as appropriate. Vital signs, including the respiratory rate, chest movement and respiratory effort, and the identification of abnormal breath. Sounds, signs of dyspnea, cyanosis, coughing, whether position affects breathing. Characteristics of sputum, signs of potential infection, or the presence of behavioral changes that may reflect hypoxia, including anxiety, apprehension, level of consciousness, and instructions for the resident on how to participate / assist in the respiratory treatments as appropriate. The attending practitioner must be immediately notified of significant changes in condition, and the medical record must reflect the notification, response, and interventions implemented to address the resident's condition. Also, refer to Section 483.10 G14 F580 for notification of physician, family of significant changes. Modalities / respiratory therapy / care / services. A variety of respiratory therapy modalities and care may be provided in the nursing home, including coughing / deep breathing, therapeutic percussion / vibration and postural. Drainage, aerosol / nebulizers, humidification, and therapeutic gas administration, BiPAP or CPAP, tracheostomy care and tracheal suctioning, and mechanical ventilation and oxygenation support. Coughing / deep breathing, therapeutic percussion / vibration, and bronchopulmonary drainage. If a resident has written orders for postural drainage, chest percussion, and vibration to increase the mobility of pulmonary secretions, the care plan must include, based upon the resident's assessments and identified needs, the type of exercise, including when and how often provided. The resident's record should reflect how staff are monitoring the condition of the resident prior to, during, and after the treatments, and, as appropriate, vital signs including the respiratory rate, pulse oximetry, presence of dyspnea, and / or signs of infection. The record should reflect the resident's response to the treatment and notification of the practitioner if necessary for a change in the resident's condition, or, as necessary, the need to revise or alter the respiratory care provided. Refer to Section 483.10 G14 F580 for notification of physician of significant changes. Respiratory medications via aerosol generators. There are 3 common types of aerosol generators used for inhaled drug delivery. A small volume nebulizer SVN, a pressurized metered dose inhaler PMDI, and a dry powder inhaler DPI. Note, for information related to aerosol delivery devices include, for example, the specific devices manufacturer's guidelines for use, and Guide to Aerosol Delivery Devices for Physicians, Nurses, Pharmacists, and Other Healthcare Professionals. American Association for Respiratory Care, 2013, http://www.org/app/uploads/2014/08/aerosol guide pro PDF. Oxygen O2 therapy. Oxygen therapy may be provided through various types of supply and delivery systems. Equipment may include the provision of oxygen through nasal cannulas, transtracheal oxygen catheters, oxygen canisters, cylinders, or concentrators. For a resident receiving oxygen therapy, the resident's record must reflect ongoing assessment of the resident's respiratory status, response to oxygen therapy, and include, at a minimum, the attending practitioner's orders and indication for use. In addition, the record should include the type of respiratory equipment to use, baseline SpO2 levels, and to initiate and / or discontinue oxygen therapy. If the resident is ambulatory with his or her oxygen delivery system, The resident must be informed of safety precautions and prohibitions for oxygen, such as where smoking is allowed or other hazardous areas, and staff should monitor to assure the resident adheres to the safety rules for oxygen. The resident's care plan should identify the interventions for oxygen therapy based upon the resident's assessment and orders, such as, but not limited to, the type of oxygen delivery system, when to administer, such as continuous or intermittent, and or when to discontinue, equipment settings for the prescribed flow rates, monitoring of SpO2 levels and or vital signs as ordered, and, based upon the individual resident's risks, if applicable, monitoring for complications, such as skin integrity issues related to the use of a nasal cannula. Note, for reference, American Association for Respiratory Care Clinical Practice Guideline Oxygen Therapy in the Home or Alternate Site Healthcare Facility, 2007, revision and update P1063 to 1067 http://www.rcjournalcom/cpgs/pdf/08.07.1063 PDF. Obstructive sleep apnea. Obstructive sleep apnea, OSA, refers to apnea syndromes due primarily to collapse of the upper airway during sleep. Non-pharmacologic medical treatments may include weight reduction, tongue-retaining devices, positive airway pressure modalities, such as continuous positive airway pressure (CPAP) and bilevel positive airway pressure (BiPAP). CPAP involves the administration of air, usually through the nose, by an external device at a fixed pressure to maintain the patency of the upper airway. BiPAP is similar to CPAP, but the devices are capable of generating two adjustable pressure levels. Other treatment methods for OSA may include the use of medications, surgical procedures. For a resident with OSA, the resident's record must reflect ongoing assessment of the resident's respiratory status, response to therapy, and include, at a minimum, the attending practitioner's orders and indication for use. In addition, the record should include the equipment settings, when to use the equipment, and humidification as appropriate. The care plan should identify the interventions for OSA based upon the resident's assessment and orders, such as, but not limited to, the type of equipment and settings, and when to administer, and, based upon the individual resident's risks, if applicable, monitoring for complications, respiratory services for mechanical ventilation, and or tracheostomy/tracheotomy care. The guidance related to care of residents receiving mechanical ventilation applies to facilities who provide this type of care. Mechanical ventilation is defined as a life support system designed to replace and or support normal ventilatory lung function. A ventilator-assisted individual VI may require mechanical aid for breathing to augment or replace. Spontaneous ventilatory efforts to achieve medical stability or maintain life. Persons requiring long-term invasive ventilatory support have demonstrated an inability to become completely weaned from invasive ventilatory support, or a progression of disease etiology that requires increasing ventilatory support. Due to the clinically complex nature of the provision of care for a resident receiving mechanical ventilation, there must be an active, ongoing interdisciplinary approach to the resident's care, including but not limited to participation as needed by the physician/practitioner, pulmonologist, registered nurse, pharmacist, dietitian, speech therapist, respiratory therapist, physical and or occupational therapist, and the resident/representative. The facility, in collaboration with the attending practitioner, must provide a comprehensive assessment of the resident's respiratory needs. The facility must provide an assessment of resident-specific communication methodologies, including assessing current visual/hearing needs, cognition, level of consciousness, and identifying potential methods for communication such as writing, communication cards/boards, and or computer access. The results of the assessment must be used in the development and implementation of a person-centered care plan. A resident receiving mechanical ventilation and or tracheostomy care is dependent on staff to provide care according to the practitioner's orders. The comprehensive assessment and individualized care plan, including, but not limited to communication, positioning and range of motion, nutrition, hydration, ADLs, bladder and bowel management. Monitoring for resident-specific risks for possible complications, psychosocial needs, as well as mechanical ventilation and tracheostomy care including suctioning as appropriate. The facility must provide consistent implementation of all aspects of care related to the provision of mechanical ventilation and tracheostomy care, in accordance with accepted professional standards of practice, including emergency interventions as appropriate. Staff must be trained and competent in application of life support interventions in case of emergency situations, such as cardiac and or respiratory complications related to mechanical ventilation and environmental emergencies, such as power outages. Care plan for mechanical ventilation / tracheostomy care. Based upon the resident assessment, attending practitioner's orders, and professional standards of practice, the facility, including the resident / representative, to the extent possible, must develop and implement a care plan that includes appropriate interventions for respiratory care. The facility must develop a care plan based on the resident's individualized assessment that may include communication needs and methods, positioning, skin integrity and redistribution of pressure, i.e., use of specialized mattresses / equipment / positioning, nutritional support, specialized care such as enteral nutrition, bowel and bladder management, provision of oral and eye care, monitoring for psychosocial needs such as depression or anxiety, as ordered by the practitioner, and or as appropriate, monitoring respirations and respiratory rates, heart rates, presence of cyanosis, dusky coloring or other color changes related to respiratory / circulatory conditions, symmetry of chest expansion / movement, diaphoresis, lethargy, vital signs and parameters including pulse oximetry. Care of a resident who is cognitively impaired and may exhibit restlessness and pulling at tubing. Adjunctive interventions, as appropriate, such as medications, aerosol bronchodilators, chest physiotherapy, oxygen therapy, and or secretion clearance devices. And identification of resident-specific risks for possible complications that may include unplanned extubation, aspiration, and the potential for respiratory infection, tracheal bronchitis, ventilator-associated pneumonia VAP, nutritional complications related to tube feedings, gastric distress, increased or decreased CO2 levels, development of oral or ocular ulcers, barotrauma, deep vein thrombosis due to immobility, and or airway complications such as tracheal infections, mucus plugging, tracheal erosion and or stenosis, advanced directives, if any, type of ventilator equipment, settings, and alarms refer to physician's orders, and manufacturer's specifications for use and care, and type and size of airway and care of artificial airway. Procedure, Section 483.25I. Use the respiratory care critical element C pathway, along with the above interpretive guidelines when determining if the facility provides the necessary care and services to ensure that a resident receives the respiratory care and services as ordered to meet his or her needs. Surveyors should use the guidance above as general information about the professional standards of practice regarding the provision of care under this tag. It is not intended to prescribe a clinical course for a specific resident. Summary of procedure. Briefly review the most recent comprehensive assessments, comprehensive care plan, and orders to identify whether the facility has assessed and developed an individualized care plan based on professional standards of practice and provided by qualified, competent staff. During this review, identify the extent to which the facility has implemented interventions in accordance with the resident's needs, goals for care, and professional standards of practice, consistently across all shifts. This information will guide observations and interviews to be made in order to corroborate concerns identified. Note: always observe for visual cues of psychosocial distress and harm. See Appendix P, Guidance on Severity and Scope Levels, and Psychosocial Outcome Severity Guide. Note: if noncompliance with respiratory care provided by nursing services is related to staff competency issues, also consider F725, Section 483.3, 5A3, Nursing Services. Key elements of noncompliance section 483.2, 5I. To cite deficient practice at F695, the surveyor's investigation will generally show that the facility failed to do one or more of the following: provide necessary respiratory care and services, such as oxygen therapy, treatments, mechanical ventilation, tracheostomy care, and slash or suctioning, or provide necessary respiratory care consistent with professional standards of practice, the resident's care plan, goals, and preferences. Deficiency Categorization Section 483.2, 5I. In addition to actual or potential physical harm, always consider whether psychosocial harm has occurred when determining severity level. See Appendix P, Section Roman 4, E, Psychosocial Outcome Severity Guide. Examples of Severity Level 4 noncompliance. Immediate jeopardy to resident health or safety includes, but is not limited to: the facility failed to assure that staff provided appropriate tracheostomy care, including suctioning as ordered by the resident's physician, and based on professional standards of practice, to use the appropriate suctioning technique. During observations, the resident experienced respiratory distress and expressed ongoing anxiety and fear related to difficulty breathing. Staff interviewed was not aware of the physician's orders for tracheal suctioning and were not aware of the techniques to use during the suctioning treatment. Staff stated this was the first time they were scheduled to work in this unit and had no prior experience in providing ventilator or tracheostomy care. This lack of knowledge of how to provide this specialized care, including the technique for suctioning, increases the likelihood for psychosocial harm, respiratory distress, obstruction of airways, and potentially death. The facility failed to provide emergency equipment available for accidental extubation for a resident on mechanical ventilation with a tracheostomy. An extubation creates an emergency situation that requires that an obturator be readily available that can be used by competent staff for reinsertion. Upon interview, staff were not aware of the location of emergency equipment or how to use it in case of accidental extubation. As a result, it is likely any resident who experienced an accidental extubation would suffer serious harm or death. Examples of Severity Level 3 noncompliance. Actual harm that is not immediate jeopardy includes, but is not limited to: the facility failed to provide consistent oxygen therapy for a resident who required oxygen during periods of activity. Over a weekend, a resident's oxygen supply was depleted, and staff failed to order replacement oxygen. As a result, the resident experienced dyspnea when dressing, expressed increasing anxiety due to difficulty in getting his or her breath when ambulating, and refused to go to the dining room for meals or to take a shower due to being short of breath. Facility failed to consistently implement a method for communication that had been established with a resident who was unable to verbally communicate due to being on a mechanical ventilator. The resident had indicated that a clipboard be used for him to write down requests and slash or concerns, but night staff cleaning the room removed it from the resident's bedside and placed it in an area inaccessible by the resident. This had occurred several times, according to the resident who expressed anger to the surveyor when he was interviewed and provided the clipboard. He wrote that staff told him slash her to relax and calm down when he could not access the communication board. The resident wrote that he feels isolated, afraid and upset when he cannot use the preferred communication method. He indicated that he did not feel as if staff could be trusted to meet his concerns and began to cry. Examples of severity level 2 noncompliance. No actual harm with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to. The facility failed to assure that a resident had a portable supply of oxygen to take along when attending activities as ordered by the attending practitioner. The resident stayed in her room on oxygen and missed the activity programs she usually participated in. The resident stated that she was upset to have to miss the programs because staff failed to order her portable supply of oxygen. The facility failed to consistently perform coughing/deep breathing exercises as ordered for a resident. However, no increase or exacerbation of respiratory symptoms as a result of the lack of exercises was identified. Severity level 1. No actual harm with potential for minimal harm. The failures of the facility to provide appropriate care and services to provide respiratory care, including oxygen therapy, respiratory treatments and or mechanical ventilation, and tracheostomy care places a resident at risk for more than minimal harm. Therefore, severity level 1 does not apply for this regulatory requirement. Tag F696. Section 483.2. 5J prostheses. The facility must ensure that a resident who has a prosthesis is provided care and assistance consistent with professional standards of practice, the comprehensive person-centered care plan, the resident's goals and preferences, to wear and be able to use the prosthetic device. Guidance Section 483.2. 5J. The non-availability of program funding does not relieve a facility of its obligation to ensure that its residents receive all needed services listed in Section 1819B4A of the Social Security Act for Medicare and Section 1919B4A of the Act for Medicaid. For services not covered under Medicare or Medicaid, a facility is required to assist the resident in securing any available resources to obtain the needed services. This requirement does not mean that the facility must purchase or provide funding for the prosthetic. Probes Section 483.2. 5J refer to appropriate sections of the RAI/MDS as applicable. For residents selected for review, as appropriate. Is resident able to apply the prosthesis by himself/herself or with some assistance? Are residents wearing their prostheses? Does the prosthesis fit correctly? Is skin/mucous membrane in contact with the prosthesis free of abrasions? Wounds, irritation. Is the prosthesis in good condition and functioning as intended? Is the prosthesis in need of repair? Tag F697. Section 483.2. 5K pain management. The facility must ensure that pain management is provided to residents who require such services, consistent with professional standards of practice, the comprehensive person-centered care plan, and the resident's goals and preferences. Intent Section 483.2. 5K. Based on the comprehensive assessment of a resident, the facility must ensure that residents receive the treatment and care in accordance with professional standards of practice, the comprehensive care plan, and the resident's choices related to pain management. Definitions Section 483.2. 5K. Adjuvant medication describes any medication with a primary indication other than pain management, but with analgesic properties in some painful conditions. Point 2. Adverse consequence is an unpleasant symptom or event that is due to or associated with a medication, such as impairment or decline in a resident's mental or physical condition or functional or psychosocial status. It may include various types of adverse drug reactions and interactions, e.g., medication, medication food, and medication disease. Medication-assisted treatment, MAT, is the use of medications in combination with counseling and behavioral therapies to provide a whole-patient approach to the treatment of substance use disorders. From the Substance Abuse and Mental Health Services Administration, SAMHSA. Opioid use disorder, OUD, is a problematic pattern of opioid use, leading to clinically significant impairment or distress. Additional criteria used to assess and diagnose OUD can be found in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition DSM-5. Note: adverse drug reaction (ADR) is a form of adverse consequences. It may be either a secondary effect of a medication that is usually undesirable and different from the therapeutic effect of the medication, or any response to a medication that is noxious and unintended and occurs in doses for prophylaxis, diagnosis, or treatment. The term side effect is often used interchangeably with ADR. However, side effects are but one of 5 ADR categories, the others being hypersensitivity, idiosyncratic response, toxic reactions, and adverse medication interactions. A side effect is an expected, well-known reaction that occurs with a predictable frequency and may or may not constitute an adverse consequence. Guidance Section 483.2, 5K. Recognition and management of pain. In order to help a resident attain or maintain his or her highest practicable level of well-being, and to prevent or manage pain, the facility, to the extent possible, recognizes when the resident is experiencing pain and identifies circumstances when pain can be anticipated, evaluates the existing pain and the causes, and manages or prevents pain, consistent with the comprehensive assessment and plan of care, current professional standards of practice, and the resident's goals and preferences. Overview of pain recognition and management. Nursing home residents are at high risk for having pain that may affect function, impair mobility, impair mood, or disturb sleep, and diminish quality of life. It is important, therefore, that a resident's reports of pain or nonverbal signs suggesting pain be evaluated. The resident's needs and goals, as well as the etiology, type, and severity of pain, are relevant to developing a plan for pain management. It should be noted that while analgesics can reduce pain and enhance the quality of life, they do not necessarily address the underlying cause of pain. It is important to consider treating the underlying cause, where possible. Strategies for pain management. Strategies for the prevention and management of pain may include, but are not limited to, the following: assessing the potential for pain, recognizing the onset, presence, and duration of pain, and assessing the characteristics of the pain. Addressing/treating the underlying causes of the pain to the extent possible, developing and implementing both non-pharmacological and pharmacological interventions/approaches to pain management, depending on factors such as whether the pain is episodic, continuous, or both. Identifying and using specific strategies for preventing or minimizing different levels or sources of pain or pain-related symptoms based on the resident-specific assessment, preferences and choices, a pertinent clinical rationale, and the resident's goals, and using pain medications judiciously to balance the resident's desired level of pain relief with the avoidance of unacceptable adverse consequences. Monitoring appropriately for effectiveness and or adverse consequences, e.g. constipation, sedation, including defining how and when to monitor the resident's symptoms and degree of pain relief, and modifying the approaches as necessary. Use of opioids for pain management. Prescribing practitioners may find that opioid medications are the most appropriate treatment for acute pain as well as chronic pain in some residents. However, because of increasing opioid addiction, abuse, and overdoses, prescribers should use caution when prescribing opioids and consider using alternative pain management approaches when appropriate. When opioids are used, the lowest possible effective dosage should be prescribed for the shortest amount of time possible after considering all medical needs, and the resident should be monitored for effectiveness and any adverse effects. Long-acting opioids may provide more consistent pain relief with less breakthrough pain. However, if using opioids in residents with dementia, immediate release forms of opioids are generally preferred over long-acting forms to reduce overdose risk, unless clinically indicated. Due to the risk of fatal respiratory depression, combining opioids and benzodiazepines should be avoided unless clinically indicated for an individual resident. Risks related to combining these medications are even greater for adults aged 65 and older and include falls and hip fractures, cognitive impairment/confusion, daytime fatigue, and delirium. If concurrent use of opioids and benzodiazepines is clinically indicated for an individual resident, the resident should be closely monitored for adverse consequences. Medication regimens for residents receiving end-of-life, palliative, or hospice care may include opioids alone or combining opioids and benzodiazepines. Their use must be consistent with accepted standards of practice for this specialty of care. For additional information, refer to Exposure-response association between concurrent opioid and benzodiazepine use and risk of opioid-related overdose in Medicare Part D beneficiaries. https://jamanetwork.com/journals/JAMA-Network-Open/full-article/2,685,628. National Institute on Drug Abuse Benzodiazepines and Opioids. https://www.drugsabuse/drugsabuse/opioids/benzodiazepines/opioids. Geriatric Pain Org, Resources and Tools for Quality Pain Care, https://geriatricpainorg/. The Society for Post-Acute and Long-Term Care Medicine, AMDA Opioid. The Society for Post-Acute and Long-Term Care Medicine, AMDA Opioids in Nursing Homes, https://paltcorg/opioids%20 and %20 nursing %20 homes. Additionally, the Centers for Disease Control and Prevention website has resources specifically related to the use of opioids in treating chronic pain lasting longer than 3 months, or past the time of normal tissue healing available at https://www.cdc.gov/opioids/patients/guideline HTML. These guidelines do not apply to individuals being treated for pain related to active cancer treatment, palliative care, and end-of-life care. Individual states also have initiatives and requirements related to opioid use for acute and chronic pain. When treating pain in a resident with an addiction history or opioid use disorder (OUD), strategies must be used to relieve pain while also considering the OUD or addiction history. These strategies may include continuation of medication-assisted treatment (MAT), if appropriate, non-opioid pain medications, and non-pharmacological approaches. Pain recognition. Because pain can significantly affect a person's well-being, it is important that the facility recognize and address pain promptly. The facility's evaluation of the resident at admission and during ongoing assessments helps identify the resident who is experiencing pain or for whom pain may be anticipated during specific procedures, care, or treatment. In addition, it is important that a resident be monitored for the presence of pain and be evaluated when there is a change in condition and whenever new pain or an exacerbation of pain is suspected. As with many symptoms, pain in a resident with moderate to severe cognitive impairment may be more difficult to recognize and assess. Expressions of pain may be verbal or nonverbal and are subjective. A resident may avoid the use of the term pain. Other words used to report or describe pain may differ by culture, language, and / or region of the country. Examples of descriptions may include heaviness or pressure, stabbing, throbbing, hurting, aching, gnawing, cramping, burning, numbness, tingling, shooting, or radiating, spasms, soreness, tenderness, discomfort, pins and needles, feeling rough, tearing, or ripping. Verbal descriptions of pain can help a practitioner identify the source, nature, and other characteristics of the pain. Nonverbal indicators, which may represent pain, need to be viewed in the entire clinical context, with consideration given to pain as well as other clinically pertinent explanations. Examples of possible indicators of pain include, but are not limited to the following: negative verbalizations and vocalizations, e.g., groaning, crying/whimpering, or screaming. Facial expressions, e.g., grimacing, frowning, fright, or clenching of the jaw, changes in gait, e.g., limping, skin color, vital signs, e.g., increased heart rate. Respirations and slash or blood pressure, perspiration, behavior such as resisting care, distressed pacing, irritability, depressed mood, or decreased participation in usual physical and slash or social activities, loss of function, or inability to perform activities of daily living adults, e.g., rubbing a specific location of the body or guarding a limb or other body parts, difficulty eating or loss of appetite, and difficulty sleeping, insomnia. In addition to the pain item sections of the MDS, many sections such as sleep cycle, change in mood, decline in function, instability of condition, weight loss, and skin conditions can be potential indicators of pain. Any of these findings may indicate the need for additional and more thorough evaluation. Many residents have more than one active medical condition and may experience pain from several different causes simultaneously. Many medical conditions may be painful, such as pressure injuries, diabetes with neuropathic pain, immobility, amputation, post-CVA, venous and arterial ulcers, multiple sclerosis, oral health conditions, and infections. In addition, common procedures, such as moving a resident or performing physical or occupational therapies, or changing a wound dressing, may be painful. Understanding the underlying causes of pain is an important step in determining optimal approaches to prevent, minimize, or manage pain. Observations at rest and during movement, particularly during activities that may increase pain, such as dressing changes, exercises, turning and positioning, bathing, rising from a chair. Walking can help to identify whether the resident is having pain. Observations during eating or during the provision of oral hygiene may also indicate dental, mouth, and slash or facial pain. Recognizing the presence of pain and identifying those situations where pain may be anticipated involves the participation of healthcare professionals and direct care and ancillary staff who have contact with the resident. Information may be obtained by talking with the resident, directly examining the resident, and observing the resident's behavior. Staffing consistency and familiarity with the residents has a significant effect on the staff's ability to identify and differentiate pain-related behavior from other behavior of cognitively impaired residents. Nursing assistants may be the first to notice a resident's symptoms. Therefore, it is important that they are able to recognize a change in the resident and the resident's functioning and to report the changes to a nurse for follow-up. Family members or friends may also recognize and report when the resident experiences pain and may provide information about the resident's pain symptoms, pain history, and previously attempted interventions. Other staff, e.g., dietary, activities, therapy, housekeeping, who have direct contact with the resident may also report changes in resident behavior or resident complaints of pain. Assessment. In addition to the Resident Assessment Instrument (RAI), it is important that the facility identifies how they will consistently assess pain. Some facilities may use assessment tools that are appropriate for use with their resident population. There are many reliable and valid evidence-based practice tools available to facility staff to assist in the assessment of pain. Pain assessment tools that can be used with cognitively intact and impaired residents can be obtained on the Geriatric Pain website at https://geriatricpainorg/clinicians/pain assessment information. An assessment or an evaluation of pain based on professional standards of practice may necessitate gathering the following information as applicable to the resident: history of pain, and its treatment, including non-pharmacological and pharmacological treatment, and whether or not each treatment has been effective. History of addiction, past and / or ongoing and related treatment for OUD. Characteristics of pain such as intensity, pattern, location, frequency, and duration, impact of pain on quality of life, e.g., sleeping, functioning, appetite, and mood. Factors such as activities, care, or treatment that precipitate or exacerbate pain as well as those that reduce or eliminate the pain. Additional symptoms associated with pain, e.g., nausea, anxiety, physical and psychosocial issues, physical examination of the site of the pain, movement or activity that causes the pain, as well as any discussion with resident about any psychological or psychosocial concerns that may be causing or exacerbating the pain. Current medical conditions and medications, including medication-assisted treatment for OUD, and the resident's goals for pain management and his or her satisfaction with the current level of pain control. While it may be difficult to conduct a thorough assessment of all of the above factors in a cognitively impaired or non-responsive resident, the facility staff is responsible for obtaining as much information as possible and evaluating the resident's pain through all available means. Observing the resident during care, activities, and treatments helps not only to detect whether pain is present, but also to potentially identify its location and the limitations it places on the resident. Management of pain. Based on the evaluation, the facility, in collaboration with the attending physician / prescriber, other healthcare professionals, and the resident and / or his or her representative, develops, implements, monitors, and revises as necessary interventions to prevent or manage each individual resident's pain, beginning at admission. These interventions may be integrated into components of the comprehensive care plan, addressing conditions or situations that may be associated with pain, or may be included as a specific pain management need or goal. The interdisciplinary team and the resident and / or representative collaborate to arrive at pertinent, realistic, and measurable goals for treatment, such as reducing pain sufficiently to allow the resident to ambulate comfortably to the dining room for each meal or to participate in 30 minutes of physical therapy. Depending on the situation and the resident's wishes, the target may be to reduce the pain level, but not necessarily to become pain-free. To the extent possible, the interdisciplinary team educates the resident and / or representative about the need to report pain when it occurs and about the various approaches to pain management and the need to monitor the effectiveness of the interventions used. The basis for effective interventions includes several considerations, such as the resident's needs and goals, the source, type, and severity of pain, recognizing that the resident may experience pain from one or more sources either simultaneously or at different times, and awareness of the available treatment options. Often, sequential trials of various treatment options are needed to develop the most effective approach. It is important for pain management approaches to follow pertinent professional standards of practice and to identify who is to be involved in managing the pain and implementing the care or supplying the services, e.g., facility staff, such as RN, LPN, CNA, attending physician or other practitioner, certified hospice, or other contractors such as therapists. Pertinent current professional standards of practice may provide recommended approaches to pain management even when the cause cannot be or has not been determined. Non-pharmacological interventions. Research supports physical activity and exercise as a part of most treatment programs for chronic pain. Activity can be supported by conventional physical therapy and exercise approaches, or by a wide range of movement therapies. Some non-pharmacologic interventions may need to be ordered by the provider, while others can be provided by facility staff during routine care. Examples of non-pharmacological interventions may include, but are not limited to, altering the environment for comfort, such as adjusting room temperature, tightening and smoothing linens, using pressure redistributing mattress and positioning, comfortable seating, and assistive devices. Physical modalities, such as ice packs or cold compresses to reduce swelling and lessen sensation, mid-heat to decrease joint stiffness and increase blood flow to an area, neutral body alignment and repositioning, baths, transcutaneous electrical nerve stimulation TENS, massage, acupuncture/acupressure, chiropractic or rehabilitation therapy. Exercises to address stiffness and prevent contractures, as well as restorative nursing programs to maintain joint mobility, and cognitive/behavioral interventions, e.g., relaxation techniques, reminiscing, diversions, activities, music therapy, offering spiritual support and comfort, as well as teaching the resident coping techniques and education about pain. Pharmacological interventions. The interdisciplinary team nurses, practitioner, pharmacists, etc. is responsible for developing a pain management regimen that is specific to each resident who has pain or who has the potential for pain, such as during a treatment. The regimen considers factors such as the causes, location, and severity of the pain, the potential benefits, risks, and adverse consequences of medications, and the resident's desired level of relief and tolerance for adverse consequences. The resident may accept partial pain relief in order to experience fewer significant adverse consequences, e.g., desire to stay alert instead of experiencing drowsiness/confusion. The interdisciplinary team works with the resident to identify the most effective and acceptable route for the administration of analgesics, such as orally, rectally, topically, by injection, by infusion pump, and / or transdermally. It is important to follow a systematic approach for selecting medications and doses to treat pain. Developing an effective pain management regimen may require repeated attempts to identify the right interventions. General guidelines for choosing appropriate categories of medications in various situations are widely available to the provider, pharmacist, and nurses. Factors influencing the selection and doses of medications include the resident's medical condition, current medication regimen, nature, severity, and cause of the pain, and the course of the illness. Analgesics may help manage pain. However, they often do not address the underlying cause of pain. Examples of different approaches may include, but are not limited to, administering lower doses of medication initially and titrating the dose. Slowly upward, administering medications around the clock rather than on-demand PRN, or combining longer-acting medications with PRN medications for breakthrough pain. Recurrent use of or repeated requests for PRN medications may indicate the need to reevaluate the situation, including the current medication regimen. Some clinical conditions or situations may require using several analgesics and / or adjuvant medications, e.g., antidepressants or anticonvulsants together. Documentation helps to clarify the rationale for a treatment regimen and to acknowledge associated risks. Opioids or other potent analgesics have been used for residents who are actively dying, those with complex pain syndromes, and those with more severe acute or chronic pain that has not responded to non-opioid analgesics or other measures. Opioids should be selected and dosed in accordance with current professional standards of practice and manufacturers' guidelines in order to optimize their effectiveness and minimize their adverse consequences. Adverse consequences may be especially problematic when the resident is receiving other medications with significant effects on the cardiovascular and central nervous systems. Therefore, careful titration of dosages based on monitoring / evaluating the effectiveness of the medication and the occurrence of adverse consequences is necessary. The clinical record should reflect the ongoing communication between the prescriber and the staff is necessary for the optimal and judicious use of pain medications. Other interventions have been used for some residents with more advanced, complex, or poorly controlled pain, such as radiation therapy, neurostimulation, spinal delivery of analgesics, implanted catheters and pump systems, and neurolytic procedures, chemical or surgical, that are administered under the close supervision of expert practitioners. Referrals to pain management clinics and pain management specialists may also be appropriate in these situations. Monitoring, reassessment, and care plan revision. Monitoring the resident over time helps identify the extent to which pain is controlled, relative to the individual's goals and the availability of effective treatment. The ongoing evaluation of the status, presence, increase, or reduction of a resident's pain is vital, including the status of underlying causes, the response to interventions to prevent or manage pain, and the possible presence of adverse consequences of treatment. Adverse consequences related to analgesics can often be anticipated and to some extent prevented or reduced. For example, opioids routinely cause constipation, which may be minimized by an appropriate bowel regimen. Identifying target signs and symptoms, including verbal reports and nonverbal indicators from the resident, and using standardized assessment tools can help the interdisciplinary team evaluate the resident's pain and responses to interventions and determine whether the care plan should be revised. For example, if pain has not been adequately controlled, it may be necessary to reconsider the current approaches and revise or supplement them as indicated, or if pain has resolved or there is no longer an indication or need for pain. Medication. The facility works with the practitioner to discontinue or taper, as needed to prevent withdrawal symptoms, analgesics. Additionally, a facility should evaluate whether there is a time or day pattern to a resident's reports or signs of increased pain to ensure that the problem is not due to drug diversion. The CDC describes a number of side effects which prescription opioids can cause even when given as directed. Some side effects for which residents should be monitored include tolerance, meaning more medication may be needed to achieve the same level of pain relief. Physical dependence, which causes symptoms of withdrawal when opioid medication is stopped, or a dose is held or missed. Increased sensitivity to pain, constipation, nausea, vomiting, and dry mouth, sleepiness, dizziness, and slash or confusion, depression, and itching and sweating. According to the Substance Abuse and Mental Health Administration, SAMHSA, opioid overdose deaths can be prevented by administering naloxone, a medication approved by the Food and Drug Administration to reverse the effects of opioids. The United States Surgeon General has recommended that naloxone be kept on hand where there is a risk for an opioid overdose. Facilities should have a written policy to address opioid overdoses. The SAMHSA website houses a number of resources related to opioid management, including this document intended for prescribers, which addresses appropriate prescribing, monitoring for adverse effects, and treating overdoses. SAMHSA Opioid Overdose Prevention Toolkit. Information for prescribers. https://www.samhsa.gov/resource/eb/opioid overdose prevention toolkit. For concerns related to staff monitoring for adverse effects of opioid use, see F757, unnecessary medications. Key elements of noncompliance. To cite deficient practice at F697, the surveyor's investigation will generally show that the facility failed to do one or more of the following: provide pain management to a resident experiencing pain, or provide pain management that met professional standards of practice, or provide pain management that was in accordance with the resident's comprehensive care plan and the resident's goals for care and preferences. Investigative summary. Use the pain recognition and management critical element C pathway, along with the above interpretive guidelines when determining if the facility provides pain management that meets professional standards of practice, and that is in accordance with the resident's comprehensive care plan, goals for care and preferences. Summary of procedure. Briefly review the most recent comprehensive assessments, comprehensive care plan, and orders to identify whether the facility has assessed and developed an individualized care plan based on professional standards of practice, and provided by qualified, competent staff. During this review, identify the extent to which the facility has implemented interventions in accordance with the resident's needs, goals for care, and professional standards of practice, consistently across all shifts. This information will guide observations and interviews to be made in order to corroborate concerns identified. Note: always observe for visual cues of psychosocial distress and harm. See guidance on severity and scope levels and psychosocial outcome severity guide. Deficiency categorization, an example of severity level 4 noncompliance. Immediate jeopardy to resident health or safety includes, but is not limited to: facility failed to implement an effective pain management regime for a resident who sustained a fracture of the hip and was determined to not be a surgical candidate. Resident stated that pain medication was not effective and she was in continuous pain. She indicated she had notified staff of the pain, but nothing was done. Interview of staff indicated no one had contacted the practitioner to discuss the ineffective pain relief. The staff stated that they were concerned regarding the amount of pain medication the resident was receiving, and that they were concerned that she would become increasingly tolerant and addicted to the medication. They stated they were aware that the resident declined assistance with ADLs due to pain, and felt that the resident was not having the amount of pain that she stated she had. The resident was observed on multiple occasions to holding her hip area, moaning and crying out, sweating, and striking out when staff attempted to move her. An example of severity level 3 noncompliance. Actual harm that is not immediate jeopardy includes, but is not limited to: the facility failed to provide effective pain management to a resident with a diagnosis of bone cancer. Record review revealed the resident only had PRN as needed pain medication every 6 hours. According to the resident, this pain regime was not effective, resulting in excruciating breakthrough pain multiple times each day. The resident said that staff would tell her she had to wait, and often would not get the PRN medicine promptly when it was due. The surveyor observed the resident to be tearful and unable to participate in activities. Examples of severity level 2 noncompliance. No actual harm with potential for more than minimal harm that is not immediate jeopardy includes, but is not limited to: facility failed to provide an effective pain management treatment per the resident's choice and preference. A resident requests a hot shower on the evening shift as an effective intervention for back pain. The staff member assigned to her informed her that she would not be able to be showered until later in the evening. A staff member who understood what the resident was experiencing quickly intervened and gave her a hot shower, relieving her back pain. The facility staff failed to consistently evaluate the effectiveness of regularly scheduled pain medication on a resident. The resident was receiving the pain medication on a routine basis. However, the record did not reflect the resident's response to the administration of the pain medication. In interviews, the resident stated that her pain was being managed for the most part, but that staff did not ask her if she received relief from the medication. She stated that occasionally she would not attend an activity due to discomfort, but this did not routinely occur. When she mentioned it to staff, they would tell her to lie down for a while and would check on her later. However, she stated that they usually did not check her. Staff interviewed stated they didn't have the time to go back, check, and record the resident's response. But if she complained, they would check her and see if she needed anything else. Severity level 1 noncompliance. No actual harm with potential for minimal harm includes the failure of the facility to provide appropriate care and services related to pain management places the resident at risk for more than minimal harm. Therefore, severity 1 does not apply for this regulatory requirement. Tag F698. Section 483.2, 5L dialysis. The facility must ensure that residents who require dialysis receive such services, consistent with professional standards of practice, the comprehensive person-centered care plan, and the resident's goals and preferences. Intent. Section 483.2. 5L. The intent of this requirement is that the facility assures that each resident receives care and services for the provision of hemodialysis and or peritoneal dialysis, consistent with professional standards of practice, including the ongoing assessment of the resident's condition and monitoring for complications before and after dialysis treatments received at a certified dialysis facility. Safe administration of hemodialysis at the bedside and or peritoneal dialysis in the nursing home provided by qualified trained staff caregivers in accordance with state and federal laws and regulations. Ongoing assessment and oversight of the resident before, during, and after dialysis treatments, including monitoring the resident's condition during treatments, monitoring for complications, implementing appropriate interventions, and using appropriate infection control practices, and ongoing communication and collaboration with the dialysis facility regarding dialysis care and services. Definitions. Section 483.2. 5L. End-stage renal disease. ESID, the stage of renal impairment that appears irreversible and permanent, and requires a regular course of dialysis or kidney transplantation to maintain life. 42 CFR, Part Section 405, Section 405.2102. Dialysis, a process by which dissolved substances are removed from a patient's body by diffusion from one fluid compartment to another across a semipermeable membrane. The two types of dialysis that are currently in common use are hemodialysis HD and peritoneal dialysis PD. Section 405.2102. Dialysis facility means an entity that provides outpatient maintenance dialysis services or home dialysis training and support services, or both. Section 494.10. Definitions. Home dialysis. Home dialysis means dialysis performed at home by an ESID patient or caregiver who has completed an appropriate course of training, as described in Section 494.100A of this part. Note, for the purposes of this guidance, the term nursing home refers to a long-term care facility and dialysis facility refers to a Medicare-certified dialysis facility. Home hemodialysis will be referenced as HHD. Interpretive guidance. Section 483.2. 5L. There is no requirement that a nursing home must offer dialysis services. If the nursing home has an arrangement with a dialysis facility for the provision of dialysis services, the nursing home must inform each resident before or at the time of admission, and periodically thereafter during the resident's stay, of dialysis services, if available in the nursing home. Residents of a nursing home may receive dialysis treatments through two main options: Medicare-certified dialysis facility. This may involve either transporting to and from an off-site certified dialysis facility for dialysis treatments, or transporting to a location within or proximate to the nursing home building, which is dedicated for and separately certified as a dialysis facility providing in-center dialysis, and or dialysis in a nursing home. Receive home hemodialysis HHD or peritoneal dialysis PD treatments in the nursing home by trained and qualified staff who have received training and competency from the dialysis facility. If a current resident has been identified as meeting the criteria for HHD/PD by the dialysis facility team and the nephrologist or the physician prescribing dialysis, and chooses to receive either HHD/PD, and the nursing home does not allow for these on-site services, the nursing home must assist the resident with the transfer to a nursing home or in the relocation to a setting, e.g. private home, or residential/assisted living facility of his or her choice that provides HHD/PD services. Note, the Long-Term Care Survey Team does not have the authority under federal nursing home regulations to review the care and services provided directly within a Medicare-certified dialysis facility located either on or off-site. If at any time during the survey, a concern or issue arises regarding the dialysis services provided to a sampled resident by the dialysis facility, the survey team should report this as a complaint to the state agency survey unit responsible for oversight of the Medicare-certified ESID entity. The survey team must identify the specific residentess involved and the concerns identified. Responsibilities for the provision of dialysis care/services. If the nursing home has made the decision to provide dialysis care and services according to the options above, there must be, in accordance with current standards of practice, coordination and collaboration between the nursing home and the dialysis facility to assure that the residents' needs related to dialysis treatments are met. Only trained and qualified staff/caregivers administer the dialysis treatments. The provision of the dialysis treatments and care of the resident meets current standards of practice for the safe administration of the dialysis treatments. Documentation requirements are met to assure that treatments are provided as ordered by the nephrologist, attending practitioner and dialysis team, and there is ongoing communication and collaboration for the development and implementation of the dialysis care plan by nursing home and dialysis staff. The nursing home remains responsible for the overall quality of care the resident receives and must provide the same services to a resident who is receiving dialysis as it furnishes to its residents who are not. This includes the ongoing provision of assessment, care planning, and provision of care. There must be a coordinated plan for dialysis treatments developed with input from both the nursing home and dialysis facility. The resident should not experience any lack of nursing home services or care because of his or her dialysis status. The nursing home staff must be aware and identify changes in residents' behavior, especially for a cognitively impaired resident, that may impact the safe administration of dialysis, including resistance to care and pulling on tubes/access sites, and inform the attending practitioner and dialysis facility of the changes. This requires more frequent and increased observations and monitoring for this resident before, during if dialysis is provided by nursing home staff/caregivers or the resident, and after dialysis treatments. Note, the nursing home may wish to designate a staff person to coordinate activities and communications with each dialysis facility that they have arrangements with to provide dialysis services. The dialysis facility is responsible for the medical management for the end-stage renal disease, including dialysis treatments, performed off-site or on-site. It is the responsibility of the dialysis facility to provide all necessary equipment and supplies for the provision of the dialysis treatments, including maintenance and repair as needed, testing/monitoring water and dialysate quality for the dialysis treatment, and for the training of individuals providing the HHD/PD. Shared communication between the nursing home and the dialysis facility. It is essential that a communication process be established between the nursing home and the dialysis facility to be used 24 hours a day. The care of the resident receiving dialysis services must reflect ongoing communication, coordination, and collaboration between the nursing home and the dialysis staff. The communication process should include how the communication will occur, who is responsible for communicating, and where the communication and responses will be documented in the medical record, including but not limited to timely medication administration initiated, administered, held or discontinued by the nursing home and/or dialysis facility, physician/treatment orders, laboratory values, and vital signs. Advance directives and code status, specific directives about treatment choices, and any changes or need for further discussion with the resident/representative and practitioners. Nutritional/fluid management, including documentation of weights, resident compliance with food/fluid restrictions, or the provision of meals before, during and slash, or after dialysis and monitoring intake and output measurements as ordered. Dialysis treatment provided and residents' response, including declines in functional status, falls, the identification of symptoms such as anxiety, depression, confusion, and slash or behavioral symptoms that interfere with treatments. Dialysis adverse reactions, slash complications, and slash or recommendations for follow-up observations and monitoring, and slash or concerns related to the vascular access site, slash PD catheter. Changes and slash or decline in condition unrelated to dialysis. This would include communication related to care concerns, such as a resident who is at risk for or who has a pressure ulcer, receiving appropriate interventions, and the occurrence or risk of falls, and any concerns related to transportation to and from the dialysis facility. Coordination of physician services between the nursing home and dialysis facility for a resident receiving dialysis. The nursing home staff must immediately contact and communicate with the attending physician/practitioner, resident/resident representative, and designated dialysis staff, i.e., nephrologist. Registered nurse regarding any significant changes in the resident's status related to clinical complications or emergent situations that may impact the dialysis portion of the care plan. Refer to F580, notification of changes in condition. These situations may include, but are not limited to, changes in cognition or sudden unexpected decline in condition, dialysis complications such as bleeding, hypotension, or adverse consequences to a medication or therapy, or other situations. Any changes in the resident's care initiated by the dialysis facility must be communicated to the resident's nursing home, attending physician/practitioner. Hospital transfer. The dialysis facility must ensure access to a hospital for emergency services that has the capacity to provide emergency dialysis care acid conditions for coverage CFC at V770 section 494.180. In order to assure that the dialysis needs of the resident are met in the case of an emergency, the care plan should identify acute care settings that would be able to meet the resident's need for dialysis. In case of the need to transfer to an acute care facility to manage dialysis complications or other care concerns, the nursing home must have ongoing communication with the dialysis facility and have knowledge of the location and how to access the hospital that has the capacity to provide emergency dialysis care, as identified by the dialysis facility. Note: according to the acid regulations at V770 section 494.180, the dialysis facility must have an agreement with a hospital that can provide inpatient care, routine and emergency dialysis and other hospital services, and emergency medical care which is available 24 hours a day, 7 days a week. The agreement must ensure that hospital services are available promptly to the dialysis facility's patients when needed. Roman II include reasonable assurances that patients from the dialysis facility are accepted and treated in emergencies. Resident care policies and staffing specific to dialysis care and services. Some state licensure rules don't allow for the provision of HHD in a nursing home and or a state's Nurse Practice Act or scope of practice may preclude certain health care workers from performing HHD treatments. Some state licensing rules may have specific regulations related to the provision of HHD/PD in a nursing home, such as specifying patient-to-staff ratio requirements. The nursing home must identify who is allowed to provide HHD/PD treatments to a resident, such as a licensed nurse or nurse aide. The dialysis facility is responsible for providing training and assuring the competency of staff or individuals that are allowed to initiate, access, and discontinue dialysis treatments. The nursing home must maintain documentation of completion of training/competency for staff or other individuals providing the dialysis treatments. Note: anecdotally, It has been reported that some nursing homes provide dialysis for multiple residents at a time in a single area/den setting. The facility must assure that compliance is maintained for providing dialysis in a location that promotes dignity, individual privacy during treatments, sufficient staff, access to a call system and hand-washing facilities, availability of emergency equipment and supplies, secured medication storage and preparation area, including a refrigerator as necessary, soiled utility area, disposal of equipment and supplies, and based upon professional standards of practice, the maintenance of effective infection control practices and measures. This includes ensuring that a resident who is hepatitis B+ is not dialyzed in the same location as resident who is not hepatitis B+. Consideration should be given to implementing appropriate infection control practices related to care of a resident who is hepatitis B+, such as using dedicated staff, a dedicated machine, equipment, instruments, and supplies that will not be used by other residents, including a resident who is not hepatitis B+. If PD treatments are provided, the treatments may only be administered by an individual trained by the qualified dialysis trainer from the certified dialysis facility. An LPN/LVN may administer the PD treatment if not in conflict with the state's Nurse Practice Act/scope of practice. A nursing home that provides dialysis treatments, in collaboration with the nursing home medical director and the dialysis facility, must develop dialysis-specific policies/procedures based upon current standards of practice. This includes the care of a resident receiving dialysis services, whether in the facility or at an off-site location. Refer to F841, Responsibilities of Medical Director. At a minimum, these policies must include, but are not limited to the following: the identification of all staff or contracted individuals who are allowed to provide HHD/PD and the training required. An RN, LPN/LVN, a nurse aide or a trained technician can provide dialysis treatments if not in conflict with the state's Nurse Practice Act/scope of practice, and only if the individual has received training from a qualified dialysis trainer from a certified dialysis facility for the individual resident receiving HHD/PD. The documentation of training and competency requirements for individuals providing dialysis treatments. If the facility allows a resident/family member or other individual to provide HHD or PD treatments, documentation that training and competency was provided by the certified dialysis facility. Procedures for the initiation, administration, and discontinuation of HHD/PD treatments. Type of monitoring required before, during, and after the treatments, including documentation requirements. Procedures for methods of communication between the nursing home and the dialysis facility, including how it will occur, with whom, and where the communication and responses will be documented. The development and implementation of a coordinated comprehensive care plan that identifies nursing home and dialysis responsibilities and provides direction for nursing home staff. And the development and implementation of interventions based upon current standards of practice, including, but not limited to, documentation and monitoring of complications, pre- and post-dialysis weights, access sites, nutrition and hydration, lab tests, vital signs including blood pressure and medications. Management of dialysis emergencies, including procedures for medical complications, and for equipment and supplies necessary. The provision of medications on dialysis treatment days, procedures for monitoring and documenting nutrition/hydration needs, including the provision of meals on days that dialysis treatments are provided, assessing, observing, and documenting care of access sites as applicable, such as auscultation/palpation of the AV fistula pulse, bruit and thrill to assure adequate blood flow. Significant changes in the extremity when compared to the opposite extremity edema, pain, redness. Steal syndrome pain, numbness, discoloration, or cold, to touch in the fingers or hand indicating inadequate arterial flow. O. Skin integrity, waxy skin, ulcerations, drainage from incisions. O. Bruising/hematoma. O. Collateral vein distension, veins in access arm close to AV fistula becoming larger. O. Complaints of pain or numbness. Or O. Evidence of infection at the surgical site, such as drainage, redness, tenderness. At incision site, fever. Safe and sanitary care and storage of dialysis equipment and supplies. Responsibility for reporting adverse events, including who to report to. Investigating the event and correcting identified problems. Response and management of technical problems related to HHD and or PD. Treatments such as power outages, or O for PD, how to recognize impaired flow and drainage or failure of the PD. Cycler, O for failure of HHD machines. Clotting of the hemodialysis circuit, dialyzer. Blood leak or line disconnection, and O for HHD/PD. How and when to stop dialysis and or seek help when there are significant issues. Note, the dialysis facility is responsible for the overall provision and maintenance of the dialysis equipment and monitoring source water. The nursing home staff should be aware of any issues with the source water, and the care plan should address these issues. The nursing home trained and qualified staff responsible for providing the dialysis treatment must know how to use the dialysis equipment and identify if there are issues in order to provide safe treatments. Dialysis-specific infection control policies, including but not limited to O. Transmission-based precautions including blood-borne precautions, placement/location cohorting, staff/visitor personal protection equipment PPE requirements, indications for the use of gloves, masks, and hand hygiene. O. Potential health care-associated infections, high including hepatitis B and tuberculosis. O. Restrictions for visitors/roommate, if any, during provision of HHD/PD. O. Handling, using, and disposing of equipment/supplies, medications or other products in accordance with manufacturer's instructions, and in accordance with all applicable federal, state, and local laws and regulations. Note, nursing home staff who have been trained to provide dialysis treatments for a resident must understand how to properly dispose of needles, effluents, disposable items, blood tubing, and dialyzers to minimize risks of infection or injury to self and others, and to prevent environmental contamination, e.g. using impervious puncture-resistant containers for disposal of sharps, placing empty dialysate bags and dialysis tubing, and other contaminated items in specific biohazard container S or bag S before discarding. O. Obtaining and reviewing dialysis facility, monitoring for the dialysis water and dialysate quality, including total chlorine testing, and at least quarterly testing of water and dialysate bacterial and endotoxin as applicable to the HHD equipment in use. O. Types of furnishings allowed such as a recliner used during the dialysis treatment, based on infection control standards, and the cleaning/sanitizing of these furnishings that have the potential to become contaminated with blood/blood products. O. Access to clean sink for hand washing. In addition, disposal needs to be addressed for dialysis byproducts from the dialysis treatment. O. Housekeeping/laundry policies for cleaning/sanitizing the location S where treatments are provided, including linen handling and waste disposal. O. Vascular access or peritoneal catheter care and dressing changes. And O. Cleaning and disinfecting dialysis equipment, including procedures for spills and splashes of blood or effluent on furnishings, equipment, floors, and supplies. Note, for information regarding home dialysis guidance, see ESID CFR section 494.100, V580 Care at Home. This condition also provides information regarding the provision of home dialysis, including water treatment and quality testing, and other requirements of the ANSI/AMI RD 52, 2004. For information related more specifically to water testing and treatment, refer to V253 ANSI/AMI RD52, 2004 requirements as adopted by reference 42 CFR section 494.40 A7.2 microbial monitoring methods. 7.2.1 General, dialysate, monthly dialysate sample/collection/frequency. Culture, dialysate fluid weekly for new systems until a pattern has been established. For established systems, monthly unless a greater frequency is dictated by historical data at a given institution. And V278 in center preconfigured HD. Quarterly cultures/LALs. Moreover, the facility must perform bacteriological and endotoxin testing on a quarterly or more frequent basis, as needed, to ensure that the water and dialysate are within AMI limits. Some portable dialysis machines may have a self-check system, and more stringent requirements may need to be followed as recommended by the manufacturer. Dialysis provided at a Medicare-certified dialysis facility located off-site or on-site. A resident may choose to receive dialysis at a dialysis facility located off-site or in a separately certified dialysis unit located within the facility. The choice of the dialysis provider is made by the resident/resident representative. The nursing home must assist the resident to assure that arrangements are provided for safe transportation to and from the dialysis facility. See F745, Social Services. The nursing home staff must provide immediate monitoring and documentation of the status of the resident's access sites upon return from the dialysis treatment to observe for bleeding or other complications. The nursing home and dialysis facility dietitians should coordinate the nutritional care, including monitoring, documenting, and deciding how and when to address weight changes and nutrition issues. This includes identifying weight fluctuations due to fluid retention between dialysis sessions, possible fluid volume depletion in the immediate post-dialysis period, or associated with anorexia, which may be due to renal failure. Staff must weigh the resident and document the findings based on orders. If weight loss occurs, the facility must notify the attending practitioner and dialysis facility practitioner regarding the management for causes of anorexia and weight loss other than fluid loss that might present. Home hemodialysis provided by nursing home staff. The nursing home must continue to meet the nursing home requirements found throughout 42 CFR Part Section 483 to assure the resident's health, safety, and well-being. The facility must be able to demonstrate in collaboration with the dialysis facility the arrangements in place in order to provide safe HHD/HPD through qualified trained staff/caregivers and assure that the resident receives the dialysis treatments as ordered. The nursing home is responsible for the ongoing coordination of dialysis care in collaboration with the Medicare-certified ESID entity. The nursing home resident who receives dialysis is entitled to the same rights, services, and efforts to achieve expected outcomes as a person receiving dialysis at a dialysis facility. Note: according to 42 CFR Section 494.100V 581, a dialysis facility that is certified to provide services to home patients must ensure through its interdisciplinary team that home dialysis services are at least equivalent to those provided to in-facility patients and meet all applicable conditions, Part 494. This does not imply that the nursing home surveyor surveys to or applies ESID regulations. Provision of HHD treatments. The nursing home and the dialysis facility must have ongoing communication to coordinate the care and manage any changes/issues that arise. The nursing home staff must use appropriate infection precautions, including blood-borne precautions, for all aspects of dialysis care. In addition, if the HHD is provided in a semi-private resident room, adherence to the right of privacy during treatment is required. The nursing home staff must have specific written guidance for identifying and handling complications and emergencies before, during, and after the provision of HHD. The nursing home must have a system in place for staff to contact the dialysis facility immediately with any concerns/issues regarding dialysis. This includes who to communicate with, such as the dialysis staff, attending practitioner, or nephrologist regarding HHD. The nursing home must have dialysis facility contact, numbers readily accessible to licensed nursing home staff, that assures the on-call dialysis qualified licensed professional staff is available by phone 24 hours a day, 7 days a week. HHD may be performed by either the resident, if physically and cognitively capable, or an individual, such as a family member if allowed by the nursing home staff, or a contracted individual, such as a licensed nurse or dialysis technician, who has completed training/competency by a qualified trainer from a Medicare-certified dialysis facility in accordance with state licensure, scope of practice for nursing. The required training for staff providing HHD and PD treatments in nursing homes must be individualized and resident-specific, and provided directly by the Medicare-certified dialysis facility that is responsible for the provision of the resident's overall dialysis care. This training cannot be provided by nursing home staff, even if they have previously received the training for dialysis by this or another dialysis facility for another resident. The nursing home must have documentation of the completion of resident-specific dialysis training by the dialysis facility for each nursing home staff member providing dialysis treatments for the resident. While a nursing home may allow a resident or a dialysis-trained caregiver to provide the dialysis treatment, the nursing home nonetheless remains responsible for the resident's care and services. The facility must maintain documentation of the required ongoing dialysis training in order to assure qualified staff/caregivers are capable of providing the HHD treatments. Refer to F658 training based upon current standards of practice must include, but not be limited to, the following: specific step-by-step instructions on how to use the resident's prescribed dialysis equipment, e.g. hemodialysis machine, and water treatment components. Specific step-by-step instructions in home dialysis procedures to facilitate adequate dialysis as prescribed by the physician. Training in proper storage and administration of erythropoiesis-stimulating agents (ESA), if applicable, and in accordance with state laws and state scope of practice. ESAs are medications that may be used to treat anemia in a resident with a diagnosis of ESID. How to identify/recognize medical emergencies, implement immediate responses/actions and methods for contacting emergency medical systems. Medical emergencies may include, but are not limited to, cardiac arrest, air embolism, drug reactions, suspected pyrogen reactions, profound hypotension or hypertension, and significant blood loss. How to recognize, manage, and report such potential complications as vascular access problems such as difficulty with cannulation, a change in bruit or thrill or bleeding, and infections, hypertension or hypotension, hyperkalemia, etc. Infection control practices, including indications for the use of gloves, masks, and other personal protective equipment, methods for hand hygiene, vascular access and dressing changes, cleaning and disinfecting dialysis equipment, cleaning and disinfection procedures for spills and splashes of blood or effluent. Identifying symptoms associated with water and dialysate contamination that cannot be readily attributed to other causes. Clinical symptoms may include, but are not limited to, chills, shaking, fever, vomiting, headache, dizziness, muscle weakness, skin flushing, itching, diarrhea, hyper/hypotension, hemolysis, and anemia. If such symptoms are present, the facility must notify the attending practitioner and dialysis team to determine appropriate action. And recognizing, managing, and reporting power outages, failure of the HD machine, failure of water treatment components, e.g. chlorine/chloramine breakthrough, clotting of the hemodialysis circuit, dialyzer blood leaks, line disconnection, water supply problems or leaks, and problems with supply delivery. The nursing home must have orders for the provision of the dialysis treatments, including individualized dialysis prescriptions such as, at a minimum, the number of treatments per week, length of treatment time, the type of dialyzer, and specific parameters of the dialysis delivery system, e.g. electrolyte composition of the dialysate, blood flow rate, and dialysate flow rate, anticoagulation, and the resident's target weight. The resident's care plan must, based on standards of practice, identify the resident-specific parameters for blood pressure, weights, and other vital signs. The resident's blood pressures must be monitored pre, during, and post-treatment, and abnormal values must be addressed. Excessively high or low blood pressure measurements during treatment without evidence of assessment and action to address those values would indicate the care plan for this parameter was either not developed or not implemented. The nursing home staff must provide ongoing assessment of the resident during dialysis, including vital signs, level of consciousness, muscle cramping, itching and comfort or distress, and must report identified or suspected complications to the attending practitioner and identified dialysis staff to enable timely interventions. In addition, staff must ensure that a resident who is hepatitis B+ is not dialyzed in the same location as resident who is not hepatitis B+. Consideration should be given to implementing appropriate infection control practices related to care of a resident who is hepatitis B+, such as using dedicated staff, a dedicated machine, equipment, instruments, and supplies that will not be used by other residents, including a resident who is not hepatitis B+. Note, according to the interpretive guidelines at ESID Regulation V581, CFR Section 494.100 condition. Care at home. Home dialysis patients are considered part of the census of the ESID facility and are entitled to the same rights, services, and efforts to achieve expected patient outcomes as the in-center dialysis patients of the facility. After receiving dialysis, staff must obtain vital signs, assess the resident's stability and monitor for post-dialysis complications and symptoms such as but not limited to dizziness, nausea, vomiting, fatigue, or hypotension. The resident receiving HHD must be under direct observation of the trained caregiver, who must be physically present in the room with the resident throughout the entire HHD treatment in the immediate location where the HHD is being provided. Note, nursing home staff assigned to provide an HHD treatment must not have assignments for additional residents throughout the duration of the HHD treatment and after completed until the resident is determined stable according to accepted standards of practice. The resident's vascular access site and bloodline connections must be able to be seen by the trained caregiver throughout the dialysis treatment. Allowing a resident to cover access sites and line connections provides an opportunity for accidental needle dislodgement or a line disconnection to go undetected. This dislodgement or disconnection could result in exsanguination and death in minutes. The medical record should reflect the care and monitoring of the access site, including but not limited to examining the arteriovenous fistula, AV fistula, and slash or surgical incisions to detect problems that require immediate notification of the attending practitioner. Peritoneal dialysis PD provided by nursing home staff. If the nursing home provides PD on site, it is responsible for the ongoing coordination of dialysis care in collaboration with the Medicare-certified dialysis facility. The nursing home staff must have specific written guidance for the provision of treatments and handling complications and emergencies during the provision of PD. The nursing home must have contact information available for staff to assure that dialysis qualified licensed professional staff is available by phone 24 hours a day, 7 days a week, including who to communicate with regarding PD-related issues. PD may be performed by either the resident if physically and cognitively capable, or an individual, such as a family member if allowed by the nursing home staff, or a contracted caregiver who has completed training/competency by a qualified trainer from a Medicare-certified dialysis facility. While a nursing home may allow a resident or a dialysis-trained caregiver to provide the dialysis treatment, the nursing home nonetheless remains responsible for the resident's care and services. The facility must maintain documentation of the required ongoing dialysis training in order to assure qualified staff/caregivers are capable of providing the PD treatments. Refer to F658. Meeting professional standards training based upon current standards of practice must include, but not be limited to, the following: specific step-by-step instructions on how to use the resident's prescribed dialysis equipment, e.g. peritoneal dialysis cycler, and instructions in home dialysis procedures for PD to facilitate adequate dialysis as prescribed by the practitioner. Training in proper storage and administration of erythropoiesis-stimulating agents ESA, if applicable. How to identify/recognize medical emergencies, implement immediate responses/actions, and methods for contacting emergency medical systems. Medical emergencies may include, but are not limited to, cardiac arrest, drug reactions, suspected pyrogen reactions, profound hypotension or hypertension, and significant blood loss. How to recognize, manage, and report dialysis complications, including catheter, tunnel, or exit site infection, peritonitis, catheter dislodgement, hypotension, hypokalemia, failure of sufficient dialysate to drain from the peritoneal space, protein malnutrition. Indications for the use of gloves, masks, and other personal protective equipment, methods for hand hygiene, peritoneal catheter care and dressing changes, cleaning and disinfecting dialysis equipment, cleaning and disinfection procedures for spills and splashes of effluent. How to properly dispose of needles, effluents, disposable items, and tubing, and to minimize risks of infection or injury to self and others, and to prevent environmental contamination, e.g. using impervious puncture-resistant containers for disposal of sharps, placing empty dialysate bags and tubing in intact plastic bags before discarding, and recognizing, managing, and reporting power outages, failure of the PD cycler. Provision of PD treatment. PD may be provided via the following modalities. Continuous ambulatory peritoneal dialysis, CAPT, is a treatment in which dialysis solution is introduced through a catheter into the abdomen via gravity, and the bag is disconnected. After a specified period of time, the catheter is reconnected and drains the solution containing wastes back into the bag. CAPT does not require a machine. The process uses gravity to fill and empty the abdomen. CAPT may be provided during 3 or 4 exchanges during the day and 1 overnight. A minicycler machine may be used to exchange the dialysis solution overnight as the resident sleeps, or continuous cycler-assisted peritoneal dialysis (CCPD) uses a machine to fill and empty the abdomen 3 to 5 times during the night. In the morning, the last fill remains in the abdomen with a dwell time that is individualized according to the resident's needs. In some cases, an additional exchange is done in the mid-afternoon to increase the amount of waste removed and to prevent excess fluid absorption. For a resident receiving PD, the practitioner orders for the individualized prescription must include at least the number of exchanges or cycles to be done during each dialysis session, the volume of fluid with each exchange, duration of fluid in the peritoneal cavity, the concentration of glucose or other osmotic agent to be used for fluid removal, and the use of an automated, manual, or combined techniques. Before, during, and after receiving the PD, nursing home staff must, based on practitioners' orders and professional standards of practice, obtain vital signs, weights, assess the resident's stability level of consciousness, and comfort or distress. and monitor for post-dialysis complications and symptoms such as but not limited to dizziness, nausea, fatigue, or hypotension. The staff must report identified or suspected complications immediately to the attending practitioner and dialysis staff to enable timely interventions. The resident's record must include documentation of ongoing evaluation of the peritoneal catheter, including assessment of catheter-related infections, for example, exit site acute and chronic infections, and tunnel for condition, monitoring for patency, leaks, infection, and bleeding at the site. In addition, staff should be monitoring for complications such as peritonitis, for example, abdominal pain/tenderness/distension, cloudy PD fluid, fever, nausea, and vomiting. Note: for more information related to PD-related infections, refer to https://www.cdc.gov/disasters/F684 Interim and emergency medications for residents receiving dialysis nursing homes must have access to medications and treatments, such as antibiotics and intravenous fluids, to treat common complications of dialysis. The nursing home staff must collaborate with the medical director, consultant pharmacist, and dialysis facility to develop policies and procedures to address common complications and to ensure access to needed medications. The attending practitioner and dialysis team may have prescribed erythropoiesis-stimulating agents (ESA), which are medications that may be used to treat anemia in a resident with a diagnosis of ESID. These medications act similarly to erythropoietin to stimulate the production of red blood cells and are administered either intravenously or subcutaneously. Commonly used ESAs include epigen-epoetin alpha 2 and Aranesp darbepoetin alpha. Other causes of anemia unrelated to kidney disease, e.g., hemolytic anemia and blood loss anemia, may also occur in individuals with ESID. Additionally, many anemic individuals with ESID are also treated with iron supplements because iron is necessary for the production of red blood cells. These include iron supplements such as Venofer iron sucrose and Ferrocit sodium ferric gluconate complex to treat iron deficiency anemia. Note: ESAs were approved by the FDA starting with Epigen for the treatment of anemia in 1989 and Aranesp in 2001. Since the approval, the product labeling for this class of medications has been updated several times to incorporate new safety information. The FDA approved new labeling for both drugs in March 2007 that included a warning that ESAs can increase the risk for death and serious cardiovascular events, including myocardial infarction, stroke, heart failure, when they are dosed to achieve a target hemoglobin of greater than 12 g/dl. For individuals with chronic kidney disease on dialysis, FDA-approved labels for ESAs now recommend that healthcare professionals initiate ESA treatment when the hemoglobin level is less than 10 g/dl, and that the dose be reduced or interrupted if the hemoglobin approaches or exceeds 11 g/dl. Ongoing monitoring is mandated to ensure efficacy as well as safety and reimbursement of the medication S. http://www.fda.gov/drugs/drugsafety/postmarket drugsafety information for patients and providers/UCM 109,375 HTM. Depending on the dialysis method and the resident's comorbidities, medication administration may need to be modified. The attending practitioner and nephrologist determine which medications are to be administered during dialysis, which are to be held prior to dialysis, e.g., because of excessive hypotension during dialysis. Whether any specific medications are to be given prior to dialysis, and any medications such as antibiotics or ESAs that are to be given by dialysis staff. All such medication administration must be coordinated, communicated, and documented between dialysis staff, nursing home staff, and practitioners. For issues related to medications and/or pharmacy review, Refer to F757 unnecessary medications, and or F755 pharmacy services, and or F756 pharmacy review. Canceling or postponing dialysis, either HD, HHD, and or PD, the nephrologist/dialysis team. The resident's attending practitioner must be notified of the canceled or postponed dialysis treatment, and responses to the change in treatment must be documented in the resident's medical record. If dialysis is canceled or postponed, the nursing home and dialysis staff should provide or obtain ongoing monitoring and medical management for changes such as fluid gain, respiratory issues, review of relevant lab results, and any other complications that occur until dialysis can be rescheduled based on resident assessment, stability, and need. Lack of sufficient trained and qualified staff to provide treatments in the event circumstance do not allow dialysis to be provided by the designated trained and qualified individual. The nursing home must immediately notify the dialysis facility in order to make arrangements to assure that no dialysis treatments are missed. Equipment failure for HHD/PD dialysis may be stopped, postponed, or delayed due to dialysis equipment failure. If this happens during dialysis, the staff and practitioner must assess the resident immediately to assure that urgent medical needs are met, identify and manage any consequences. Contact the dialysis facility and reschedule the dialysis as appropriate and or transport the resident to the off-site certified dialysis facility to receive the required dialysis treatments. The staff must check the equipment and supplies to identify what happened and why, and arrange with the dialysis facility for the repair/replace the equipment and supplies as necessary. Resident declines or acute illness, or resident complications, dialysis may be stopped, postponed, or delayed due to a resident's declines of the dialysis treatment or the presence of acute illness or complications to the resident before, during, after, and in between dialysis sessions. As part of care coordination between the nursing home and the dialysis facility, there must be a systematic approach to handling situations where the resident has a condition change and or becomes ill or unstable during dialysis. This approach includes knowing who is to be contacted, who decides whether to stop dialysis, who documents the situation, under what circumstances dialysis may be terminated, and when the dialysis treatment may be restarted or the next treatment scheduled. The record must reflect how the missed treatments will be addressed in order to prevent an avoidable decline and or potential complications. If a resident wants to decline the dialysis treatment test, the nursing home and dialysis facility social workers should coordinate services to assess psychosocial concerns related to the resident's desire to discontinue dialysis treatments. The nursing home and dialysis staff must coordinate their approaches in order to provide immediate care for possible emergencies and complications, such as cardiac arrest during dialysis. Any orders related to cardiopulmonary resuscitation (CPR) and any documents that might be needed, e.g., practitioner orders for life-sustaining treatment, advance directives including code status, must be available for both the nursing home and the dialysis staff. Knowledge of existing advance directives, including specific directives about treatment choices and code status, must be communicated between dialysis and nursing home staff to ensure that there is a uniform approach, consistent with state laws and regulations. Refer to F678, Advance Directives. Administrative review of nursing home practices as appropriate. The administrator, nursing director, medical director, and pharmacist, and the QAA committee should review the nursing home's dialysis care and services on an ongoing basis, including the communication, training, supervision, and care coordination between the nursing home and the participating dialysis facility. Whether policies and procedures for the types of dialysis that are provided in the nursing home are consistent with current standards of practice and are being followed consistently. any complications associated with dialysis provision, such as those associated with potential breaches in infection control, those resulting in hospitalization, and those due to equipment, technique, process failures, or supplies. Provision of ongoing staff training, which is individualized to meet the needs of each HHD/PD resident. Staff training must be provided by qualified dialysis facility instructors and include how to address emergencies, and communication and coordination between the nursing home and the dialysis facility in sharing data about outcomes and processes and reviewing quality indicators and care issues. Investigative summary for dialysis care and services use the dialysis critical element C pathway, along with the interpretive guidelines when determining if the facility meets the requirements for providing care and services for a resident receiving dialysis services, in accordance with professional standards of practice. And the comprehensive, person-centered care plan. Summary of investigative procedure. Briefly review the most recent comprehensive assessments, comprehensive care plan, and orders to identify whether the facility has recognized, assessed, provided interventions, and implemented care and services according to professional standards of practice in order to meet the residents' dialysis care needs under investigation. This information will guide observations and interviews to be made in order to corroborate concerns identified. In addition, investigate to assure that there are sufficient numbers of trained, qualified, and competent staff to provide the interventions identified for a resident receiving dialysis care and services. If the resident has been in the facility for less than 14 days before completion of all the resident assessment instrument RI is required, review the baseline care plan, which must be completed within 48 hours to determine if the facility is providing appropriate care and services based on information available at the time of admission. In addition, review to determine whether the comprehensive care plan is evaluated and revised based on the resident's response to interventions. Note, always observe for visual cues of psychosocial distress and harm. See Appendix P, Guidance on Severity and Scope Levels, and Psychosocial Outcome Severity Guide. In addition, if noncompliance at this tag demonstrates a pervasive disregard for the resident's quality of life, consider investigating concerns at F675, Quality of Life. Other tags, care areas, CA, and tasks to consider. Dignity CA F550, Right to be informed and make treatment decisions F552, Right to refuse F578, Advanced Directives CA F561, Notification of Change F580, Accommodation of Needs, Call System Environment Task, and F558, be provided by qualified persons F650. Nutrition CAF 692, Hydration CAF 692, Sufficient and Competent Staffing Task, and F725, Unnecessary Medications CAF 757, Infection Control Task, and F880, Medical Director F841, Resident Records F842, and CA and ACAPI Task F868. Deficiency Categorization Part Roman 4, Appendix P. Note: the death or transfer of a resident who is harmed as a result of nursing home practices does not remove a finding of immediate jeopardy. The nursing home is required to implement specific actions to correct the deficient practices which allowed or caused the immediate jeopardy. Examples that demonstrate severity at level 4 include, but are not limited to, the nursing home failed to ensure that the nursing home staff provided adequate monitoring for a resident after returning from receiving an off-site HHD treatment at an IRST unit. The resident was found to have pulled out the hemodialysis catheter and was found by staff over an hour later to be profusely bleeding, which led to death. The nursing home failed to ensure that nursing home staff providing the HHD monitored and identified complications during a dialysis treatment. The resident's vital signs were not monitored during the dialysis treatment, and as a result, the resident experienced serious hypotensive complications resulting in an emergency transfer and admission to the hospital. The nursing home failed to ensure that the nursing home staff monitored the PD catheter site for complications. The nursing home staff providing the PD treatments failed to monitor the condition of the PD catheter site and identify signs of infection. As a result of the infection at the catheter site, the resident required medical intervention for removal of the catheter and initiation of hemodialysis. Examples that demonstrate severity at level 3 may include, but are not limited to, the nursing home failed to notify the attending practitioner and dialysis team of changes in a resident's behavior and failed to assure the treatments were provided according to the orders. A cognitively impaired resident was observed during a HHD treatment to exhibit combative and resistive behaviors, such as pulling at the tubing and access site. The resident had a history of previously dislodging the catheter, causing bleeding. The resident was observed trying to remove his or her shoes and trying to stand up from the dialysis chair and requires constant supervision during the treatment. The staff attributed the behavioral symptoms to dementia and administered a benzodiazepine to try to sedate the resident. Due to the behavioral symptoms, the HHD treatment had to be discontinued, but the practitioner wasn't contacted regarding discontinuing the treatment. This had occurred several times. However, the nursing home staff failed to contact the practitioner, identify underlying causes, such as delirium or medication side effects, and did not attempt to consider environmental or other non-pharmacological measures to try to reduce the restlessness during dialysis. As a result of the treatments being discontinued early, the resident had electrolyte imbalance and fluid retention. Examples that demonstrate severity level 2 include, but are not limited to, the nursing home failed to ensure that the nursing home staff provided PD treatments as ordered. The nursing home staff providing the PD failed to follow the orders for the duration of fluid in the peritoneal cavity, however, the resident's status was stable. The nursing home failed to ensure that the nursing home staff provided PD treatments as ordered. The nursing home staff failed to identify a recent change in a resident's dialysis order for an increase in the number of daily PD treatments. However, the resident's status was stable. Severity level 1. No actual harm with potential for minimal harm. The failure of the nursing home to provide appropriate care and services to a resident who is receiving dialysis care and services is more than minimal harm. Therefore, severity level 1 does not apply for this regulatory requirement. Tag F699. Section 483.2. 5M. Trauma-informed care. The facility must ensure that residents who are trauma survivors receive culturally competent, trauma-informed care in accordance with professional standards of practice and accounting for residents' experiences and preferences, in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. The intent of this requirement is to ensure that facilities deliver care and services which, in addition to meeting professional standards, are delivered using approaches which are culturally competent and account for experiences and preferences, and address the needs of trauma survivors by minimizing triggers and or re-traumatization. Definitions. Culture is the conceptual system that structures the way people view the world. It is the particular set of beliefs, norms, and values that influence ideas about the nature of relationships, the way people live their lives, and the way people organize their world. Adopted from Substance Abuse and Mental Health Services Administration. Improving cultural competence. Treatment Improvement Protocol Tip Series No. 59. HHS Publication No. SMA 144849. https://storsamsagov/systems/files/SMA 14 to 4849. PDF. Cultural competency is a developmental process in which individuals or institutions achieve increasing levels of awareness, knowledge, and skills along a cultural competence continuum. Cultural competence involves valuing diversity, conducting self-assessments, avoiding stereotypes, managing the dynamics of difference, acquiring and institutionalizing cultural knowledge, and adapting to diversity and cultural contexts in communities. U.S. Department of Health and Human Services publication. A blueprint for advancing and sustaining clause policy and practice at https://thinkculturalhealthhhs.gov/clause/blueprint #text equals a %20 blueprint %20 for %20 adv. Ansing %20 and %20 sustaining %20 clause %20 policy, culturally %20 and %20, linguistically %20, appropriate %20 services %20 within %20, your %20 organization. Trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being, trauma. SAMHSA HRSA Center for Integrated Health Solutions, Substance Abuse and Mental Health Services Administration, 30 Nov 2016, accessed at https://www.samhsagov/resource/dbis/samhsas concept trauma guidance trauma-informed approach. Trauma-informed care is an approach to delivering care that involves understanding, recognizing, and responding to the effects of all types of trauma. A trauma-informed approach to care delivery recognizes the widespread impact and signs and symptoms of trauma in residents, and incorporates knowledge about trauma into care plans, policies, procedures, and practices to avoid re-traumatization. Referred to variably as trauma-informed care or trauma-informed approach. Adapted from concept of trauma and guidance for a trauma-informed approach. https://storesamhsagov/systems/files/SMA14 to 4884, PDF. Guidance, Section 483.2, 5M Background. Increasingly diverse demographics among nursing home residents require nursing homes to provide culturally competent care. Cultural competency, which includes language and cultural preferences, and other cultural aspects such as thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups, is an important aspect of person-centered care. These elements influence the beliefs surrounding health, healing, wellness, and the delivery of health services, and are critical to reducing health disparities. Cultural competence has emerged as an important issue for three practical reasons. First, as the United States becomes more diverse, practitioners will increasingly see people with a broad range of perspectives on health, often influenced by their social or cultural backgrounds. Second, research has shown that provider-patient communication is linked to health outcomes. And third, two landmark Institute of Medicine IAM reports, Crossing the Quality Chasm and Unequal Treatment, highlight the importance of patient-centered care and cultural competence in improving quality and eliminating health disparities. Point 2. According to the Substance Abuse and Mental Health Services Administration SAMHSA, 70% of adults in the United States have experienced some type of traumatic event, at least once in their lives. There is a direct correlation between trauma and physical health conditions such as diabetes, chronic obstructive pulmonary disease (COPD), heart disease, cancer, and high blood pressure. While care and services must always be person-centered and honor residents' choice and preferences, what is different about providing care and services to a trauma survivor is that these residents may have lost the ability to trust caregivers and to feel safe in their environment. As a result, the principles of trauma-informed care must be addressed and applied purposefully. The following principles pertaining to trauma-informed care have been adapted from SAMHSA concept of trauma and guidance for a trauma-informed approach, located at https://storesamhsagov/systems/files/SMA14 to 4884, PDF. Safety, ensuring residents have a sense of emotional and physical safety. Trustworthiness and transparency, efforts to establish a relationship based on trust and clear and open communication between the staff and the resident. Peer support and mutual self-help. If practicable, it may be appropriate to assist the resident in locating and arranging to attend support groups which are organized by qualified professionals. It may be possible for the group to meet in the facility. Collaboration. There is an emphasis on partnering between a resident and or his or her representative, and all staff and disciplines involved in the resident's care in developing the plan of care. There is recognition that healing happens in relationships and in the meaningful sharing of power and decision-making. Empowerment, voice, and choice, ensuring that residents' choice and preferences are honored, and that residents are empowered to be active participants in their care and decision-making, including recognition of and building on resident strengths. Assessment. Facilities should use a multi-pronged approach to identifying a resident's history of trauma as well as his or her cultural preferences. This would include asking the resident about triggers that may be stressors or may prompt recall of a previous traumatic event, as well as screening and assessment tools such as the Resident Assessment Instrument RI, Admission Assessment, the History and Physical, the Social History/Assessment, and others. There are many psychosocial screening and assessment tools available, including assessment tools from the United States Department of Veterans Affairs site, PTSD. National Center for PTSD, https://www.ptsdvagov/professional/indexasp. Trauma. Residents of long-term care facilities may include, but are not limited to, trauma survivors such as military veterans, survivors of large-scale natural and human-caused disasters, Holocaust survivors, survivors of physical, sexual and/or mental abuse past or current, or other violent crime, as well as residents with a history of imprisonment, homelessness, or who have suffered the traumatic loss of a loved one. The history and physical assessment done by the attending physician can reveal many clues to a resident's history of trauma. Scars and other signs of physical trauma should be explored to determine the cause if the resident is comfortable/agreeable with discussing them. Numerical tattoos may be an indicator of World War II Holocaust survivors. Residents with a history of trauma may have diagnoses such as anxiety, depression, or may have substance abuse issues such as alcoholism, and or may abuse prescription medications or street drugs. Evidence of physical and or psychological trauma can be revealed during a comprehensive social history or assessment by the social worker. Triggers. Facilities must identify triggers which may re-traumatize residents with a history of trauma. A trigger is a psychological stimulus that prompts recall of a previous traumatic event, even if the stimulus itself is not traumatic or frightening. For many trauma survivors, the transition to living in an institutional setting and the associated loss of independence can trigger profound re-traumatization. While most triggers are highly individualized, some common triggers may include experiencing a lack of privacy or confinement in a crowded or small space, exposure to loud noises or bright/flashing lights, certain sights, such as objects that are associated with those that use to abuse, and or sounds, smells, and even physical touch. Culture. As mentioned in the background section above, the increasingly changing demographics of nursing homes has led to the need to provide culturally competent care. In addition to racial and ethnic diversity, this also includes religious preference, sexual orientation, and gender identity. There are several tools that facilities may use in addition to the Resident Assessment Instrument, RI, to assist them in identifying a resident's cultural preferences. Chapter 3 of the RAI gives guidance on completing minimum data set MDS items in section that addresses race, ethnicity, and language with which the resident most closely identifies. These MDS items may be indicators of a resident's culture and may indicate further assessment is necessary to determine if there are any cultural preferences which should be honored while the resident is in the facility. The categories in this classification are sociopolitical constructs and should not be interpreted as being scientific or anthropological in nature. They provide demographic race/ethnicity-specific health trend information. These categories are not used to determine eligibility for participation in any federal program. MDS section identifies whether the resident wants or needs an interpreter and the resident's preferred language. Inability to make needs known and to engage in social interaction because of a language barrier can result in isolation, depression, and unmet needs. Language barriers can interfere with accurate assessment. Facilities must use their facility assessment, F684, for additional guidance related to facility assessment to identify resident populations having unique cultural characteristics, such as language including American Sign Language, religious or cultural practices, values, and preferences. This facilitates a facility-wide and department-wide understanding of cultural differences and how to approach the provision of care and services with dignity and respect for the individual. Also see F675, Quality of Life, for further discussion of the impact of cultural differences on residents and staff. Note, facilities are required to communicate effectively, both verbally and in writing, with residents in a language and manner they can understand. For additional information, see F552, Right to be informed/make treatment decisions, F572, Notice of Rights and Rules, and F573, Right to access/purchase copies of records. Cultural competencies. Cultural competencies help staff communicate effectively with residents and their families and help provide care that is appropriate to the culture and the individual. Cultural competence, also known as cultural responsiveness, cultural awareness, and cultural sensitivity, refers to a person's ability to interact effectively with persons of cultures different from his or her own. With regard to healthcare, cultural competence is a set of behaviors and attitudes held by clinicians that allows them to communicate effectively with individuals of various cultural backgrounds, and to plan for and provide care that is appropriate to the culture and to the individual. The following resources are intended for informational purposes only. The National Center for Cultural Competence, https://NCCC Georgetown Edu, the National Standards for Culturally and Linguistically Appropriate Services in Health and Healthcare, developed by the Office of Minority Health in HHS, https://www.thinkculturalhealthhs.gov/clause/blueprint, Office of Minority Health, Think Cultural Health website, https://www.thinkculturalhealthhs.gov. Georgetown University publication, Cultural Competence in Healthcare. Is it important for people with chronic conditions? https://HBI Georgetown Edu/Adjing Society/PubItml/cultural/cultural HTML. Care planning to address past trauma. The facility should collaborate with resident trauma survivors, and as appropriate, the resident's family, friends, and any other health care professionals such as psychologists, mental health professionals to develop and implement individualized interventions. In some cases, if a facility has more than one trauma survivor, social services might consider establishing a support group that is run by a qualified professional, or allowing a support group to meet in the facility. In situations where a trauma survivor is reluctant to share his or her history, facilities are still responsible to try to identify triggers which may re-traumatize the resident and develop care plan interventions which minimize or eliminate the effect of the trigger on the resident. Trigger-specific interventions should identify ways to decrease the resident's exposure to triggers which re-traumatize the resident, as well as identify ways to mitigate or decrease the effect of the trigger on the resident. Examples of trigger-specific interventions include, but are not limited to the following: trigger showers/shower fixtures, confinement in small/crowded spaces, loud noises, removal of clothing, exposure to smoke or fire. Intervention provide alternative methods for bathing such as tubs, sponge bath. Offer individual or small group activities. Decrease/eliminate exposure to loud noises during holiday celebrations, July 4th, New Year's Eve, and slash or decrease volume of, or eliminate overhead paging systems. Consideration should be given to methods of assistance given to residents such as consistent staffing/same-sex caregiver, removing clothing slowly, explanation of what is happening, remove from areas where smoking is permitted or cookouts occur, provide alternative meals inside facility. Additionally, trauma-specific interventions should recognize the interrelation between trauma and symptoms of trauma such as substance abuse, eating disorders, depression, and anxiety. Trauma-specific interventions generally recognize the survivor's need to be respected, informed, connected, and hopeful regarding their own recovery. Trauma survivors may need access to support groups either in the facility or in the community, if appropriate and feasible. Care planning to address cultural preferences. When a facility admits a resident, it has determined that it can provide the individualized care and services that resident requires. Facilities must create and sustain an environment that humanizes and promotes each resident's well-being and feeling of self-worth and self-esteem. This requires nursing home leadership to establish a culture that treats each resident with respect and dignity as an individual, and addresses, supports, and or enhances his or her feelings of self-worth, including personal control over choices and cultural preferences. It is important for facilities to be aware of the impact of culture and cultural preferences on the provision of care, and have an understanding of the cultural norms and practices of the individuals they care for. For example, in some cultures, it may be considered taboo to direct care at end of life. Or in other cultures, care must be provided by caregivers of the same sex as the resident. In order to provide culturally competent care, staff must understand the cultural preferences of the individual and how it impacts the delivery of care. A key component is identifying how to communicate with the resident in order to be able to identify physical concerns and issues, and for developing a trusting relationship with staff. For example, if the resident is non-English speaking or has limited understanding of English, the facility should identify how communication will occur with the resident. The care plan should identify the language spoken and what tools are available to communicate, whether it be with a communication board or other systems, or through translators. If communication systems are used, all staff interacting with the resident must know where those materials are kept, must understand how to use them, and consistently implement use of those methods. Staff must demonstrate proficiency in communicating with the resident to assure that critical information can be conveyed, such as a change in condition, the presence of pain, explanation of routine care, and the ability to refuse care and services. The facility must provide sufficient guidance for staff, including temporary staff, on how to communicate and deliver care for the resident. See also Section 483.10C1, Resident Rights, and Section 483.2, 1B3 Roman 3, Comprehensive Person-Centered Care Planning. There are many aspects of cultural preferences which may impact the delivery of care, such as food preparation and choices, clothing preferences such as covering hair or exposed skin, physical contact or provision of care by a person of the opposite sex, or cultural etiquette such as avoiding eye contact or not raising the voice. Additionally, facilities should consider offering activities that are culturally relevant to resident populations within the facility. Group activities with both sexes may not be permitted or appropriate in some cultures, or the type of programming may be in conflict with his or her cultural preferences. Providing reading materials, movies, newspapers in the resident's preferred language may help orient a resident to date, times, and events. Allowing the performance of religious rites at end of life to the extent possible, and certain medications, procedures, or treatments may be prohibited. Social services and facility administration may need to evaluate how forms, including informed consent forms, are provided in the language used by the resident. As mentioned above, this is a facility-wide opportunity to provide a culturally diverse environment, respecting and treating each resident with dignity. Assisting the resident and his or her representative with daily schedules, developed with input by the resident/representative, ahead of time may alleviate fear and frustration. Resident-specific approaches must be developed and included in the resident's care plan. These interventions must be provided consistently, and supervising staff should monitor the delivery of care and staff interactions with the resident to assure they are implemented as written. Using consistent staff, to the extent possible, will assist the resident in feeling more comfort in the facility. If concerns related to culturally competent and/or trauma-informed care planning are identified, see additional guidance at Section 483.21b in F656. Monitoring delivery of care and services. As required with any care plan interventions, facilities must monitor the effects of their approaches to ensure they are implemented as intended and are having the desired effect to achieve the measurable objectives and the residents' goals for care. For residents with a history of trauma in particular, facilities must evaluate whether the interventions have been able to mitigate or reduce the impact of identified triggers on the resident that may cause re-traumatization. It is critical to involve the resident and/or his or her family or representative in this evaluation to ensure clear and open discussion and better understand if interventions must be modified. It may be necessary to engage the services of an interpreter to monitor or evaluate the effect of cultural interventions for non-English speaking residents. As noted above, it is critical to involve the resident and/or his or her family in evaluating the effectiveness of cultural interventions in achieving measurable objectives and resident goals. Surveyors should refer to the following when investigating concerns and citing noncompliance related to culturally competent, trauma-informed care. F656, for concerns related to development or implementation of culturally competent and/or trauma-informed care plan interventions. F699, for concerns related to outcomes or potential outcomes to the resident related to culturally competent and/or trauma-informed care. F726, for concerns related to the knowledge, competencies, or skill sets of nursing staff to provide care or services that are culturally competent and trauma-informed. F742, for concerns related to treatment and services for resident with history of trauma and/or history of post-traumatic stress disorder (PTSD). Key elements of noncompliance. To cite deficient practice at F699, the surveyor's investigation will generally show that the facility failed to do any one of the following. Identify cultural preferences of residents who are trauma survivors. Identify a resident's past history of trauma and/or triggers which may cause traumatization. Consistently use approaches that are culturally competent and/or are trauma-informed. Investigative summary. Use the general critical element C pathway along with the above interpretive guideline when determining if the facility meets the requirements to provide culturally competent, trauma-informed care in accordance with professional standards of practice and accounting for residents' experiences and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of the resident. Deficiency categorization. An example of severity level 4 noncompliance Immediate jeopardy to resident health or safety includes, but is not limited to, a resident was admitted with a history of sexual abuse by a male and a diagnosis of post-traumatic stress disorder. The resident requested only female staff provide perineal care due to her severe trauma. A male staff person answered the resident's call light for assistance to the bathroom and insisted on performing perineal care as he was the only staff member available at the time. She refused his assistance and began to get visibly upset and requested that a female staff member be called in. The resident stated that the male staff member insisted on performing perineal hygiene after she had toileted despite the resident's past trauma. After returning her to her bed, she was crying and distraught and stated that she was afraid to request assistance with perineal care as he might return. She stated she cried all night and that she had profuse sweating, fearing that someone was outside her door, waiting to come in if she fell asleep. Eventually, the resident fell asleep but awakened screaming, kicking, and throwing objects, reliving her previous sexual assault. She told staff who came into her room that she was fearful for her life, felt dirty and demeaned, that she wasn't respected, and there was no reason to go on living. An example of severity level 3 noncompliance. Actual harm that is not immediate jeopardy includes, but is not limited to. Residents were gathered to watch July 4th fireworks on television. A resident with a known history of surviving a mass shooting several years ago was placed in the activity room to watch the fireworks. When the show began, the resident became tearful and frightened when he heard the sound of the fireworks, which resembled the sound of gunshots. The facility staff noticed that the resident was tearful and appeared frightened. When asked what was wrong, the resident shared that he was having flashbacks from the mass shooting he survived years ago. The staff member rubbed the resident's back and said it will be okay /////. The show is only 30 minutes long. The resident remained in the activity room for the duration of the fireworks and continued to be tearful. In the following weeks, the resident decreased his attendance at activities that he previously enjoyed. An example of severity level 2 noncompliance. No actual harm with potential for more than minimal harm that is not immediate jeopardy includes, but is not limited to. Facility staff escorted residents to a local baseball game. One of the residents was a survivor of a refugee camp and is not comfortable in highly populated areas. Prior to leaving for the game, facility staff failed to consider the resident's discomfort with crowded areas due to his time in a refugee camp. Upon arriving to the baseball game, there were hundreds of fans that came to watch the game. While watching the game, the resident informed one of the facility staff members that he was not enjoying himself because he was feeling anxious in the stadium with so many people around him and often has panic attacks when he is in crowded areas too long. The facility staff member immediately escorted the resident out of the stadium and onto the bus where his anxiety resolved. An example of severity level 1 noncompliance. No actual harm with potential for minimal harm. Because of the potential for psychosocial harm, noncompliance at F699 should generally not be cited at severity level 1. Lurie N., Young M., and Lavizo Murray R. 2005. Disparities and Quality Improvement, Federal Policy Levers. Health Affairs 24-354-364. 2 Betancourt, J.R., Green, A.R., Carrillo, J.E., and Park, E.R. 2005. Cultural Competence and Healthcare. Disparities, Key Perspectives and Trends. Health Affairs 24-499-505. Tag F700. Section 483.2, 5N bed rails. The facility must attempt to use appropriate alternatives prior to installing a side or bed rail. If a bed or side rail is used, the facility must ensure correct installation, use, and maintenance of bed rails, including but not limited to the following elements. Section 483.25N1. Assess the resident for risk of entrapment from bed rails prior to installation. Section 483.2, 5N2. Review the risks and benefits of bed rails with the resident or resident representative, and obtain informed consent prior to installation. Section 483.2, 5N3, ensure that the bed's dimensions are appropriate for the resident's size and weight. Section 483.2, 5N4, follow the manufacturer's recommendations and specifications for installing and maintaining bed rails. Intent Section 483.25N. The intent of this requirement is to ensure that prior to the installation or use of bed rails, the facility attempts to use alternatives. If the attempted alternatives were not adequate to meet the resident's needs, the resident is assessed for the use of bed rails, which includes a review of risks including entrapment. And informed consent is obtained from the resident or, if applicable, the resident representative. The facility must ensure the bed is appropriate for the resident and that bed rails are properly installed and maintained. Definitions Section 483.25N. Entrapment is an event in which a resident is caught, trapped, or entangled in the space in or about the bed rail. Bed rails are adjustable metal or rigid plastic bars that attach to the bed. They are available in a variety of types, shapes, and sizes ranging from full to 1/2, 1/4, or 1/8 lengths. Also, some bed rails are not designed as part of the bed by the manufacturer and may be installed on or used along the side of a bed. Examples of bed rails include, but are not limited to, side rails, bedside rails and safety rails, and grab bars and assist bars. Guidance Section 483.25N. Even when bed rails are properly designed to reduce the risk of entrapment or falls, are compatible with the bed and mattress, and are used appropriately, they can present a hazard to certain individuals, particularly to people with physical limitations or altered mental status, such as dementia or delirium. Resident assessment. After a facility has first attempted to use appropriate alternatives to bed rails and determined that these alternatives do not meet the resident's needs, the facility must assess the resident for the risks of entrapment and review possible risks and benefits of bed rails prior to installation or use. In determining whether to use bed rails to meet the needs of a resident, the following components of the resident assessment should be considered, including, but not limited to: medical diagnosis, conditions, symptoms, and or behavioral symptoms, size and weight, sleep habits, medication acute medical or surgical interventions, underlying medical conditions, existence of delirium, ability to toilet self safely, cognition, communication, mobility in and out of bed, and risk of falling. In addition, the resident assessment must include an evaluation of the alternatives that were attempted prior to the installation or use of a bed rail, and how these alternatives failed to meet the resident's assessed needs. The facility must also assess the resident's risk from using bed rails. The following includes examples of the potential risks with the use of bed rails, as identified by the Food and Drug Administration's Hospital Bed Safety Workgroup, Clinical Guidance for the Assessment and Implementation of Bed Rails in Hospitals, Long-Term Care Facilities, and Home Care Settings, April 2003. And that have been adapted for surveyor guidance. Accident hazards. The resident could attempt to climb over, around, between, or through the rails, or over the footboard. A resident or part of his or her body could be caught between rails, the openings of the rails, or between the bed rails and mattress. Barrier to residents from safely getting out of bed. A resident could crawl over rails and fall from greater heights, increasing the risk for serious injury. A resident could attempt to get out of bed over the footboard. Physical restraint. Hinders residents from independently getting out of bed, thereby confining them to their beds. Creates a barrier to performing routine activities, such as going to the bathroom or retrieving items in his or her room. Other potential negative physical outcomes. Decline in resident function, such as muscle functioning / balance. Skin integrity issues. Decline in other areas of activities of daily living, such as using the bathroom, continence, eating, hydration, walking, and mobility. Other potential negative psychosocial outcomes, creates an undignified self-image, and alter the resident's self-esteem. Contributes to feelings of isolation. Induces agitation or anxiety. These potential risks can be exacerbated by improper match of the bed rail to bed frame, improper installation and maintenance, and use with other devices or supports that remain when the bed rail is removed. Entrapment may occur when a resident is caught between the mattress and bed rail or in the bed rail itself. Although not all bed rails create a risk for entrapment, injury may still occur and is varied depending on the resident. Residents most at risk for entrapment are those who are frail or elderly, or those who have conditions such as agitation, delirium, confusion, pain, uncontrolled body movement, hypoxia, fecal impaction, acute urinary retention, etc. That may cause them to move about the bed or try to exit from the bed. The untimeliness of assistance, using the bathroom, and inappropriate positioning, or other care-related activities can contribute to the risk of entrapment. Informed consent. After appropriate alternatives have been attempted, and prior to installation, the facility must obtain informed consent from the resident or the resident representative for the use of bed rails. The facility should maintain evidence that it has provided sufficient information so that the resident or resident representative could make an informed decision. Information that the facility should provide to the resident or resident representative include, but are not limited to: what assessed medical needs would be addressed by the use of bed rails, the resident's benefits from the use of bed rails, and the likelihood of these. Benefits: the resident's risks from the use of bed rails and how these risks will be mitigated, and alternatives attempted that failed to meet the resident's needs, and alternatives considered but not attempted because they were considered to be inappropriate. The information should be presented to the resident or the resident representative so that it could be understood and that consent can be given voluntarily, free from coercion. Appropriate alternatives facilities must attempt to use appropriate alternatives prior to installing or using bed rails. CMS encourages facilities to refer to published information from recognized authorities, such as the Food and Drug Administration, which has identified the following alternatives to bed rail use. Alternatives include roll guards, foam bumpers, lowering the bed, and using concave mattresses that can help reduce rolling off the bed. This and more information may be found at https://www.fda.gov/medical devices/products and medical procedures/home health hand co-ensumer/consumer products/bed rail safety/UCM 362,843 HTM. This webpage was last updated in December 2017. See also Clinical Guidance for Assessment and Implementation of Bed Rails in Hospitals, Long-Term Care Facilities, and Home Care Settings. https://www.fda.gov/media/88765/download. Recommendations for healthcare providers about bed rails. https://www.fda.gov/medical devices/products and medical procedures/home health hand co-ensumer/consumer products/bed rail safety/UCM 362,848 HTM. Additionally, alternatives that are attempted should be appropriate for the resident, safe, and address the medical conditions, symptoms, or behavioral patterns for which a bed rail was considered. For example, a low bed or concave mattress may not be an appropriate alternative to enable movement in bed for a resident receiving therapy for hip replacement. If no appropriate alternative was identified, the medical record would have to include evidence of the following: purpose for which the bed rail was intended, and evidence that alternatives were tried and were not successful. Assessment of the resident, the bed, the mattress, and rail for entrapment risk, which would include ensuring bed dimensions are appropriate for resident size/weight, and risks and benefits were reviewed with the resident or resident representative, and informed consent was given before installation or use. Installation and maintenance of bed rails. Assuring the correct installation and maintenance of bed rails is an essential component in reducing the risk of injury resulting from entrapment or falls. The FDA and the United States Consumer Product Safety Commission, CPSC, has recommended the following initial and ongoing actions to prevent deaths and injuries from entrapment and slash or falls from bed rails. Before bed rails are installed, the facility should check with the manufacturers to make sure the bed rails, mattress, and bed frame are compatible, since most bed rails and mattresses are purchased separately from the bed frame. Note, the FDA has published the Hospital Bed System Dimensional and Assessment Guidance to reduce entrapment as a resource to reduce entrapments resulting from hospital beds and to practice hospital bed safety as to the proper dimensions and distance of various parts of the beds, i.e., distance between bed frames and mattresses, bed rails and mattresses, etc. Rails should be selected and placed to discourage climbing over rails, which could lead to falling over bed rails. When installing and using bed rails, the facility should ensure that the bed's dimensions are appropriate for the resident. Confirm that the bed rails to be installed are appropriate for the size and weight of the resident using the bed. Install bed rails using the manufacturer's instructions and specifications to ensure a proper fit. Inspect and regularly check the mattress and bed rails for areas of possible entrapment. Regardless of mattress width, length, and slash or depth, the bed frame, bed rail, and mattress should leave no gap wide enough to entrap a resident's head or body. Gaps can be created by movement or compression of the mattress, which may be caused by resident weight, resident movement, or bed position, or by using a specialty mattress, such as an air mattress, mattress pad, or waterbed. Check bed rails regularly to make sure they are still installed correctly, as rails may shift or loosen over time. In addition, ongoing precautions may include following manufacturer equipment, alerts, and recalls, and increasing resident supervision. The use of a specialty air-filled mattress or a therapeutic air-filled bed may also present an entrapment risk that is different from rail entrapment with a regular mattress. The high compressibility of an air-filled mattress compared to a regular conventional mattress requires appropriate precautions when used for a resident at risk for entrapment. An air-filled mattress compresses on the side to which a person moves, thus raising the center of the mattress and lowering the side. This may make it easier for a resident to slide off the mattress or against the rail. Mattress compression widens the space between the mattress and rail. When a resident is between the mattress and rail, the mattress can re-expand and press the chest, neck, or head against the rail. While using air therapy to prevent and treat pressure injuries, facilities should also take precautions to reduce the risk of entrapment. Precautions may include following manufacturer equipment alerts and increasing supervision. Facilities must also conduct routine preventive maintenance of beds and bed rails to ensure they meet current safety standards and are not in need of repair. CMS recognizes that there are many different types of beds, some with bed rails pre-installed or bed rails with the call button and lights incorporated into the rail, and others without bed rails pre-installed for which a separate rail could be installed. Facilities should have a process for determining whether beds, including mattresses and rails, are appropriate and safe for their residents. For beds with rails that are incorporated or pre-installed, the facility must determine whether or not disabling the bed rail poses a risk for the resident. Some considerations would include, but are not limited to, the following. Could the rail simply be moved to the down position and tucked under the bed frame? When in the down position, does it pose a tripping or entrapment hazard? Would it have to be physically removed to eliminate a tripping or entrapment hazard? Facilities should follow manufacturers' recommendations/instructions regarding disabling or tying rails down. CMS regulations do not specify that bed rails must be removed or disabled when not in use. However, if bed rails are not appropriate for the resident and the facility chooses to keep the bed rail on the bed, but in the down position, raising the rail even for episodic use during care would be considered noncompliance if all of the requirements assessment, informed consent, appropriateness of bed, and inspection and maintenance are not met prior to the episodic bedrail use for the resident. Ongoing monitoring and supervision, assuring the correct use of an installed bed rail and maintenance of bed rails, is an essential component in reducing the risk of injury. After the installation of bed rails, it is expected that the facility will continue to provide necessary treatment and care to the resident in accordance with professional standards of practice and the resident's choices. This should be evidenced in the resident's records, including their care plan, including, but not limited to, the following information: the type of specific direct monitoring and supervision provided during the use of the bed rails, including documentation of the monitoring, the identification of how needs will be met during use of the bed rails, such as for repositioning, hydration, meals, use of the bathroom and hygiene. Ongoing assessment to assure that the bed rail is used to meet the resident's needs. Ongoing evaluation of risks, the identification of who may determine when the bed rail will be discontinued, and the identification and interventions to address any residual effects of the bed rail, e.g., generalized weakness, skin breakdown. Key elements of noncompliance section 483.25N. To cite deficient practice at F700, the surveyor's investigation will generally show that the facility failed to do one or more of the following: identify and use appropriate alternatives prior to installing or using a side or bed rail. Assess the resident for risk of entrapment prior to installing or using a bed rail. Assess the risk versus benefits of using a bed rail and review them with the resident or the resident's representative. Obtain informed consent for the installation and use of bed rails prior to use. Ensure appropriate dimensions of the bed based on the resident's size and weight. Ensure correct installation of bed rails, including adherence to manufacturers recommendations and or specifications. Ensure correct use of an installed bed or side rail, and ensure scheduled maintenance of any bed rail in use according to the manufacturer's recommendations and specifications. Note: if a facility is unable to identify the manufacturer and access the manufacturer information and guidance for bed rails that they use, they would not meet requirements to follow the manufacturer's recommendations and specifications for installing and maintaining bed rails at 483.25N4. Investigative Protocol Section 483.25N. Use this protocol for a sampled resident who has MDS data that indicates a bed/side rail is used. Surveyor observation of the use of a bed/side rail for a resident, and or an allegation of inappropriate use of a bed/side rail received by the state survey agency. Procedures Section 483.25N. Briefly review the assessment, care plan, and orders of the resident to identify facility interventions and to guide observations to be made. Corroborate observations by interview and record review. Observation resident during observations of a resident who has bed/side rails. Determine what type of bed rail is installed or used, and for how long the bed rail has been in use. If the bed rail in good working order, frequency of use of the bed rail, any physical or psychosocial reaction to the bed rail, such as attempts to release/remove the bed rail, verbalizing anger/anxiety, who raises and lowers the bed rail and how often monitoring is provided, how the resident is positioned in the bed relative to the bed rails, and how the Resident moves in bed. How the resident requests staff assistance, e.g., access to the call light, whether the resident is toileted, ambulated, or provided exercises or range of. Motion when the bed rails are released. Who released the bed rails and for how long? Note, a resident may have a device in place that the facility has stated can be removed by the resident. For safety reasons, do not request that the resident remove the bed rails, but rather request that staff ask the resident to demonstrate how he/she releases the bed rails. Interview resident or resident representative. Interview the resident, or if applicable, the resident representative, to the degree possible to identify who requested the bed rail to be installed or used prior to the use of the bed rail, whether staff provided information regarding how the bed rail would address a resident need, the risks and benefits and alternatives to bed rails, when and how long the bed rails were going to be used, whether the interdisciplinary team provided interventions for monitoring and release of the bed rails for activities, such as use of the bathroom, walking, and range of motion. Whether staff discussed mobility issues with the resident or resident's representative when the bed rail is in use and/or other impacts on activities of daily living and involvement in activities, and how the resident can request staff assistance when the bed rail is in use. Interview staff, interview direct care, and licensed nursing staff on various shifts who provide care to the resident to determine knowledge of specific interventions related to the use of the bed rails for the resident, including when use of the bed rail was initiated, the rationale for selecting the bed rail for use, identifying the benefits and risks of using the bed rail. What is the resident's functional ability, such as bed mobility and ability to transfer between positions, to and from bed or chair, to toilet, and to ability to stand? Whether there have been any physical and/or psychosocial changes related to the use of the bed rail, such as increased incontinence, decline in ADLs or ROM, increased confusion, agitation, and depression. Whether other interventions have been attempted to minimize or eliminate the use of the bed rails, and whether there are facility guidelines/protocols for the use of bed rails. Interview the charge nurse to gather the following additional information: how the implementation of the use of bed rails is monitored and who is responsible for the monitoring, who evaluates and assesses the resident to determine the ongoing need for bed rails, whether bed rail use should be gradually decreased, and how the modifications for the interventions are evaluated for effectiveness in discontinuing the use of the bed rails. Record review. Review the MDS, assessments, physician orders, therapy and nursing notes, and other progress notes that may have assessment information related to use of the bed rail. Determine whether identified decline can be attributed to a disease progression or use of bed rails. Determine whether the assessment information accurately and comprehensively reflects the status of the resident for the identification of specific medical symptoms for which the bed rail is used, functional ability, including strength and balance such as bed mobility and ability to transfer between positions, to and from bed or chair, and to stand, and the ability to toilet. Identification of the resident's risks such as physical/functional decline and psychosocial changes, and benefits, if any, due to the use of the bed rails. Attempts at using alternatives to bed rails, including how the alternatives did not meet the resident's medical or safety need or were inappropriate. Identification of any injuries or potential injuries that occurred during the use of bed rails. When the interdisciplinary team has determined that a resident may benefit from the use of a device for mobility or transfer, whether the assessment includes a review of the resident's bed mobility and ability to transfer between positions, to and from bed or chair, to stand, and the ability to toilet. Review the resident's care plan to determine if it is consistent with the resident's specific conditions, risks, needs, behaviors, preferences, current professional standards of practice, and included measurable objectives and timetables, with specific interventions/services for use of the bed rail. The care plan may include which medical need would be met through the use of bed rails, how often the bed rail is applied, duration of use, and the circumstances for when it is to be used, how monitoring is provided, and when and how often the bed rail is to be released, and assistance provided for use of the bathroom, walking, and range of motion. What the resident's functional ability is, such as bed mobility and ability to transfer between positions, to and from bed or chair, and to stand and toilet and staff required for each function that requires assistance. Identification of interventions to address any potential complications such as physical and/or psychosocial changes related to the use of the bed rails, such as increased incontinence, decline in ADLs or ROM, increased confusion, agitation, and depression. Identification of interventions to minimize or eliminate the use of the bed rails, and who monitors for the implementation of the use of the bed rails, and who evaluates and assesses the resident to determine the ongoing need for bed rails, whether the bed rail use should be gradually decreased, and how the modifications for the interventions are evaluated for effectiveness in discontinuing the use of the bed rail. Deficiency Categorization Section 483.2, 5N. Examples of severity level 4 noncompliance immediate jeopardy to resident health or safety include, but are not limited to: a facility failed to attempt to use alternatives to bed rails and assess a resident for risk of entrapment. The resident was assessed to be at risk of falls when she made repeated attempts to self-transfer off of her bed. All of the falls occurred when a half-side rail was in use. According to a facility accident report, the resident was found on the floor with her back against the bed, holding onto one of the half-side rails with both hands, with her neck wedged between the half-side rails. The resident was able to remove herself from between the mattress and the bed rail and did not sustain any injuries from the fall. After this incident, the facility performed a bed rail assessment, which did not indicate the risks/benefits of using bed rails. However, no changes were made to the resident's care plan, nor was there any documentation that the facility considered discontinuing use of the bed rails. 9 months later, the resident was found dead on the floor next to her bed, with her head wedged between the half-side rail and the mattress. The resident's death certificate listed the cause to be asphyxiation positional, extrinsic compression of the neck, and neck trapped under the bed rail. The facility failed to assess the resident for use of a bed rail, and failed to ensure that the bed rails did not pose a risk of entrapment or injury from falls. A moderately cognitively impaired resident was admitted to the facility who required extensive assistance with bed mobility and transfer, and was not ambulatory. The nursing assessment completed on admission indicated that the resident was at high risk for falls, and full bed rails were used on all open sides of the bed. No assessment related to the use of bed rails was completed. A facility investigation report revealed that the resident crawled to the foot of his bed with the full bed rails in a raised position, tried to stand and ambulate, and fell off the right side of the bed. The resident sustained a femoral neck fracture and was hospitalized. A facility failed to attempt to use alternatives to bed rails and assess a resident for risk of entrapment. A bed rail assessment indicated that 2 half-side rails would be used for the resident to promote independence. There was no evidence that the facility evaluated risks associated with bed rail use when the facility changed the bed mattress to an air mattress. A facility accident report indicated that a nurse aide discovered the resident on the floor, with his or her head positioned between the side rail and the air mattress. The resident had visible bruising to the neck, had no pulse or blood pressure. Examples of severity level 3 noncompliance actual harm that is not immediate jeopardy include, but are not limited to: an example of noncompliance that demonstrates severity at level 3 includes, but is not limited to: A facility failed to ensure the resident's bed dimensions were appropriate for the resident's size and weight. An extremely obese resident fell out of bed and sustained an injury while using the bed rail as an enabler to turn on his side. The bed was narrow, and the bed rail could not sustain his weight and broke. The bed was meant to sustain the size and weight of a smaller person per manufacturer's directions. Example of severity level 2, noncompliance, no actual harm with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to. An example of noncompliance that demonstrates severity at level 2 includes, but is not limited to. The facility failed to inform a resident/representative of the risks and benefits of using side rails prior to installing or using them on the resident's bed. The resident was cognitively impaired and was unable to comprehend. However, the staff did not contact the resident's representative to provide the information. Examples of severity level 1 noncompliance, no actual harm with potential for minimal harm include, but are not limited to. Facility failed to have a schedule for routine maintenance of its 4 beds with bed rails, which were newly installed 2 years ago. There is no evidence of incidents or injuries in those 2 years. The relevant resident care plans appear appropriate regarding bed rail usage, and the facility provides evidence of checks by staff on the impacted residents and appropriate use and installation of bed rails. Note: references to non-CMS/HHS sources or sites on the Internet included above or later in this document are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services. CMS is not responsible for the content of pages found at these sites. URL addresses were current as of the date of this publication. Other resources which may be useful: Falls National Council on Aging National Falls Prevention Resource Center at https://ncoa.org/professionals/health/ Center for Healthy Aging / National Falls Prevention Resource Center. Centers for Disease Control and Prevention at https://www.cdc.gov/falls/index.html. CDC AA ref val equals https://3 A%2 F%2 FWWWCDC V%2 F Home and Recreational Safety %2 F Falls %2 Findex HTML. World Health Organization Fall Prevention in Older Age at https://www.publications/9,789,941,563,536. National Institute of Health Senior Health at https://www.neonigov/health/topics/falls and falls prevention. Wandering and Elopement Resources, U.S. Department of Veterans Affairs VHA National Center for Patient Safety at https://patientsafety.gov/a toolkit patients at risk for wandering ASP. This concludes the reading of Appendix PP. Regulation Section 483.25, tags F684 through F700.